साइन इन नहीं देते हैं ना हमारे बॉस, यही तो दिक्कत है। नहीं देते हैं ना, यही
Hello, check. Hello, 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 check. Check one test. Hello, 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 check. Check one. Hello, hello. सही है लेवल? वो मिला नहीं क्या अभी आईडी? आईडी लेके ओपन तो करा लो.
1500 प्रीलोडेड गानों वाला कीपैड धमाकेदार
Hello, check.
Hello, mic check. Hello, hello. Good afternoon, ladies and gentlemen. We'll be starting our session shortly. I request you all to please take your seats. We will be starting our first session shortly, so I request all the dignitaries to please take their seats. Ladies and gentlemen, distinguished guests and esteemed colleagues, Namaskar and a very warm welcome to the CME on acute kidney injury, past, present, and future, and Foundation Day celebration organized by the Department of Nephrology, SGPGIMS, Lucknow. I, Dr. Ankita Pandey, on behalf of Professor Dr. Narayan Prasad and the Department of Nephrology, SGPGIMS Lucknow, welcome you all today as we embark on the journey of knowledge exchange, collaboration, and innovation in the field of medical science. Throughout our sessions, workshops, and panel discussions, we aim to explore innovative solutions, best practices, and emerging trends that align with this theme. Let's delve into the enriching sessions lined up for the day. Session 1 is on thrombotic microangiopathy. Ladies and gentlemen, it is now time to start our first session, and who better to lead us than the brilliant chairpersons. Please join me in welcoming them to the stage to begin the session. I invite on stage Dr. Ratan Jha, consultant nephrologist from Hyderabad. Welcome, sir. Please welcome with a round of applause. Thank you. Dr. Praveen Kumar Rai, consultant nephrologist from Varanasi. Welcome, sir. Dr. Manoj Jain, professor pathology, SGPGIMS Lucknow, and Dr. Kara Langlin from Chandigarh. So the stage is all set, but before that, I have a few quick announcements. Speakers are requested to please keep up with the time, and the discussion will be taken at the end of the session. With this, I turn the time over to the chairpersons. Thank you.
Good afternoon, everyone. We welcome you to the post-lunch session on a common theme topic of thrombotic microangiopathy. To begin, I request Dr. Sana Mohishin, Senior Resident Department of Nephrology, SGPGI Lucknow, to present a case of relevance of thrombotic angiopathy or a differential diagnosis of thrombotic microangiopathy. Dr. Sana Mohishin, please.
Thank you, sir. Good morning, everyone. Today, I'll be presenting my case. She's an 11-year-old female born of a non-consanguineous marriage, full-term LSCS birth with no significant perinatal issues. She had average school performance with no known comorbidities. She had a history of fever and sore throat for 2 to 3 days, 1 month back, followed by abdominal pain for 15 days, vomiting for 15 days, which was followed by gross hematuria for 4 to 5 days, after which she presented to SGPGI. She had no history of any yellowish discoloration of eyes or urine, any diarrheal illness, any headache, focal neurological deficits or seizures, any history of impetigo, skin infection, any skin rash, joint pain, oral ulcers, photosensitivity or myalgias. There was no history of any drug intake before the onset of symptoms or any drug allergies. She had no history of any decreased urine output or pedal edema at presentation. On examination, she was conscious, oriented to time, place, and person. Her height and weight were within 50th to 75th centile. Her blood pressures were slightly raised. They were 132 by 98, which was above the 95th centile. She had pallor present, and rest of the general and systemic examination was within normal limits. So this is the brief overview of what happened to our patient outside our hospital. She had the symptom onset, followed by being treated conservatively with IV antibiotics, antiemetics, and PPIs, and then she presented to SGPGI. Her outside investigations revealed that she had anemia with thrombocytopenia with hemoglobin of 9.0 and a platelet count of 45,000. She had a creatinine level of 5.1 and her urine showed 3+ of protein and 40 to 60 RBCs. Her tropical fever workup was all negative. Initial labs in SGPGI revealed that on 14th of March, she had a hemoglobin of 9.6 and platelet of 45,000 with an elevated retic count of 11%, schistocytes of 8% on peripheral blood smear, and an LDH of more than 5,000, pointing to a diagnosis of hemolytic anemia. She had creatinine levels of 4.49. Her urine showed 2+ of protein and 10 to 15 RBCs. Her serum albumin was 3.09, and her USG showed bilateral normal sized kidneys. Autoimmune workup revealed that ANA was 1+, fine speckled. C3 was low, which was 47, and C4 was normal, which was 25.4. DCT and ICT were negative, and ASO titers were less than 200. So we found that we were dealing with a case of non-immune intravascular hemolytic anemia with thrombocytopenia with schistocytes, pointing to a diagnosis of fragmentation syndrome. But our case showed no features of any CNS involvement, any drug intake, any prosthetic heart valves. She had no history of suggestive of sepsis or DIC. She had no history of any diarrheal illness preceding the symptoms. Rather, she had features of renal involvement with hypocomplementemia in the form of low C3. That pointed to a diagnosis of atypical HUS. So we further investigated our case and found that ADAM-TS13 levels were normal, and her anti-complement factor HSA was raised, which was 521. Further on genetic analysis, she was found to have homozygous deletion of complement factor H regulatory protein 3 and 1. So as of now, we were having a syndromic diagnosis of RPRF and etiological diagnosis of atypical HUS, which was anti-CFH positive and also had mutations for complement factor regulatory proteins 3 and 1 with a pathological diagnosis of TMA. So this is the brief overview of what has happened with the patient during the hospitalization in SGPGI. Once being investigated thoroughly and being diagnosed with atypical HUS, she was given immunosuppression in the form of prednisolone and mycophenolate mofetil. Over the course, she had received 14 cycles of Plex and 4 doses of eculizumab. So these are the trends. As we can see that the patient had anemia, thrombocytopenia with elevated schistocyte and retic count and LDH. Over the course, she was given 5 cycles of Plex, but her platelet counts were still falling and reached an adder of 30K. And then she was given first dose of eculizumab on 27th of March 2024. Even after that, her creatinine levels were stuck between 4 to 5, and her urine output showed a progressively falling trend up to 600. So she was given a second dose of eculizumab on 5th of April 2024. Following this, by 8th of April, she had a falling urine output with only 350 ml urine in 24 hours with features of volume overload. So she required the 7th session of Plex along with hemodialysis on 8th of April. In view of non-recovering renal function and suspected acute cortical necrosis, we did a kidney biopsy on 10th of April 2024. We received 2 linear cores which comprised of 23 glomeruli, one of which was globally sclerosed. Few of the glomeruli displayed bloodless capillary loops with fibrillary and foamy appearance, as can be seen here also. Few glomeruli also showed splitting, as marked by the red arrow of the glomerular capillary walls, which was prominent under the silver stain. Tubules showed mild acute tubular injury in the form of dilation and loss of brush-bordered epithelium, as is marked by the black arrow here. There was mild lymphomononuclear inflammatory infiltrates in the interstitium, and blood vessels showed occluded lumen with fragmented red blood cells in occasional vessels. Thickening of vessel wall was also seen along with myxoid degeneration. As here it is marked, the glomerulus is showing the fibrin thrombi and fragmented RBCs in the glomerular capillary lumens. This is the electron microscopy of the same patient, showing patent capillary loops although, but there was subendothelial widening as marked by the blue arrow with increased mesangial cellularity as marked by the star. Capillary loops showed obliteration by subendothelial widening, although the podocytes were unremarkable. So her immunofluorescence showed no immune deposits for IgG, IgM, IgA, C3, C1q, kappa, or lambda. So her native kidney biopsy was reported as suggestive of thrombotic microangiopathy with no evidence of any cortical necrosis. In view of this, her Plex was intensified and she received further courses of Plex over the following days, with a third dose of eculizumab being given on 12th of April. Even after that, on 21st of April, the patient had accelerated hypertension with seizures, visual symptoms, blurring in the form of blurring and flashes, with likely due to press. And she had features of volume overload requiring hemodialysis and few sessions of ISO-UF. So 13th and 14th session of Plex were done, but the platelet counts started to fall. In view of suspected hematological relapse, the Plex sessions were given. Later, her anti-CFH levels came out to be normal, so Plex was withheld, and the patient was given the 4th dose of eculizumab on 29th of April in view of non-recovering renal function and low platelet counts. After which, the platelet counts have shown recovery, and the urine output has also improved to more than 1 liter in 24 hours. So, as of now, the patient is in hematological remission with blood pressure controlled on antihypertensive drugs, seizures controlled on anti-epileptic drugs, and a stable creatinine, and she is dialysis independent. So this is our experience with patients with atypical HUS in SGPGI over the last 5 years. We had 73 patients, out of which 57 fulfilled the criteria for inclusion in the study. And out of them, 42 were treatment responders and 15 were treatment non-responders. So this is comparative data. The point to be highlighted is anti-CFH positivity was seen more associated with the subgroup of responders rather than non-responders. These are the biopsy parameters. Most of them showed no significant difference, but it was seen that patients who were non-responders showed moderate IFTA as compared to those who were responders showing only mild IFTA. This is a survival curve comparison showing that patients who were anti-CFH positive had better dialysis-free renal survival, and patients who were responders also showed better survival. So overall, in our study, we found that the factors predicting poor outcomes in atypical HUS are as follows. Age more than 18 years, female gender, and the presence of seizures were predictive of poor outcomes. Although anti-CFH positivity was not associated with any significant difference, but it was seen that anti-CFH titers of more than 4,000 had 18 times more risk of having a poor outcome. Thank you.
Are there any questions from the? So we won't go with the question now, and we'll be calling the next speaker, Dr. Raja Ramachandran from PGI. He is actually an excellent orator, a very good clinician, and a wonderful person. So without much ado, please, sir.
Thank you, Kara. At the outset, I would like to thank Mr. Narayan Prasad for inviting me to speak on the topic. Before I go to the pertinent questions in thrombotic microangiopathy, what thrombotic microangiopathy is important. Kidney failure or kidney injury is sine qua non for the presence of thrombotic microangiopathy. So for the diagnosis of thrombotic microangiopathy with or without microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is intravascular hemolytic anemia along with thrombocytopenia. Intravascular hemolytic anemia is diagnosed by the presence of fragmented RBCs, or what you call schistozoids, on peripheral smear examination, increased LDH levels, and low haptoglobin levels. Many a times we do not have all the three investigations, so you could use either two of them to make the diagnosis of microangiopathic hemolytic anemia. What are the questions pertinent to the topic? The first one is the current classification, a comprehensive classification for thrombotic microangiopathy. Two, what is the role of alternate complement cascade in health and disease and in thrombotic microangiopathy? The third, what are the genetic or the functional abnormalities in a patients with thrombotic microangiopathy? The four, what is the role of autoantibodies in the pathophysiology and diagnosis of thrombotic microangiopathy? You all would have seen reports of CFHR deletion or duplication. What is the role of CFHRs in the diagnosis and pathogenesis of thrombotic microangiopathy? Last but not least, you all seen patients with IgA nephropathy, patients with C3 glomerulopathy, or other glomerular disease with thrombotic microangiopathy. What is the significance of this? Is there a complement dysregulation in these patients? And then what is the role of alternate pathway dysregulation in patients with malignant hypertension? So before we go on to the classification part, there are many limitations to thrombotic microangiopathic diagnosis. The first among them is lack of awareness. What the mind does not know, the eyes don't see. So if you do not know microangiopathic hemolytic anemia, you are less likely to evaluate for the same. Non-availability of investigation is a real issue. Most of the folks sitting here have an easy accessibility to haptoglobin and LDH levels or a peripheral smear examination, but they can be constraints in limited resource setting. Even in abundant resource setting, peripheral smear examination is very poorly done because most of the time the technician or the resident will have to see 100 smears, and if you do not provide them with adequate data, they are likely to miss them or not see properly. The third one is delayed presentation to nephrologist. Many a times the microangiopathic is transient phenomenon, especially in patients with pregnancy-related HUS, where the thrombotic microangiopathy is very transient unless you carefully look into it. The fourth one is reluctant to biopsy a patient of acute kidney injury or carry out a contrast CT in someone who we suspect a cortical necrosis, which is nothing but an extreme form of thrombotic microangiopathy. The current classification of thrombotic microangiopathy is largely as primary and secondary. Primary thrombotic thrombocytopenic purpura, complement-mediated thrombotic microangiopathy, and STEC-HUS. And secondary, you have drugs, malignancy, transplant-related bone marrow, and kidney transplant-related. So what are the limitations to the current classification? First is on the pathogenesis. We have moved from a pattern-based classification to a pathogenesis-based classification. The classical examples are membranoproliferative glomerulonephritis, where we classify them as immune complex or as C3 glomerulopathy. Membranous nephropathy, where we have graduated to a molecular typing, where we classify them as PLA2R, NEL, and even NEL, you know, it's complementary medicine related or malignancy related, semaphorins and exostosins for autoimmune related membranous nephropathy. Similarly, the classification of thrombotic microangiopathy does not reflect the pathogenesis like it should. Second one, the complement is the elephant in the room, and that the classification does not reflect the same. Like you have C3 glomerulopathy, but in the TMA classification, the role of complement is not reflected. Third, triggers. So maybe 1/4 of the patients sitting in this hall may have a genetic predisposition to develop thrombotic microangiopathy, and the triggers are the more critical ones, like, you know, hemorrhage, infection, pregnancy, you know, some kind of surgical stress. So the triggers are critical, and classification should reflect them because they are very important in the pathophysiology of the disease. Then there is emerging anti-complement therapy. Outside eculizumab, there are at least 3 anti-complement therapies which are being evaluated, 2 at least in India, iptacopan and other C5e inhibitor. So I think the response to them also should be reflected in the diagnosis. This part may not be very relevant to Indian population as of now, but I think in the future is bright, and this should reflect upon in the classification. Coming to pathology of the TMA, I think my predecessor did a wonderful job by showing all of them in a single patient. The TMA is not a single diagnosis, but it's a spectrum. It moves from endothelial swelling or endotheliosis till renal cortical necrosis. So endothelial swelling is nothing but swelling of the endothelial cells. Most common cause of endothelial swelling, you all know, is preeclampsia. Preeclampsia is a disease of the endothelium, and then becomes, if it is very severe, it becomes a disease of the podocyte. Second, mesangiolisis. Mesangiolisis, there is lysis of the mesangium. Again, most commonly seen in patients with snake bites. Then the third one is presence of fibrin thrombi, subendothelial widening, which you can see in the 4th figure towards your right. And then you have fibrinoid necrosis in the form of fibrin and subendothelial swelling, and the bloodless glomeruli, or what one may call as glomerular paralysis. That is just a step prior to renal cortical necrosis. So coming to the next question is the role of the alternate complement pathway in health and disease. There are at least 3 pathways: classical pathway, lectin pathway, and alternate complement cascade. The classical pathway and the lectin pathway are only activated if there is a presence of immune complex or any infection or presence of any liposaccharides, whereas the alternate pathway of the complement cascade is always activated. It is in a state of activation. It's also called tick-off. The C3 is a very unstable molecule, undergoes spontaneous hydrolysis, resulting in the formation of C3H2O. Factor B in the presence of propyridine is broken down to BB and BA. The hydrolytic C3 along with factor BB results in the formation of C3H2O BB, which is also known as C3 convertase in the fluid space, which is unstable. What the unstable C3 convertase does is it breaks down the C3 again into C3A and C3B. The C3B along with BB results in the formation of a stable C3 convertase. The stable C3 convertase along with BB results in the formation of C5 convertase. I'm not going to pronounce that because it's a very inconvenient pronunciation. So what the C5 convertase does is it breaks down the C5 into C5A and C5B, and C5B translocates to the surface of the cells. C5A along with C6 to 8 results in the formation of C5b8, which polymerizes C9 on the surface, resulting in the formation of C5b9, which is also known as membrane attack complex. The membrane attack complex is not a molecule, but it's just a channel which is formed in the surface of the cell. This channel is open and there is free flow of electrolytes irrespective of the gradient, resulting in hemolysis or lysis of the cell. So this is how a pathogen is being destroyed. But this can happen to even a normal cell, and that can be suicidal. So how is that regulated? Here comes the role of complement factor H. So the complement factor H is a glycoprotein which has 20 short consensus repeat. That is, each short consensus repeat consists of about 60 amino acids. The one towards your left is the amino terminal and one towards your right is the carboxy terminal. The carboxy terminal of the complement factor H actually binds to the surface. That is why when you have a deficiency or an anomaly at the carboxy terminal end, you have thrombotic microangiopathy, because thrombotic microangiopathy is a disease of endothelium. Whereas if you have defects in the amino terminal end, which actually binds to the plasma C3b, you have C3 glomerulopathy and other related disease. Although it's not mathematics, it's more of a biology. So you could have vice versa also, but that's an exception. So what the factor H does is, the factor H actually binds to the C3b and prevents binding of other C3b to a single C3b which is attached to the surface, thus inhibiting the formation of the C3 convertase. Also, the complement factor H acts as a complement, as a cofactor for complement factor I. What complement factor I does is it prevents the joining of C3b and BB. Hence, there is no formation of C3 convertase. So this is what is being inhibited by complement factor H. So next is, what are the genes which are implicated in thrombotic microangiopathy? You have complement related genes and non-complement genes. Among the complement related genes, you could have a gain of function mutations. A gain of function mutations is with complement C3 or factor B. Loss of function is its complement factor H, complement factor I, membrane cofactor protein, and the CFHRs. Among the non-complement, DGKE is results in thrombotic microangiopathy in neonates and infants. It is non-complement related. It activates the coagulation cascade and VEGF inhibition, resulting in thrombotic microangiopathy. We had TREX1 related thrombotic microangiopathy recently reported. It is usually causes retinal vasculopathy and cerebral TMA, but it's also repeated recently with renal TMAs, and most of the time they are limited to the kidneys. Thrombospondylin role is highly debatable. There was a publication in 2009 in New England Journal. To cut the long story short, it is an amazing biology and a poor genetics. What they found was thrombospondylin is also found in normal population. Coming to the evidence on what is the percentage of patients with TMA with complement genetic defects, about 2/3, 60 to 70% of the patients with TMA have genetic defects. The most common among them is mutations or aberrations or variations in the complement factor H, followed by membrane cofactor protein, C3, and complement factor I. Most of the data on thrombotic microangiopathy is from Europe, so much so that Americans believe that it's only a disease of the Europe till eculizumab was available. So there's another study. The first one is from Paris. The second one is from Italy, where 16% of the patients had mutations in complement factor H, 7% with membrane cofactor protein, and C3 and CFI, and 4 and 3% respectively. Coming to another interesting, which the case was just present, the role of autoantibodies in complement-mediated thrombotic microangiopathy. We all now know the structure of the complement factor H. So you can develop, or autoantibodies to complement factor H is the most common cause of HUS or complement-mediated thrombotic microangiopathy in children. So about 55% of the Indian children with complement-mediated HUS or TMA have anti-CFH antibodies. most of the anti-CFH antibodies, that is 93 to 100% of them, are towards the short consensus repeat 18, 19, and 20. That is 93 to 100% of them are towards the carboxy terminal end. That is why you develop HUS. And most of these antibodies are IgG3 in nature. Coming to the C3 glomerulopathy, 52% of them have autoantibodies towards the amino terminal end, and 47% or 48% have autoantibodies towards the carboxy terminal end. And as shown in the previous case, CFHR1 and 3 deletion is associated with complement factor H autoantibody associated TME. The exact mechanism why these mutations result, or these variations or deletions result in thrombotic on production of anti-CFH antibody remains unknown. There are also reports which have gone on to show that these deletions are also associated CFI antibodies. Patients with anti-CFH antibodies have predisposing features like respiratory tract infection or diarrhea in 7 to 10% of them. Another antibody is anti-complementar anti-complement I antibodies, which is seen in 33% of patients with complement-mediated TMA. This was reported by Dr. Kara herself. And most of these patients are tiny. If I remember, they were all less than a year. The median age was 10 months. And many of these patients have nephrotic range proteinuria. Coming to the mechanism of D plus HUS, its most common cause of TMA less than 10 years of age associated with E. coli O157H7 or Shigella dysentery. It is because of the Shiga toxin 2 binding to GB3 receptors on the endothelium and activating the complement cascade, activating the coagulation cascade. And another important aspect is an emerging evidence that this may be complement related. If you see, the plasma of these patients is rich in complement factor B and membrane attack complex. And also there is a deposition of C3 and C5b9 in the kidney biopsy of these patients. There was a recent randomized trial which evaluated eculizumab versus supportive care in 100 of these patients. What they found was the primary outcome of RRT requirement was no different between both the groups, although numerically better in the eculizumab group, but presence of urinary abnormalities or chronic kidney disease was better with eculizumab as compared to the control, and the difference was statistically significant. So the bottom line is in D plus HUS, there are functional abnormalities, but there are no genetic abnormalities to suggest complement activations. So what are the tests that you will do? I'm sure that my successor will speak about these. So genetic testing, what the KDIGO, I just attended the KDIGO meeting being a member, and what was decided was to do a whole exome sequencing, targeting only the complement genes. If it is negative, they would evaluate outside the complement genes, or you could do a targeted sequencing of complement factor 3, C3, B, CFH, CFI, and the CFHRs, and you do a multiplex ligation probe amplification to see for copy number variation. There is duplication or deletion of CFH and CFHR 135. So next is coming to the functional testing. Functional testing is important. So there's a laundry list of tests, but what I believe is what are important is you either do alternate pathway functional assay or AH50. C3, C4 I think is freely available. Because then you do C5b9 assessment, which has got a therapeutic implication. If a patient is on eculizumab and having a non-CFH related TMA, you can also withdraw eculizumab if the patient is in stable remission and for presence of autoantibodies against CFH and CFI. So what are the things that one need to be mindful of? There are at least 3 lessons that I learned. One is the complement proteins are highly unstable and you need to immediately put them on the ice. If you keep them on an ambient temperature, there will be activation of complement and very high levels of C5b9. We lost close to 100 samples this way. The second thing is ADAM-TS is very important. You start your workup with ADAM-TS testing. I didn't focus because that's largely a domain of the hematologist. And we had a patient who was on a clinical trial. We found the lab from the country showed normal levels, and finally, when the results came from an internationally validated lab, the patient actually had TTB. The patient had CNS manifestations along with kidney injury. So it was a case of TTB. The third one is genetic testing is very important. You need to be very careful when you do genetic testing. There's a competition. So people are likely to cut corners because they want to get as cheap as possible. So we had 2/3 of the patients with pregnancy associated HUS showing duplication CFHR 1 and 3. Many of these patients were planned for transplant. So we actually sent these samples to David Kavanga for validation because it was surprising to us. And what we found was none of the reports were validated. They were all wrong reports. It was probably the control that the company was using probably had only one strand, and all the duplication, all the normal were shown as duplications. So you need to be careful. You need to have an access to the raw data of these patients. Coming to the last part is the significance of CFHRs. CFHR is very common in normal population. There was a publication in PLOS One, which actually, I'll take 2 minutes more. So there's a publication in PLOS One which actually evaluated the role of CFHR in population. What they found, which also had a Gujarati Indian population, and they found that 38% of the population were positive actually for CFHR deletion homozygous or heterozygous being more commoner than the homozygous. And there was a study by Dragon Dury in 2009 where she reported the frequency of CFHR deletion homozygous was commoner in patients with HUS. However, when anti-CFH and anti-CFI related HUS were expunged, they found that there was no difference. So the role of CFHR deletion is largely debatable, but I wouldn't stop there. I think we should look at the functional abnormalities. There may be a novel finding. There are at least 3 reports that I have seen. One is CFHR deletion in patients with pregnancy-associated TMA, which was reported from Pune by Dr. Valentin Lobo. Another case of HUS, which was a hybrid between CFH and CFHR1, which caused TMA from Pune, and the similar one caused familial C3 glomerulopathy in a family which is under our follow-up now. So the last part is about the secondary TMA. I'm running over time. So, this is a study which evaluated up 300 patients, half of them with AHUS or TTP, and half of them with secondary glomerular disease, which was stem cell transplant, organ transplant, malignant hypertension, other glomerular disease. The main was clinical outcomes and the genetic results. The clinical outcome showed that those patients with secondary TMA had poorer prognosis compared to those patients with AHUS or TTP. Coming to the genetic testing, 2/3 of the patients were positive for rare genetic variants with AHUS, and 15% were positive for secondary TMA. Whereas when they looked at pathogenic or likely pathogenic, 49% were positive for AHUS and 3% were positive for secondary TMA. So it goes on to suggest that the secondary TMA, there is no much role of complement activation. However, there is another study, so there can be a debate, is presence of TMA, complement-mediated TMA in malignant hypertension. This study was published in 2018, actually published in 2017, where they reported that less than 50% of the patients with renal limited TMA actually with malignant hypertension had renal limited TMA. And the TMA was mainly in the form of endothelial swelling, fibrin thrombi, and intimal edema. And all of these patients had elevated C5b9, that is the membrane attack complex, and 2/3 of these patients, that is 6 out of the 9 patients, had positive genetic testing. 3 had positive for C3, 1 each had for complement factor H, I, and membrane attack complex. So I think there is some role of complement in malignant hypertension, but not in other secondary diseases. So my last slide is a summary. So there is a role of alternate pathway dysregulation in patients with complement mediated TMA. Genetics is positive in 60% of the patients with complement-mediated TMA, and the most common one is variations in CFH gene. The role of CFHR is debatable, and we need to read more, or we need to evaluate more. The third one, anti-CFH TMA, most common cause of complement-mediated TMA in children and associated with homozygous deletion in CFHR 1 and 3. In STEC HUS, there is an emerging role of complement, mostly functional rather than genetic. Then malignant hypertension, where you have ruled out all the other causes like IgA, C3, and other glomerular diseases. And most of these patients present with renal limited TMA, And alternate pathway dysregulation is found in 100% of these patients, with genetics in 2/3 of these patients. Thank you all for a patient hearing.
I congratulate Dr. Raja for the excellent talk. And before the session is open for the question and answer, I would like to know your experience. What are the patients who really do good in the long term? How do you decide that which patient is going to do fairly good after suffering from thrombotic microangiopathy?
So,
And
actually, sorry, sir, we have a talk on the clinical part and the management part is subsequently. So I think she will cover that. I don't want to encroach on her domain.
Okay, maybe that's Gina is going to cover.
Yeah.
So should we not invite the questions or we can?
I think the chairpersons can decide upon that.
Because thereafter the other chairpersons are going to come in this place.
Okay. Please.
What about Dr. Narayan? What do you suggest? So should you go for the second session and then the question? It should be open for questions, sir. Because the topic has not been covered.
Dr. Raja, I want to know which patients you should go for genetic testing on clinical basis.
It's a good question. All the patients with thrombotic microangiopathy, where you do not have a secondary disease, should undergo a genetic testing.
Even in malignant hypertension also.
Sir, malignant hypertension, if you are unable to isolate, suppose you do a kidney biopsy, you have only TMA and you don't have any other secondary glomerular diseases, and your renal artery stenosis has been ruled out, I think then you will have to do a genetic testing in these patients because they have an implication in the post-transplant period when these patients land up in end-stage kidney disease.
Regarding this ADAM-TS TTP pathway,
yes.
So should all patients should go?
Yes, the first step in the complement workup itself is you start with ADAM-TS. Only if the ADAM-TS is normal, you proceed with other tests.
Sir, we have time for question answers, 15 minutes in the last. So we'll take all together questions.
Thank you.
Thank you, sir. And I thank the chairpersons and I request them to please proceed towards the left of the stage for the felicitation. Thank you. And with this, I take deep honor to invite the chairpersons on stage for the next talk. And I invite on stage Dr. Anupma Kaul, Professor Nephrology, SGPG IMS Lucknow. Please put your hands together. Thank you. Dr. Sridas G, consultant nephrologist from Kollam. Welcome, sir. Dr. Jalis Fatima, Professor Medicine, ERA, Lucknow. Dr. Venkatesh T, consultant nephrologist from Max Hospital, Lucknow. And Dr. Yuvraj Gulati, consultant nephrologist from Kanpur. I welcome you all on stage.
A very good afternoon to all of you. The next speaker needs no introduction. She's Dr. Saxena Alexander. She's the professor in the Department of Nephrology at CMC Vellore. She has special interest in IgA nephropathy, immune-mediated kidney disease, and renal genetics. Over to you, Dr. Saxena.
Good afternoon. Greetings from CMC Vellore. I'll take you through the pragmatic as well as a comprehensive evaluation for management of thrombotic microangiopathy. Now, we all should understand that when you use the term thrombotic microangiopathy, it doesn't only mean atypical HUS, it means TTP. Typical HUS, which is the Shiga toxin-induced E. coli related HUS, as well as atypical HUS. So when you say TMA, it is all three. Okay, it is TTP, atypical HUS, as well as the typical Shiga toxin-induced HUS. Now, if you look at this pictogram, The previous speaker has already told you about the classification. I'll just take you through some pertinent points. Currently, it's classified as primary and secondary. Primary is again classified as hereditary and acquired. Okay, so hereditary are all the TMAs that have a genetic mutation. Now, these could be either TTP, which has an Adams 13 genetic defect. It could be atypical HUS, which will have complement related or non-complement related gene mutations, or it could be even congenital genetic mutations, for example, the cobalamin C deficiency, where you have a deficiency in the cobalamin synthesis gene. When you come to the acquired, it is when you say primary TMA which is acquired, it means that there is presence of autoantibodies. So again here, it could be TTP, which has autoantibodies against Adams 13, or it could be atypical HUS, typically having autoantibodies against factor H. Again here, you should understand that this classification is not equivocal. It overlaps. So in a patient with atypical HUS who has factor H antibody, many of these patients have a predisposing genetic abnormality, mostly a CFHR 1 or 2, 3 deletions. So it is not a mutually exclusive classification. Now coming to the secondary HUS. The secondary HUS, again, there is a whole lot of infection-related HUS. Here we have the typical Shiga toxin E. coli related HUS and the pneumococcal HUS, which have very distinct pathomechanisms. And these are not, they have distinct pathophysiology. HIV related was more common during the pre-ART era. And there are other infections that can trigger a thrombotic microangiopathy. Now, the reasons are multifactorial. Again, here, you should understand that there are many infections that can trigger in people who have an underlying genetic predisposition. Okay, so they might well have a genetic variant here, and they may have a second hit as an infection, which will manifest the TMA. Now, coming to the secondary TMAs, there are many entities here. There are TMAs related to glomerular diseases. There are malignancy-associated TMAs. There are drug-induced TMAs. TMA secondary to autoimmune conditions, severe hypertension, and especially if you look at these two conditions, that is the pregnancy-associated TMA and the TMA after solid organ transplant. Okay, these are classified under secondary, but more and more evidence that a huge proportion of people who develop these two TMA have an underlying genetic abnormality. So just keep all these things in mind when you evaluate patients with all these triggering conditions. Okay. Now the defining feature of TMA are 3: thrombocytopenia, microangiopathic hemolytic anemia, and organ injury. When you look at atypical HUS, it is kidney, which is the most common organ injury. But obviously in TTP, it is not the kidney, it is the brain, it's a neurology. The other ancillary test, the biochemical and the clinical tests that will help you in establishing a diagnosis of TMA will be a raised LDH, a low haptoglobin, and a negative DCT. So once you have made a clinical diagnosis of TMA, the most common differential that we see may be a DIC, which is actually a problem of the coagulation cascade. But these initial biochemical tests can help you distinguish that. We also need to understand that just because you are saying it is atypical HUS, the manifestations are not limited to the kidney. Okay, people can have manifestations in neurological involvement, they can have cardiac, gastrointestinal, they can have digital gangrenes, they can have hepatitis. So just going by clinical scenario and distinguishing all these variants is difficult. So you need something more than clinical, right? This is just to tell you, now we will concentrate, the next set of slides will be on atypical HUS. And after that, I'll take you briefly through the other types of TME. In atypical HUS, we need to know that there are, these are abnormalities usually of the complement cascade. There are complement regulatory proteins, which can be either membrane bound or they can be in the circulation. As alluded to previously, especially in the case of factor H, if it is a C-terminal abnormality, it relates to a membrane-bound abnormality. That is, the C-terminal binds to the C3b that is present in the cell surface. And when it is in a solid phase, it leads to atypical HUS. And usually when it is an N-terminal abnormality in the fluid phase, the manifestation is usually a C3 glomerulonephritis. Another point that we also need to know when we assess patients are that factor H gene is in chromosome 1. And it is in the same chromosome that we find factor H related genes. And these are located just downstream of the factor H gene. And there's significant homology between these genes, which means that there can be various recombinations. And these can produce hybrid genes. These can produce large deletions or duplications. And it's quite commonly seen in these genes. Okay. Now coming to the genetic drivers of atypical HUS, it's been shown in literature that at least 60% of all atypical HUS cases have a genetic predisposition. But what do you mean by genetic predisposition? Generally, you say that there is a genetic abnormality only if you identify a pathogenic or a likely pathogenic variant. Okay, VUS is not classically, we don't say it causes. It might, with accumulating evidence in future, may get reclassified into pathogenic or likely pathogenic, but as of now, it will be based on whether the mutation is pathogenic or likely pathogenic. And most of them are complement mediated or non-complement mediated gene. In non-complement mediated gene, the ones that we need to look out for are thrombomodulin, the diacylglycerol gene, vitronectin, and recently there have been reports of INF2. INF2, as you all know, is a common cause of adult onset FSGS, right? It is not associated with TME, but there are certain SNPs in INF2 which have shown to cause TMA as a manifestation. And we recently had one reported from a case in Mumbai where the patient had transplant, had an immediate, on the table, had a post-transplant TMA, lost the graft, they did a genetic mutation, and it was an INF2 gene mutation. Now, when we say a genetic abnormality, always remember it is not, we can't say it is causing. There has to be a separate trigger. In most of the cases, there'll be a second hit. So it is a two-hit hypothesis. Okay, you have a genetic predisposition and you have an acquired trigger. The acquired trigger can be either an infection or it could be pregnancy, drugs, post-transplantation. Now, the common endpoint for all these triggers are usually complement activation. Okay, as we know, in pregnancy, what happens? Normally, the complements are activated. If you look at the feto-maternal interface in the placenta, normally complements are activated. This when this becomes out of control, it can become the second trigger. Even in infections, complements are activated, right? The innate immune system is activated in infections. And even in post-transplant scenarios, with CNIs and ischemia reperfusion, the complement cascade is activated. So what are the clinical dilemmas that we have now? One is the complement mediated TMA can be mimicked by a host of secondary TMAs. There are multiple potential triggers. And if, depending on the etiology, the chance of recurrence post-transplant can be low, high, or moderate. And it also has implications for living-related donors. Hence, just a clinical classification or basic test may not be enough. And that is why now, in most cases, a comprehensive evaluation of the alternate pathway is recommended. Now, what do I mean by comprehensive evaluation? These could be 5 types. One is you measure the serum levels of different complements and complement regulators. Second is you look at the serum levels and quantify their activation products. Third are looking at acquired drivers, that is autoantibodies. So you have C3nef, you have C5nef, you have factor H antibody. Then also you have functional assays. Functional assays look at the activity of the alternate or the complement, classical complement pathway. And you have genetic analysis looking at the various genes. Now, so when do we consider genetic analysis in a case of atypical HUS? This is the criteria that's generally recommended, especially when you have more than one family member who have a diagnosis of HUS. There is an individual who relapses, the HUS relapses in an individual after complete recovery, or you do not have, you have a secondary cause, but not the classic Shiga toxin induced E. coli HUS, which can be like a secondary trigger, and there can be an underlying genetic basis. The diagnosis of genetic HUS is based on the presence of pathogenic variants. There are two ways of genetic inheritance. One is the heterozygous dominant inheritance of one of these complement or non-complement genes. There can also be homozygous recessive inheritance, and this is especially true for diacylglycerol as well as INF2 gene. One thing that we need to know is even if you have a gene, it doesn't mean that you will manifest the disease. Okay? Because you have to understand that most of these autosomal pathogenic variants have incomplete penetrance. That is, they don't manifest the disease 100%. And one of the important factors for manifesting the disease is age. So as your age increases, your penetrance increases. It has been shown that when you reach 70 years of age, the penetrance of these genetic mutation increases up to 65%. Apart from single nucleotide polymorphisms or single mutations, there are modifiers that can cause, that can be the predisposing factors. And these are related to groups of SNPs in genes like CFH or CD46, or there could be homozygous deletions of CFHR related genes. Now coming to the ways in which you can do genetic testing, they can be either single gene, which is usually not recommended, only if it is a very young child who has most probably a diacylglycerol autosomal recessive kind of inheritance. You have multi-gene panel. Again, here you should be careful. You need to include all the complement related and non-complement related genes that cause HUS. And you will have to specifically look for deletions in complement factor H related genes, as well as the haplotypes. Hence, the most comprehensive genetic test that we recommend will be whole exome sequencing, but you can have a virtual panel of complement gene to do an initial screen and then expand the panel if you don't find anything in the initial virtual panel. Also, you will have to do an MLPA, though you can get some indication on CFHR related CFHR 1 or 3 deletions. Those are large deletions in NGS panel. It depends a lot on what controls are being used and whether those controls are standardized. Hence, a second test like MLPA is essential to confirm CFHR 1 or 3 related, these gene related deletions, large deletions or duplications. Okay, this I have already alluded to previously, so I'll not go more in detail. So these are autosomal dominant pathogenic variants. and there can be autosomal recessive homozygous variants. Polygenic inheritance is when you have genetic variants in more than one complement related or non-complement related genes. So now what is the role of plasma infusion? Now, though we are in the era of eculizumab, we cannot underestimate the role of plasmapheresis, okay? Just because we are in a role of eculizumab doesn't mean that plasmapheresis does not have a role. And in most cases, at least in the current scenario, eculizumab is not affordable for many of our patients, and we have to rely on plasma exchange. So despite the variability of response, if the patient comes to emergency or your clinic with evidence of MAHA, thrombocytopenia, and organ injury, and you have diagnosed TMA, I don't think you will have enough time to go and get the drug eculizumab. The first line therapy for you at that point is to immediately institute plasma exchange after taking a blood sample. Now I'll come to that, what blood sample it is. Plasma exchange is usually the monitoring parameters are platelet count and serum LDH. Now, does genetic abnormality help you to optimize plex treatment? There are certain indicators that will help you and to prognosticate your patients as well as to understand whether it is going to overall improve your patient's care. So if it is CFH, there is definitely a role for plex because it replaces the CFH protein. Even in C3, there is a 57% response rate because the plasma exchange will take out the mutated hyperactive C3 and also provide the necessary regulatory plasma proteins. In CFB, there is very limited data for the use of plex. CD46 is a membrane, transmembrane protein, and theoretically there is no benefit. But there are studies which have shown that 80 to 90% of these mutations remit with plex. Hence again, treatment will have to be tailored to your clinical severity. What about CFI? CFI, though it is a genetic mutation, and we would say that with plasma exchange, there will be replacement of CFI. The remission rates are quite low if you have a CFI mutation. It is mostly because CFI is a large protein, okay? And you need large volumes of plasma to correct this deficiency. In cases of non-complement related gene mutations, which are diacylglycerol, the benefit of plasmapheresis is not shown, even in INF2. Now coming to C5 eculizumab, which was approved by FDA in 2011. Again, it is useful, especially for complement gene related variants, but not for non-complement gene related variants. Some of the practical considerations for eculizumab therapy in your outpatient is meningococcal vaccine is mandatory. And though vaccine is mandatory, the serological conversion following vaccine is very variable. Hence, you also require long-term antibiotic prophylaxis. It is an intravenous infusion, and it is usually administered every 14 days. The monitoring parameters could be hematological indicators for TMA. It could also be CFH50 and AH15. At this point, I would like to say that Dr. Valentine's lab does many of these complement related tests, especially CH50, AH50, factor H level, anti-factor H antibodies, and C3. So some of them are done even in our center, but we don't do the activations. The other C5 antibody that has been recently approved by FDA is ravulizumab. The advantage of this over eculizumab is that it has a much higher, it's a longer acting. So you need to give it only every 8 weeks. Now, does the eculizumab have a role in preventing recurrence? Yes, both primary and secondary. Primary in people who have known pathogenic variants, and secondary in people to prevent post-transplant recurrence in people who had TMA-related end-stage kidney disease. Especially in secondary recurrences, there is a risk stratification from low, moderate, high. I'm not going too much into details of this because of the want of time. Other drugs that are being evaluated in different phases of clinical trial. Some of the promising ones are avacopan, there's iptacopan, there is anti-factor B drug, and cemdisiran. What about renal transplantation outcomes? Again, there is a role for genetic testing here to define graft prognosis, especially C3, CF5, and CFB, the graft failure rates are very high. MCP, there is no recurrence, and you can safely go ahead with renal transplant because it is a kidney-related protein. CFH, definitely combine it with a liver transplant. Diacylglycerol, again, there is no recurrence. You can safely go ahead with renal transplant. Thrombospondin is a very contentious thing, and it might require protection. Now, can we discontinue eculizumab in patients who have been started with us and who's had a recovery? Again, it has been shown that though eculizumab, initially, when it was licensed for lifelong use, though there was no evidence. But now there is emerging evidence that you can safely discontinue eculizumab, at least in a proportion, a subset of patients. It is not advisable in those who harbor a CFH mutation. With experience in using eculizumab, it is also shown that some of them can have non-response to eculizumab, okay, just because they have a complement-related underlying abnormality. And you should also understand that all the studies that have been done using eculizumab, most of them have not had an underlying genetic abnormality. Okay, just because you don't have an underlying genetic abnormality does not rule out a complement-mediated HUS. Now, 27% of individuals without an identified complement abnormality failed to show an improvement. They've also shown that a polymorphism in C5 gene has been demonstrated to hinder the binding of eculizumab, and those who don't respond to eculizumab have been advised to undergo genetic screening for this polymorphism. Also, individuals with non-complement related genes can have non-response. Hence, there are various genetic dilemmas too, in addition to the clinical dilemmas. Now, just to go briefly through the other forms of TMA and how we will approach it in a pragmatic way. One is, first is to diagnose TMA based on the essential clinical and biochemical tests, okay, which is thrombocytopenia, MAHA, and the ancillary clinical tests. Now, once you have diagnosed and have ruled out others like DIC, then the first thing is to institute plasmapheresis after taking a blood sample for what? For Adams 13. Okay, so you institute plasmapheresis after plasma exchange after taking a blood sample for Adams 13 genome activity, and that is the first line. Every other evaluation will be after that. So after you institute plasmapheresis, you go ahead with a comprehensive evaluation. The results of all the comprehensive evaluation is going to take some time. It's not going to come immediately to you. So you meanwhile look at all the other secondary causes that can be ruled out. There are specific tests. For example, typical, you can have sugar toxin detection if there is sugar toxin suspected E. coli. Pneumococcus, again, if there is isolation, then it is supportive treatment. HIV, other infections can have complement gene abnormality as an underlying, as a predisposing factor, so you need to be careful. You may continue plasmapheresis till those results come. Drug-induced TMA is very interesting. Drug-induced TMA can be because of either autoantibodies or to platelet glycoprotein complexes, or it could be because of a dose-dependent toxicity, and this is true for many of the chemotherapy drugs, Or as in the case of ticlopidin, it could be an autoantibody to Adams 13, right? And most of the cases, the treatment is immediate drug withdrawal, except for ticlopidin where there is a role for plasmapheresis. Then we also looked at other secondary causes, which is hypertension. Now, it's very difficult for you in a clinic to know whether it is hypertension which caused TMA or TMA which caused hypertension. Hence, may be safer. Usually, if it is a severe hypertension that causes TMA, then with the BP control, the parameters, that is a MAHA, platelets, all that should normalize. If it is not normalizing and if it is proceeding to an end-stage kidney disease, definitely it requires it will require a comprehensive evaluation. Then there are autoimmune diseases where the treatment is treat the underlying condition. You have bone marrow transplant related TMA. You have TMA post solid organ, that is post renal transplant, for example. Here again, a high proportion of patients will have complement gene abnormality, and you will require a comprehensive evaluation. Malignancy, again, there's no role for plasma exchange, and DJKE, again, there's no role. Now, these three entities remain, okay? The complement-mediated HUS, the post-renal transplant HUS, and pregnancy. Because there is a high proportion of patients who have complement abnormalities, mediated abnormalities, these could go in for Flex and eculizumab. So the take-home message here is to establish the cause of TMA after complete evaluation. Acute decision-making is time critical, and the initial priority is consideration of plasma, sorry, not TTP, Plex. Urgent management is important to, because the high mortality, especially if it is TTP. And if Adams 13 excludes TTP, then obviously there's a role for Plex or eculizumab depending on the underlying condition. Thank you.
Now's the time for the discussion.
Thank you so much for the talk, ma'am. The house is open for the questions now.
Thank you so much to all the speakers. I'm from PGI, so we see pediatric nephrology. We see at least around 25 atypical HUSs in a year. So I would just want to ask what the other centers are actually doing, because out of these 25 patients, most of them are anti-factor H for us. And we have the other types also. So in anti-factor H, which is the most common, so international and national guidelines say that we should start steroids, then we give IV cyclophosphamide together with plasmapheresis. This plasmapheresis will go on till there is remission. And then after the 6th dose of IV cyclophosphamide, we would then start on MMF. If the child does not respond to IV cyclophosphamide, it's something like something that is taken from lupus, because anti-factor H is an antibody. So if the child does not respond to cyclophosphamide, we give rituximab. And if the child still does not respond to all these plasmapheresis, IV cyclophosphamide, rituximab, then we will think of eculizumab, because eculizumab actually, at least the Solaris one will cost somewhere around 28 lakhs per month, and the normal one will also cost 1 lakh per vial. So it's very difficult to get. So I wanted to know what the other units are doing.
Actually, Sana has presented this patient. This was the first time we have used eculizumab in one of the patients, because that was affordable, and now it is available in black market. You can get it from Delhi. So that is the good news for someone, those who can afford. And you can see almost protocol is similar. We give plasma, we start plasmapheresis as soon as possible. We get ADMTS 13 is available. We get to roll out whether this is there. Anti-factor H antibody, if available, get it done. Do plasmapheresis, get the hematological remission. But we start steroid and mycophenolate mofetil or cyclophosphamide depending on the condition of the patient, whether this patient has infection or not. When we have dilemma of infections, many times we have high procalcitonin and very high TLC, that might be due to HUS per se, but sometimes you have dilemma. Then mycophenolate moftil, steroids, get these hematological remissions, continue plasmapheresis. If hematological remission we get, then we reduce plasmapheresis. And we can show the data was excellent. Sometimes anti-factor H antibody positivity response rate was 70%. 70% of your patient response. Right now, we have one patient admitted there that she has presented, she has mutation. Despite giving eculizumab, she was throwing seizures. Blood pressure was sky high. 6-7 antihypertensive along with AC inhibitors, angiotensin receptor IV to control blood pressure. So now she has started responding after about a 1.5 months. She is dialysis free, putting out the urine output of 1 liters. So protocol is almost similar. This is this you can say the poor man's protocol. So there you must try, but I think we should not leave that if you do not have the eculizumab, you cannot use. We have post-transplant recurrence with the HUS. The Iptacopan was available in the trial. Dr. Dharmendra has used this in this patient. The patient has responded. So whenever you have availability of these medicines, you should use. But it is not that we should not try in this group of the patient. Definitely, I think I would like to have comment from Dr. Raja.
Yeah, I just need add a little bit. So I think I'm not sure. I'm an adult nephrologist, so I'm not a pediatric nephrologist. But from what other centers that have eculizumab practice for their pediatric patient is because children have a higher mortality with plasma exchange. Many of the pediatric centers that have access to eculizumab, they even use eculizumab as a first line therapy without starting Plex. And the other thing is you definitely need a comprehensive evaluation in children, even if it's the presence of anti-factor H antibody, because there can be complement related gene variants.
Thank you, Dr. Alexander, for the elaborate presentation. My comment would be specific to the eculizumab availability. Eculizumab is available free of cost in multiple centers across the country. Only thing we need to put some efforts. Kara's head is actually the chairman of the committee who gets eculizumab for us. So he will surely do it for Kara as well. So we go by a quotation L1. And the Russian eculizumab is available. Most of the eculizumab that comes to India now is a Russian because Solaris officially does not market it outside Europe or the Western world, you can say that. So I think AIMS, SGPGI,
many of the government
PGI, and
institutes,
also
I think, will have,
Vellore is also a center. So you will be able to get free eculizumab for your patients as well.
Okay.
Yeah. Just wanted to know if I understood from the case that patient received about 14 plasma exchanges over a month and a half. So I think the Indian Society of Pediatric Nephrology guidelines say daily plasma exchange for 7 to 14 days and then alternate days till remission. So perhaps the intensity of the plasma exchange may need to be a little more one. The second, as Dr. Allen also mentioned, that there is a paper from Newcastle which says that 1/3 of their patients who had anti-factor H antibodies also had other genetic abnormality. So that's something to look at. I saw the MLPA result. We had a patient who came to us very well managed in a pediatric nephrology unit in Mumbai for 7 years, and he had multiple relapses. Each time his antibodies were done, he received plasma exchange and immunosuppression. When he came to us after 2 years of follow-up, at the age of 19, he became end-stage renal disease and he wanted a transplant. We did a whole exome sequencing and he had an inverted formin 2 mutation. So under the other abnormalities which may not respond to either eculizumab or plasma exchange, which may coexist, need to be looked at.
Definitely, what happens when you are treating your patient? You see this patient had initially hematological remission. We thought that everything is fine. Patient's urine output improved, patient was looking fine. But suddenly, one day, he has accelerated hypertension, she thrown seizure, urine output reduced, and we are very much scared at that point of time. So we have got the second doses of eculizumab again. After third or fourth, one patient, we have done plasmapheresis for 2 months. And that patient came with a serum creatinine value of 4. Now that boy, after getting this much of the plasma, he was obese, he was tolerating plasmapheresis well, and he becomes dialysis free now. He was one businessman's son from Kanpur. He afforded everything. Creatine value came down to 1.5. Now he is in our follow-up 1.5 years. So which patient is likely to behave in what way? Totally different. We have a conversation with the Dr. Arvind Baga for this patient also. What to do next? Everything is being done. So wait for ya. So sometimes this blood pressure business, once we have controlled his blood pressure, she becomes relatively little better now.
Just one more point I would like to add here. That is when you have a TMA patient who is progressed to end-stage kidney disease and awaiting transplant, it's better to do a comprehensive evaluation, including genetic, because it has implications both not just for the patient as recurrence, but also for the living donor. And if you have an identifiable complement-related gene mutation in either the recipient, then it's better not to go ahead with the living donor.
Thank you so much for the wonderful presentation and for the wonderful session. I request the chairpersons to please proceed to the left for the felicitation. Without further ado, let's give a warm round of applause to our esteemed chairpersons for the next session, that is session 2. And I am deeply honored to invite on stage Dr. Asit R. Mehta, consultant nephrologist, Narayana Super Specialty Hospitals, Ahmedabad. Please put your hands together. Thank you. With deep honor, I invite Dr. Narayan Prasad, Professor and Head, Department of Nephrology, SGPGIMS, Lucknow. Welcome, sir. And I invite Dr. Manas Patel, Additional Professor, SGPGIMS, Lucknow, on stage. It's the request to the speakers to please restrict to the time, because we have so many sessions lined up. Thank you so much. And the stage is all set. Over to you, chairpersons.
So good afternoon and welcome to another session. Another very important topic, and we all face this day to day. So I straight away called Dr. Swaminathan from Bangalore to deliver his talk. So he is basically associated with the Indian Institute of Sciences and Medical School, Bangalore, and adjunct faculty at Mayo Clinic, USA. Dr. Swaminathan.
Good afternoon. Thank you, Dr. Prasad and the organizing committee for inviting me here to give this talk. So, so today we are going to look in depth about molecular mechanisms that kind of plays a role in progression of acute kidney injury to chronic kidney disease. So for a post-lunch afternoon session, it's going to be a lot of molecular stuff. I'm giving heads up and warning, and I'll try to keep it interesting as we walk through this. So little bit about acute kidney injury. AKI affects 30–60% of critically ill patients, and it's associated with acute mortality and morbidity. And again, because of the long-term impact on renal function, including chronic kidney disease, and risk of recurrent AKI and increased risk of cardiovascular complications. So long-term mortality is increased even after a single episode of acute kidney injury. So therefore, prevention, early recognition and prevention of acute kidney injury is really important. And unfortunately, we have not made much progress. There are very limited interventions that we can use in our patients to prevent and treat AKI. And these are generally limited to optimizing hemodynamic status, generally with fluids, and avoidance of nephrotoxic medication. And also search for a specific pharmacological treatment is hampered by late diagnosis and complex and incompletely elucidated pathophysiology. So in that sense, like now, various classifications are there. I'm just just for the sake of giving you a little bit background, here you all know this a patient at risk of AKI, for example, somebody with a chronic kidney disease or congestive heart failure. And then we have this subclinical AKI where there is an increase in biomarker, but you have not seen an increase in creatinine or a drop in urine output. And then AKI stage 1, stage 2, and stage 3. And if this reduced kidney function continues beyond a week, up to 3 months, now we have this period called acute kidney disease. Beyond 3 months, if the renal function dysfunction persists, then it becomes a chronic kidney disease. So various things have been discovered in the last few years, and people have come out with a clinical risk score, which can be useful in predicting who is going to get acute kidney injury. For example, this is useful in cardiac surgery setting. You can plug in certain factors and that can give you some information. Usually biomarkers are in a later stage of acute kidney injury, which is when it is useful, although I'm going to show you some data where biomarkers are becoming available where you can actually predict the risk of acute kidney injury. And then this e-alert, some of it I think Dr. Jha will cover in his talk, and real-time prediction models with artificial intelligence coming into picture. So this is again a summary of the same thing where we talk about acute kidney injury, and then there is a big acute kidney disease here, and there is an overlap, and then it evolves into chronic kidney disease, primarily determined by the duration of persistence of low kidney function. And so usually, many patients may not have a biopsy, and if they do, that will help. But in addition, you can look for markers of kidney damage like albuminuria, and even in patients evolving from AKI to CKD, albuminuria can be a very powerful predictor. So generally, when we go by clinical factors, there are a lot of studies that are available. What I try to do is to pull some recent studies to see if there are some new pieces of clinical data that could be helpful in our day-to-day rounds, when we see patients. So, for example, in cardiopulmonary bypass, we all know age is an important factor, CKD, diabetes, all those factors are there. But then this recent paper in a small sample size, but again showed if presence of right ventricular dysfunction and diastolic dysfunction are important disease predictors. So then, as I mentioned earlier, this recent paper published in Lancet actually have discovered a biomarker which can be measured pre-operatively. It's called DKK3 or creatinine. And this can actually predict who are the patients who are going to have an acute kidney injury with it's a sample size of 733 patients. And pretty significantly, it can predict the risk of acute kidney injury. So then there are other newer biomarkers, TIM2, IGF-BP7, NGAL, many of you are aware. And the standard clinical practice, we use fractional excretion of sodium, fractional excretion of urea, proteinuria, and all that. But then there is also this a kinetic eGFR, which is calculated based on changes in creatinine. So this is the formula for calculating kinetic eGFR, where you measure serum creatinine at 2 different time points, and then you plug into this equation, and that can actually give you a better estimate of what is happening to the kidney. So then going to some novel biomarkers, what I did is that I took those, there are hundreds of thousands of articles for biomarkers in AKI. So then I was going through the literature. I just picked up those where there are repeated kind of data from multiple centers showing that it is showing promise. So CCL14 is one such marker where they've shown that it's a novel one, where they've shown that there is a pretty good prediction for acute kidney injury, and particularly with the cutoff, which is more than 13, it's a very, very good marker for predicting persistent acute kidney injury. So essentially, persistent acute kidney injury is when acute kidney injury persists for more than 3 days. So, so this is something it could be used. So now, with this background, now let us start thinking about pathophysiology of acute kidney injury. So we all know that there is a tubular epithelial necrosis, and we know that there are immune inflammatory cell infiltrate, And there are like a lot of other novel mechanisms, right? Mitochondrial dysfunction is something we all know. It's a part of what happens in the kidney. But then there are like newer things, like you must have heard this work from Samir Parikh about the deficiency of NAD+. He had a fantastic paper where a small clinical trial as well, where he showed that this could actually, deficiency of NAD could play a role in acute kidney injury. But then there are a lot of other very interesting mechanisms that are evolving, particularly the cell cycle arrest. The work with cell cycle arrest is very old. Dr. Bonventre's group has published on this more than 20 years ago. But then new pieces of information are evolving in the area of like cell cycle arrest. And then ferroptosis, this is something area very close to my heart because some of the work I did was in iron and acute kidney injury. And I'm very gratified to see that a lot of work, very, very good, coming out, showing relevance of ferroptosis in acute kidney injury and progression to chronic kidney disease. So now that being said, so let us step back. So we see acute kidney injury and then patients that are typically hypovolemic, and let's say they have a diarrhea or gastroenteritis. That is one set of patient we see on our rounds. And then we go to the next bed, and then here we have a patient who underwent a, abdominal aortic aneurysm surgery. And then there was clamping, cross-clamping of aorta, and then there's a renal ischemia, and then patient has got acute kidney injury. So here, on a routine clinical practice, see both these patients have elevated creatinine. Both these patients have a drop in urine output. And then the standard markers, we may use creatinine. Best case scenario, we may measure like NGAL. And then we say that, okay, patient has got acute kidney injury, whether you diagnose it 12 hours later or 48 hours later, and then treatment, wait and watch, give Lasix, urine output picks up or not, and then dialysis becomes indicated, start dialysis. I mean, that is where we are with our clinical practice of acute kidney injury. And we treat both these patients identical. But what it turns out that there are entirely different things that are happening in the kidney, although both seem to have a reduced blood flow causing a tubular necrosis and acute kidney injury. So this is very important to understand. So all AKI, although they may look like it's all ATN, it's not the same. See, right now we think about ATN and acute interstitial nephritis as separate. We know that acute glomerulonephritis and interstitial nephritis is separate. But when it comes to ATN, we think like ATN is all one and same. When we think about AKI, we think about ATN, but ATN is not all one and the same. It's different. So how do we know this? So in this paper, what they did is they depleted volume to cause a volume hypovolemic AKI. And then in another group of mice, they induced a renal ischemia by clamping the artery to cause like acute kidney injury. And then they went and looked at very deep transcriptome changes in different parts of the kidney. That's what you're seeing. Look at what you're seeing, the Venn diagram here. There is very little overlap in terms of the changes in the genes and RNA that you're seeing between these two groups of kidneys. So AKI is not all one as we think. So again, here showing some of the heat maps, you can look at there is nothing that's comparable between the two. It's all red here. And then they looked at various signals here. And here, in volume hypovolemic AKI, you're seeing more of metabolic kind of changes here. But whereas in inflammatory acute kidney injury, you're seeing a lot of coagulation and inflammatory pathways that are like different here. So not only ATN, and let's say that we have patients with a sepsis presenting with acute kidney injury. It turns out patients with sepsis, they have like very different phenotypes. So this is a fantastic paper published in Chest and then a few others. Now they phenotype sepsis into 4 different phenotypes. So the patients with the delta phenotype of sepsis are the ones who get acute kidney injury. What is the delta phenotype of sepsis? These are the patients who are hyperinflammatory. They got like a lot of activational coagulation markers. Inflammatory markers are very, very high in these patients. Many of them have underlying, for example, chronic liver disease. They belong to the delta phenotype. So when you're seeing, somebody with a sepsis, look at these phenotypes to understand what is the risk of acute kidney injury. You can literally put them into these categories and then say that this is the subset of patients who is going to be most likely to develop acute kidney injury. right? So this is all based on clinical observation itself. There is so much of it. So likewise, so far what we have seen is not all ATN is not identical. Within ATN, there is a huge differences. All sepsis is not the same. There are like 4 different phenotypes, at least, that we know of. Now, looking at cell death. So when we talk about acute tubular necrosis, we used to talk only about apoptosis and necrosis. So now we know that there are varied types of cell deaths that happen in kidney injury. So now apoptosis is when it's a caspase dependent process. And the key thing that I want you to remember is when there is apoptosis, the plasma membrane does not rupture. It does not rupture. So it does not lead to activation of the inflammatory cells. So it's a non-inflammatory kind of a thing, apoptosis is. It does not play an important role in acute kidney injury. That is something for the trainees here, very important to remember. Apoptosis does not play a very important role in the pathogenesis of acute kidney injury. So now if you leave apoptosis aside, now people have thrown away the term necrosis. Now we talk about like 2 important types of cell death that happens in a kidney that is undergoing ATN. The first one is what is called as necroptosis. The second one is called ferroptosis. Ferro is iron, so it's an iron-mediated cell death. Necroptosis. So both these processes have very well-defined molecular pathways. And again, what you can see is in both these processes, unlike apoptosis, there is rupture of plasma membrane, and it leads to activation of inflammatory cells. So you will see infiltration of the immune cells like macrophages, lymphocytes, they all come into the kidney. So this is the reason why these kidneys do not recover completely. They progress on to develop something chronic. That's the hypothesis. I'm going to show you more papers. So this is the 3 types of cell that we spoke about: ferroptosis, apoptosis, and necroptosis. Very complex molecular mechanisms. And here, you see hepcidin. This is the work that our lab have originally showed to be protective in acute kidney injury and in other models of like kidney injury by limiting iron that's available in the peripheral blood. But then a lot of other excellent work have really studied ferroptosis closely. Now we have like small molecules that can inhibit ferroptosis and have been shown to benefit acute kidney injury. So this is apoptosis, and this is what is called necroptosis. If you have to remember something within this complex cascade, I would suggest remember RIPK3, RIPK1, and MLKL. So those are the 3 things you need to remember in necroptosis. So that is how like necroptosis happen in the cell. So now it's not that just the epithelial cells are dying. As the epithelial cells in the kidney is dying, I want you to visualize a kidney that is undergoing ischemia. This is your patient who is post-operative after abdominal aortic aneurysm after a clamping. So you are seeing him at hour 3 after surgery. He's not making much urine. So what is happening is that those cells are dying by necroptosis. There is death by ferroptosis. And then these cells are releasing extracellular vesicles, which is going and attacking the healthy epithelial cell, which is present in the kidney. So this is called as propagation of kidney injury. So you need to have one insult, and then that one insult leads to a propagation of wave of death. That's what it is called. That is what leads to worsening of kidney function, although the insult is not persisting anymore. So now this is a very important concept that has evolved over a series of papers that has been published. The cells are called inflammatory proximal tubular epithelial cell. Essentially what they've shown is the proximal tubular epithelial cell, when the AKI persists, then over a period of like 7, when we have like acute kidney disease, AKI to become AKD, then these epithelial cells, they start expressing this markers called VCAM1 and SOX9. And essentially what was very interesting is that like these are the cells that lead to persistent dysfunction of the kidney. So these inflammatory proximal tubular cells, now rather than being non-inflammatory epithelial cell, the cell itself changes the phenotype. It becomes an injury inflammatory proximal tubular cells. And what this study showed is that like these cells have high expression of ferroptosis markers. And when they gave the small molecule LIP1, then they were able to show that they were able to reduce this persistent abnormal cells in the kidney. So essentially, this is a paper just published recently to show that you can inhibit ferroptosis and prevent AKI becoming AKD and becoming chronic kidney disease. So this is again the same thing I'm showing here to show that you can show the benefit over a long period of time. So these are called as damage associated proximal tubular cells. These are the healthy proximal tubular cells in the kidney, and then there is this fraction of cells that leads to progression of the chronic kidney disease. So you can inhibit them, and then you can show that there is a benefit that happens. And not only ferroptosis, there are like, necroptosis and inflammatory markers like TNF alpha, and there is another protein called Indian hedgehog. Here they show that, you can inhibit that by giving, genetic knockout of the animals. You protect the kidney from fibrosis. And this is a, animal model of ureteric obstruction. And also what they show is that like patients who have an elevated level of Indian hedgehog, then they seem to have a worsening GFR in the long term. So this is another biomarkers that could be helpful. You can measure Indian hedgehog in the plasma, and then say that, let's say that you see a patient 1 month after AKI, you can measure the Indian hedgehog levels in the blood. If it is persistently elevated, he is likely to progress to chronic kidney disease. So then these cells are also called as scatter cells. The cells that I told you as injury, inflammatory, proximal tubular cells, they are also called as scatter cells. So this is one paper, I'm just showing it here because, it's not like all evidence suggests that these cells are bad. There's one paper in a model of renal artery stenosis showed that it could actually have some beneficial role. So I don't know what to make of this. There's the only odd paper out there which gives a contrary evidence. So then in these cells, there are a lot of genetic changes that happen, and they looked at various markers. And so this state of epithelial cell, it's called as failed repair. So these cells are not able to repair, and they get better. So the next two sets of data I'm going to show is very interesting. I want you to pay attention to these two interesting pieces of data. So far we have looked at ferroptosis. We have looked at a set of proximal tubular cells which are not recovering, which are inflamed, which is causing chronic kidney disease. But then there is an idea called polyploidy. Polyploidy is like, where multinucleated kind of cells, where the cells have thing. So what they showed is that like in this paper, when you have polyploidy, it's controlled by a factor called YAP1. And this was published very recently in Nature Communications. And very interestingly, when you induce polyploidy, you protect from acute kidney injury, but you have worse chronic kidney disease. So this is a very important concept to remember. So these animals are protected from acute kidney injury, but they have worse chronic kidney disease. Okay, so this is one set of data. So this is the previous one. So again, they have like worse fibrosis, as you can see here. When you knock out the polyploidy is induced, because when you have SAV1 knockout, there is more polyploidy, and they get like more fibrosis. All the blue areas are more fibrosis. So normally what you would have thought is, when you have a protection from acute kidney injury, you would think that there is less injury, therefore there will be less fibrosis. But rather what you saw in this paper is that like it's not necessarily true. There is not a linear correlation between a protection from acute kidney injury and protection from chronic kidney disease. Okay, now go to the second paper. So this paper is something where they deleted a gene that's important for renal development. PAX2, PAX8 genes, they're important in the formation of the renal tubules and everything, when the kidneys form. So they just knocked out those genes in the tubules of the kidney. And then what they did is, then they induced ischemia, and then they looked at what happens acutely and what happens chronically. What was shocking is that like these kidneys, they had like increased injury, acute injury, but they had like less fibrosis in the long term. It's the opposite of the last paper I showed you. So the last paper, we saw that there is more injury, There is protection from injury, but there is more fibrosis. Despite protection from acute injury, there is more fibrosis. This paper shows there is more injury, but those mice with the more early injury changes have protection from fibrosis. Okay, so this is like, this completely throws out the hypothesis that there is a linear correlation between more injury to the kidney and more fibrosis. That's not true. So then the authors here, they went ahead and separated these cells, and they show that essentially you induce a little bit injury to the kidney cells. Then those cells, they get prepped and they're ready to deal with a bigger challenge. You know, it's like the example I can give is a spoiled kid. You know, a kid that has been challenged a little bit is prepared for the worst. I mean, even an adult. Same thing happens in the kidney tubular epithelial cells. So people used to call this as a preconditioning kind of a thing. I mean, this is fascinating. So then there are like novel mechanisms, like, you know, there is a whole thing called TASCC, which is a component that has like involved in, like, you know, cell cycle arrest, and which is associated with cyclin G1. And that turns out to be very important. And if you are able to knock this out in the proximal tubule, then you reduce kidney fibrosis in mice with a chronic kidney disease. So then there is also some data about intracellular HMGB1. See, HMGB1 is actually one of those danger-associated molecules, right? And a lot of studies have previously been done where they actually gave antibodies or other kind of chemical inhibitors to neutralize HMGB1. And the idea was that, like, you know, it'll protect from chronic kidney disease. It'll prevent acute kidney injury and protect from chronic kidney disease. And the data has been negative. You know, it has been all over the place, and essentially people gave up. But here in this paper, what they have actually shown is HMGB1 is present inside the cell. It's called tubular intracellular HMGB1. If you're able to specifically delete the tubular HMGB1, then you're able to protect from AKI becoming chronic kidney disease. So this is another type of a new thing which is been published recently, where we know the distinction between extracellular and intracellular HMGB1. So now we have so far looked at various molecular pathways, various types of cell death, and cell cycle, danger molecules, and also we looked at the discorrelation between severity of acute kidney injury and chronic kidney disease. So those are the 4 or 5 things we have seen so far. So now that comes another important concept, which is nephron endowment and risk of progression of AKI to chronic kidney disease. See, there is a lot of work, you know, on nephron endowment, and, you know, generally the thought is that, like, you know, these are people who may have increased risk of chronic kidney disease. But this paper is a very, very nice paper to actually systematically address that. So the glial-derived neurotropic factor and its signaling through RET is very important in nephron development. So what they did, authors, is that, like, you know, if you're going to really delete RET, then those mice won't develop. They won't survive. You know. So now they came out with a very interesting innovation here. So they created a mouse with a floxed RET allele that's engineered with a single amino acid substitution. So what it does is that, like, now the RET protein is more sensitive to a chemical. So now they can actually go and give a chemical to modulate the level of RET. And so essentially you're creating a very similar kind of a thing. And what they actually showed is that, like, you know, as you see in the picture, the nephron numbers are less in the NAPP1, which is the, you know, the mutant mice treated with a drug. So essentially in this setting, they took those mice and with a low nephron endowment, and then they looked at, just followed them. That's one set of experiments. And the second set of experiments is that, like, you know, in those mice with the low nephron endowment, they gave, like, neonatal gentamicin exposure, and so it's a nephrotoxin. and then it causes severe injury and incomplete repair. In both these model systems, they went on to show that there is worse chronic kidney disease as these mice get older. And also, like after an acute kidney injury, these mice go on to develop accelerated chronic kidney disease. So this is an excellent experimental model to really show that low nephron endowment is a risk factor for AKI progress into chronic kidney disease, right? So next time, then for trainees, when you see a patient, make sure you take a history, birth history of the patient, if it is available, right? So that could have some relevance to their adult risk of AKI progressing to chronic kidney disease. So now this is another model they've used. See, we didn't have a good model to study cardiorenal syndrome. So here authors have created a model of a CPR, cardiac arrest. So essentially what they did is that they took mice and then they actually intubated the mice, gave anesthesia with isoflurane, and then they induced cardiac arrest. And they left the mice for 8 minutes, and then they did a CPR, and they were able to rescue about 75% of the mice. So now they are survivors of cardiac arrest, these mice. And now, so it's a model which is developed and published in 2019. So it's a good model to study, what happens after cardiac surgery. So then they looked at what this is a complex system, what they developed and how AKI kind of develops and what percentage of patients, mice develop chronic kidney disease. They're followed up to 7 weeks here. They didn't have a follow-up after 7 weeks, but 7 weeks is a pretty good length of time. And as you can see that very significant subset of these mice, they go on to develop chronic kidney disease. But what is very interesting here is this is a GFR. So if you look at these are sham, which are control mice, and these are mice that underwent the cardiac arrest followed by resuscitation. It's at 1 week. As expected, at 1 week, there is acute kidney injury. There is less GFR. And then if you follow them for 2 weeks, at 2 weeks, there is a recovery of GFR, pretty good recovery of GFR, as you can see, compared to the sham level here. But despite a recovery in GFR, you look at the kidney, there is significant fibrosis. So this is another very important lesson to keep in mind. So we see patients with acute kidney injury where the creatinine goes up from 0.8 to 2.4, and then we give fluids or whatever interventions we do. Creatinine falls back to 1.2. Then, if you're a little bit, nephrology team is a little bit more patient, they'll say, okay, follow for 1 more day. And then they follow, and then the creatinine comes down to 0.9, and then we'll say we are signing off. Okay. But remember, we are signing off of acute kidney injury with patient developing fibrosis in the kidney. So this is the piece of data that really shows you that you may have a complete clinical recovery of acute kidney injury, but you may have a histopathology which is actually showing progression to fibrosis. So now just think about it. If you have repeated episodes of acute kidney injury, the patient has ventricular fibrillation, right? His AICD didn't fire, and then he has another episode of cardiac arrest, or patient gets perforated diverticulitis, and then he comes into sepsis as another event, all within a period of 3 to 6 months or 9 months or a year. Every one of them is going to cause this kind of leave this residual fibrosis in the kidney, which leads to the reduction in the GFR that you are seeing. So this is a beautiful piece of paper really showing that phenomenon that is happening. So this is the point I want to mention, that what is happening is in this kidneys, which is worsening of the fibrosis, as you see here, with all the straining for fibrillin and smooth muscle actin, but there is also significant worsening of inflammation. These are macrophages, and then, inflammatory macrophages, INOS positive, and then a lot of lymphocytes also present in the kidney. So we don't biopsy the kidney. How many times we have biopsied a kidney which has recovered from AKI? I would say 0. So this is what is happening in the kidney, so this at least something to keep in mind. So anyway, so the consequence of the tubular all the necrosis, necroptosis, ferroptosis, and all that we saw. And then subsequently it leads to an inflammatory process that is happening, which in turn secretes various factors. And then, there is worsening of fibrosis. That is what we are seeing in this kidney. So now, normally when we think about inflammatory cells and persistence or worsening of chronic kidney disease, we tend to think about macrophages very commonly. Maybe we'll think about dendritic cells. That is one of my laboratory work during my fellowship. We think about a lot of work on lymphocytes. But these recent data actually show a very important role for natural killer cells in the kidney. So this is the third most common subset of inflammatory cells. They isolated in the kidney after acute cardiorenal syndrome. So something to think about. And there's a beautiful paper here. What they showed is that, NK cell infiltration preceded expansion of the fibroblast in the kidney. And not only that, they went on to show that if they are able to administer granzyme A, which is actually a mediator that comes from the natural killer cells, it actually stimulates fibroblasts to proliferate. And then they went on to show that if you block granzyme A signaling in mice, you're able to attenuate fibrosis development in the kidney. So now we have a new target to think about. Maybe we need to inhibit granzyme A or natural killer cells. So there are many, many other factors. For the brevity of time, just to keep the focus. And so I'm not covering the roles of uremic toxins, gut microbes, brain-kidney axis, stem cell therapy. There may be myriad of other kind of hypotheses and factors which may be relevant in AKI to CKD progression. So now we saw a lot of mice data. And then we fill that with some of the relevance for our clinical practice. But then, it wouldn't be good if I didn't bring any human data. Fortunately, we have some human data that just got published in Nature in 2023. So here they took a comprehensive atlas of both healthy and injured renal cell states. And it's more than 400,000 single cell nuclei data gathered from 3 major consortia: Human Biomolecular Atlas Program, KPMP, and then Human Cell Atlas. And then healthy reference were from 45 individuals who were healthy. And then also they had biopsy of 48 patients suffering from acute kidney injury or chronic kidney disease. And then they did in-depth, transcriptomes and omics, and then multiple immunofluorescence studies to really define the intricate cellular status of what is happening in the kidney, human kidney, after acute kidney injury. So in that, they saw a lot of very interesting thing, but one thing which really was a surprise. It turns out one of the signature which gets activated in acute kidney injury is not just proximal tubular cells turning inflammatory. It's actually the thick ascending limb of loop of Henle. So this was something loop of Henle signature for the first time, right? So this is why, you can't apply all the mice data to human, there is a difference, Mice data does give a clue. You have to do human research. And so essentially they found that there is a maladaptive change that's happening in the loop of Henle. And they found specific factors like, TRAP2B in the mid-repair stages of the distal tubules, So essentially, the thick ascending limb of loop of Henle signatures were significantly associated with progression of kidney disease. So now, if anybody ask you a question, what are all the factors in the kidney after acute kidney injury that are important for progression to chronic kidney disease? You must say that proximal tubular cells turning inflammatory. Now we have this paper from Nature 2023, which clearly shows a role for loop of Henle in human kidney biopsies turning pro-inflammatory. And then we have lots of data on varied type of inflammatory cells playing a very important role. And of course, fibroblast. But eventually the loss of podocytes and glomerulosclerosis and all that happens in the kidney. So this is the thing, this is the essay question for the DM graduates here, for the pathogenesis of molecular pathogenesis of acute kidney injury, and so something to keep in mind. So this is again showing that pictorially the importance of loop of Henle. So now a little bit about therapy. Last 3-4 slides I have about 4 minutes. So, so essentially, can you inhibit ferroptosis to prevent renal fibrosis? That's the next question. And then it turns out rosiglitazone, Avandia, which is no more in use or very little in use, is a very powerful inhibitor of ferroptosis. So in this study, what they did is they went ahead and used this in a mice model, and they actually showed that the amount of fibrosis is reduced after unilateral ureteric obstruction when they gave this mice Avandia. And they also show that there is reduction in ferroptosis markers, which they measured here. So now the second interesting preclinical thing that is coming up is inhibition of endothelin A. Here they used the endothelin A inhibitor and then went on to show that actually, this is in human AKI. So what they did is that they took human AKI and they showed that the levels of endothelin 1 in both plasma and urine fractional excretion is pretty high in acute kidney injury. And then they went to animal model to really show that if you're able to inhibit endothelin endothelin A, then you have the orange one, you're able to actually protect the kidney, cortex medulla, you reduce inflammation and improve the microvessel density in the kidney. So this may be something that you may end up seeing. So there is actual clinical data. Do you have any clinical trial for preventing progression of AKI to chronic kidney disease? Nothing. But this is the only database type of data that's available from veteran study, where they actually showed that if you're able to start SGLT2 inhibitor after the onset of AKI, and here retrospectively they are looking at it, those who started SGLT2 inhibitor after AKI versus those who didn't, and they went on to show that there is a significant reduced hazard risk in various models that they tested. Those who started SGLT2 inhibitor after an episode of AKI, they had reduced chronic kidney disease. So if there is any little bit evidence for any agent based on human data, this is the only one. So now you may ask a question. We spoke about a lot of biomarkers to predict AKI, but are there any biomarkers that can say that my patient is unlikely to get acute kidney injury? So these are negative biomarkers of acute kidney injury. It turns out there are two biomarkers that you can test that, if high, would say that the kidney of your patient is likely to be protected from acute kidney injury. So these are called negative biomarkers. And the two are essentially uromodulin and, very surprisingly, epithelial growth factor. So if a patient has high urine epithelial growth factor, then there is a very significant reduction in the risk of postoperative acute kidney injury. So again, these are things that need to be replicated, tested in large samples and so on and so forth. But I just want you to think about this. When you talk about biomarkers, always think about negative biomarkers for acute kidney injury and CKD progression. This is the paper which actually showed that if the urine epithelial growth factor is high, then the hazard ratio for CKD progression is actually 0.83. So one little bit snippet that we normally think about AKI, CKD progression, dialysis, cardiovascular risk. But this paper, which was published recently, has actually shown that people who have AKI, who progress to AKD and chronic kidney disease, have increased infection risk. Because remember, when you have a progression of acute kidney injury to chronic kidney disease, it is actually causing a systemic effect. And there is a lot of changes in the immune landscape, not only in the kidney, but in the systemic landscape as well. So that probably explains the increased risk of infection that you're seeing in these patients. So that kind of takes me to the summary of my talk. So the injury repair proximal tubules and thick ascending loop of Henle both play an important role in AKI to CKD progression. Inflammatory macrophages and lymphocytes we know from before, and more recently, natural killer cells have been shown to mediate propagation of fibrosis. Negative urine biomarkers, high urine epithelial growth factor and uromodulin are negative predictors of AKI to CKD progression. Preclinical studies show promising benefit from ETA, endothelin A antagonism, as well as inhibition of HMGB to protect from AKI to CKD progression. Some suggestive database-driven clinical data indicate post-AKI initiation of SGLT2 inhibitor may prevent progression of AKI to CKD. Definite confirmation will require randomized controlled trial. And in terms of mechanistic studies, what holds the most promise in terms of future clinical testing and all that is ferroptosis inhibition, maybe something that may hold the future for preventing the progression of AKI to chronic kidney disease. So I'll stop here and I'll show you this picture, which is actually, this is my walk, in Indian Institute of Science. And these are like beautiful Gulmohar trees and, a lot of science buildings on either side. And it's a very beautiful and inspiring campus. You must visit the Indian Institute of Science. And this is the Indian Institute of Science Medical School that is coming up. And 40% of the building is already complete, and we should have 832-bed hospital ready by January of 2025. We are recruiting outstanding faculty to join our program in not only nephrology but various specialties. Please pass the word of mouth, and we'd love to consider it. Thank you.
Thanks a lot, Dr. Swami, for mind-blowing cover on AKI to CKD progressions. Really, it was mind-blowing, and everyone will appreciate this wide coverage on this. Everyone will be happy with the cover of the apoptosis, ferroptosis, and necroptosis. So these are three important events which you have described, and you have given some clues on future implications of the therapeutics like osiglitazone, SGLT2 inhibitors, endothelin receptor antagonist. Definitely, many of the clinicians have always the fear of using SGLT2 inhibitors when they have AKI, because they think that there will be natriuresis, patient will be dehydrated, and there will be precipitations of the AKI. So they would be interested in knowing this, how much time after recovery you need to switch on the SGLT2 inhibitors. Right. And then endothelin receptor antagonist, again, there was a problem that many of the clinicians are very much hesitant in using this kind of the drugs because of the, again, there will be some physiological decline in this GFR, and then they are scared of hyperkalemia, whether this would be there. So when to reinstitute these kind of the medicines when the patient recovers. So that is the for clinical purpose, and a lot of cover on your HMGB1, Indian hedgehog, and extracellular vesicles has been shown in many of these small studies, in particular in rat models, showing some protections in many of not only acute kidney injury, many of the other kidney diseases like this. So what do you think about the future perspectives of the extracellular vesicles as a therapy?
I think all are very good questions. See, we cannot have any recommendations. That's one thing very clear, because these are registry-based retrospective data, but a very good suggestive evidence. Something for us to plan a good study. So I would say, we need an excellent study for SGLT2 inhibitor initiation after AKI, and then see what happens to renal function in 6 months or a year or things like that. So that's what that needs to be done. But then if you ask me, not as a clinician, but as a scientist, I would say that you may want to initiate SGLT2 inhibitor probably around 1 to 2 weeks after acute kidney injury. Because, that's where you're seeing that although creatinine is improving and all that, the persistent epithelial inflammatory signature, kind of starts establishing. Then they start making fibrosis and everything. So maybe that may be the time frame, where you want to initiate that. So of course, with careful attention to hydration and careful attention to risk of infections. If AKI to CKD causes increased risk of infection, then SGLT2 inhibitor is not going to make it any better. And that's something to keep in mind. I agree with the endothelin 2 receptor antagonist as well. I think you need to weigh the risk and benefits. You need good clinical trials, to really see that, what are those kind of benefits and all that. But I think the big take-home point, for our trainees in particular, I would say is that when you sign off a patient having recovered from acute kidney injury, you never think that kidney is recovered. Kidney does not recover. It leaves a scar. It leaves fibrosis. That's something to really, really think about. When you see a patient next time, and when you see a patient again next time, don't think all ATNs are the same. They are very, very different, based on the data that we presented here. And if I were to think about futuristic, I don't know if it is my own bias I would say ferroptosis was the key.
Questions from audience?
Yeah, congratulations for a masterly exposition on AKI. My question is regarding, we all know that TGF beta is one of the markers for fibrosis. As you said, that's what is happening at the molecular level. And our oncology colleagues, like always, they are way ahead, and they have, the TGF beta inhibitors are now in use in oncology. So any evidence in experimental animals about the use for retarding fibrosis and any biomarkers? The other limitation is that, as you rightly said, that once we sign off, we are totally limited by the lack of any biomarkers, simple biomarkers that we can use.
Exactly. Yeah, I think, those are excellent questions. There are a lot of studies blocking the TGF beta receptor pathway in mice, showing that it protects from fibrosis. There is also data on blocking connective tissue growth factor, CTGF pathway, which is again connected to the TGF beta pathway to protect from fibrosis. And in terms of human data, Chirag Parikh's group recently published an excellent paper. They went to KPMP and they looked at molecular signatures of patients, where the transition is happening in the proximal tubular cells. And in that, they found actually TGF beta receptor R2 is the one which is most overrepresented. And then they went ahead and measured that in actually patients to show that it actually predicts the progression of AKI to chronic kidney disease. So I think all those there are no clinical studies, in terms of things. I mean, other molecule that is of interest, again, targeting the TGF beta pathways, perfenidone. Perfenidone is something people have used for various types of fibrosis and things like that. But the problem is that there are no good solid studies. I mean, what we really need is, here we have a patient who had a partial recovery of AKI at 2 weeks after acute kidney injury. We have nice definitions. And during the early phases of AKD, 1 week after the injury, but then within the first 2-3 weeks of AKD, we need to do good clinical trials, to really see that, we are able to see that there is an improvement and recovery of renal function.
Thank you so much, sir, for that thought-provoking lecture. You have acute glomerular nephritis on one side and you have acute tubular injury on the other side. But in the middle, there is the acute tubular interstitial nephritis. So we have quite a number of patients actually where we have followed up. Some of them, the serum creatinine will become normal spontaneously. Some would need a bit of steroids. Some may even need MMF, and some will just not improve. So do you think that from these studies that you've shown us, we should think of clinical trials on treatment of ATIN? And if there is if the trials are there, would uromodulin and all these other help in that also? Can we extract that? And the other thing is that if we're doing clinical trials, should we stress on the steroids and the immunosuppressants that we use for the GNs, or should we focus on whatever you have just told just now?
Okay. I think it's a very good question. So see, a lot of times the confounding part is this, right? When you biopsy a patient with acute tubular interstitial nephritis, see, pathologists call this acute tubular interstitial nephritis. They see a lot of lymphocytes. They see some macrophages, maybe some epithelioid cells, occasional eosinophils. And but then they'll also report, okay, there are some plasma cells, and there are some streaks of fibrosis, right? See, the problem is this conundrum goes back to transplant also, IFTA, right? Where there is a fibrosis-associated inflammation, right? And so some of these chronic inflammations are difficult to treat, they don't respond, And so, for example, acute interstitial nephritis, once it gets established for a period of time, you come back and treat them with the steroids, they don't respond well. So I don't know if that is one reason why you are seeing those patients, where there is a differential response. But I agree that we are so far in our investigations limited ourselves to morphological evaluation of inflammatory cells and kidney biopsies, rather than going and actually characterizing what those inflammatory cells are in the kidney. See, for example, right, inflammatory cells are not limited to the population that I mentioned. There are a whole group of cells called innate lymphoid cells, ILC1, 2, and 3. NK T cells, more than NK cells. So there are so many other different types of inflammatory cells which could be dominating in a particular patient and dictate how they respond to the treatment. So we need to have a good, deep immune phenotyping of these patients on the biopsy and also in the peripheral blood to really understand, like, what they are. And then we see, okay, if they're responding to steroids, this is the signature I'm seeing. If they are not responding to steroids, this is the signature I'm seeing. I think that will be a starting point, to really know how to approach these patients.
Thank you, Kara. Quick question. Yeah.
Thanks, Dr. Swaminathan, for a wonderful talk. So I'm here to share, our experience in the sense that you mentioned that ferroptosis is something that is high on cards when you're thinking of progression of AKI to CKD. So at PGI we have a AKI cohort, and we were fascinated by work which is done by Dr. Anupam Agrawal's group and Dr. Kanwar in Chicago, where he's looking at NEOX, which is in a way linked to ferroptosis. And when we looked at our data, we realized that in addition to urine and albumin excretion rate, the independent predictor which came out for progression to CKD was serum NEOX level. So that's something that I wanted to share. Thank you.
Thank you. That's it.
Thank you very much. Thank you. We should have the big round of applause for Dr. Swami. And this was really a mind-blowing lecture. Thank you. Thank you very much, Dr. Swami.
Thank you to the speaker, sir, and to the chairpersons. I request you all to move for the felicitation towards the left of the stage. Before entering into the next session, there is a quick announcement, and that is we have a QR code quiz for the trainees and students after the session 5. So stay tuned for further information. With this, we now come to our session 3, and that is on biomarkers of acute kidney injury. I would like to extend a heartfelt invitation to the chairpersons who have always been the driving force. Please come forward and lead us into this engaging and insightful session. I invite on stage Dr. S.N. Mandal, consultant nephrologist from Hyderabad. Welcome, sir. Please put your hands together and welcome the dignitaries. Dr. Raka Kaushal, consultant nephrologist from Chandigarh. Dr. Ajay Singh, consultant nephrologist from Jaipur. And Colonel Dr. Sudeep Prakash, consultant nephrologist, Command Hospital, Lucknow. And I request the speakers to please restrict yourself within the time limits. And over to the chairpersons. Thank you.
Yeah. Now I'd like to invite Dr. Vivek Kumar, who's an associate professor in the Department of Nephrology at PGI Chandigarh. He'll be telling us about biomarkers in predicting AKI.
Thank you, chairpersons. First, I would like to thank Professor Narayan Prasad and the organizing committee for giving me an opportunity to speak on biomarkers. So this was initially supposed to be, 2 15-minute sessions. Unfortunately, the second speaker is not here, so I'll be taking up that role also. But I think a part of it, which is the second part of the second session about outcomes, I think a lot has been already said by Professor Swaminathan. So this is just a brief outline. We'll start with the context. We'll look at what is the current status and where we are going. So when we think of acute kidney injury, let's just imagine about the clinical practice of acute kidney injury. And to start with, let's think of what is important to us as clinicians. Now, if we think of managing patients with AKI, there are certain questions which are important to us. And these questions relate to every phase of AKI in that patient. To start with, we would want to identify patients at risk of AKI before they develop overt AKI. We would want more sensitive markers, better markers for diagnosing AKI. And as of now, the methods by which we diagnose AKI, they do not give us any idea as to what is causing the AKI. So I think that is also an important consideration at our end when we are diagnosing AKI. We would also be interested in identifying patients who would be at risk of progression to severe stages of AKI or needing or developing some complications or needing kidney replacement therapy. And finally, we would be interested in, selecting patients at the time of discharge, especially the ones who are at risk of progression to chronic kidney disease or long-term complications, so that we can follow them closely as compared to those who are at low risk of developing complications in future. I think these are the goals which are practiced to which are common to nephrology practice across the world. Now, let's see how we are doing it in today's time. Now, we are doing it basically as we do for every diseases, that we have a clinical judgment, we have history, we have examinations, and we have certain investigations. Now, specifically in the context of acute kidney injury, this is related to measurement of two parameters, that is serum creatinine and urine output. And in addition, when we are managing patients with AKI, we are resorting to certain risk scores, like for predicting development of AKI, or we commonly do a frucimide stress test to see whether the patient is going to develop severe AKI in the coming days or not. And at times we might even do a kidney biopsy. Now, if you look at the two parameters, the serum creatinine and urine output that we use to diagnose and classify AKI, let's look at their limitations. Now, these are actually markers of function, that is glomerular filtration rate, and they are not markers of kidney stress or damage. They miss, as was shown in the previous presentation by Dr. Swaminathan also, and I also show that slide, that they miss early phases of stress or acute kidney injury. They do not differentiate between between different causes of AKI. And these markers, they are actually not kidney specific. There are a number of extrarenal factors which can produce changes in serum creatinine and urine output with kidneys having absolutely normal structure. So when we look at this scenario, we realize that there is indeed a need for refining the way we are, managing, or I would say diagnosing AKI right from the beginning. And the need is there because AKI in hospital settings is very common. Now, in this context, when we are talking of AKI, the next thing which will come to us, which will come to our mind, is definitely that we have a lot of literature about biomarkers. Now, let's just look at a simple definition of biomarker. Now, this is something which has been subject of various, I would say, conferences, workshops, etc. And we have several consensus documents on how to define a biomarker. But in simplest terms, a biomarker is a characteristic of the body that we can measure. So anything that we measure, as simple as blood pressure, can be categorized as a biomarker. Now, if we just think of a disease right from its preclinical stage to an overt stage where the disease is manifesting and the diagnosis is clear, and subsequent recovery or progression to complications and ultimately death, there are several important clinical objectives in the mind of a clinician. And accordingly, we can have several markers at different time points which cater to specific objectives at that particular point. And we can classify these different kind of measurements which relate with these objectives as biomarkers. And in that context, we can have biomarkers which are diagnostic, which are prognostic. When we are using some kind of therapy which is toxic, you can have some kind of safety biomarkers. Then you can have surrogate biomarkers which relate with long-term clinical endpoints. Now, extrapolating it to acute kidney injury, we see that in the normal steady state, the biomarkers that we would be interested in, that whether do we have a marker which will tell us that the structure of the kidney is normal? Do we have a marker which suggests that the function of the kidney is normal? But in addition, in relation to kidney, we would also be interested in knowing the renal reserve. So do we have a biomarker which tells us about renal functional reserve in the steady state? Now, once exposure for AKI has happened and you have subsequent development of AKI, during the initial phases, we would be interested in knowing, is there a biomarker on the basis of which I can diagnose AKI before I have overt change in serum creatinine and urine output? And that would be, I would say, a stress or injury biomarker primarily. And thereafter, I will have, once I have functional decline, I will have both stress and injury biomarkers as well as functional biomarkers reflecting underlying kidney state. And finally, once the acute insult is over and the patient is recovering, then I would be interested in looking at parameters which can tell me as to what degree the patient has started improving and whether he's going to progress to chronic kidney disease or develop other complications, long-term complications. And in that context, we would be looking at, recovery or prognostic biomarkers. Now, whenever we talk of biomarkers, this is the kind of figure which comes to our mind. You have, different parts of the nephron and, and the various kinds of proteins, peptides or molecules which originate from different kinds of cells and which have been evaluated as kind of stress or injury biomarkers in various clinical scenarios. In addition, we have certain circulating plasma proteins which get affected because they are being handled by the kidneys. So, and a typical example is creatinine and cystatin C. So it's not only that the biomarker has to have an origin from the kidney, it can be something else which is circulating in the kidney, but which is just handled by the kidney. And in this context, let's go back to the definition of biomarker and let's just not restrict ourselves to proteins. Anything, any observation, even a Doppler observation, an ultrasound observation, or upcoming things like exosomes, microRNAs, etc., extracellular vesicles, all these things can ultimately, qualify to be a biomarker. Now, the most comprehensive set of document that we have in this regard, which describes the status of biomarkers in the field of acute kidney injury, was published about 4 years back by ADQI in 2020, which summarized literature from approximately 65,000 articles, and I'm sure that over last 3 or 4 years, a few thousand again would have accumulated. So, but look at the look at the quality of evidence in this regard. So the grade A recommendations are only 2 out of the 11 consensus statements which were given out in this a report of this consensus conference. We have grade A recommendations for only 2. And they typically, align the statements with what we want in clinical practice, and they divided it into 4 categories with respect to AKI risk assessment, prediction and prevention, diagnosis, etiology and management, and progression and recovery. Now, when we talk of AKI risk assessment, typically we are doing it by a combination of, history taking, examination where we look at the, the perfusion, the blood pressure, etc. And then we look at urine output, measure serum creatinine, and look at other exposures in that particular clinical context. Now, in hospitalized patients, 2 important exposures which are routinely associated with, overt or clinical AKI are major surgeries and nephrotoxic drugs. It's important for us to realize that whenever we are talking of biomarkers or additional measurements which would help us refine our clinical skill with respect to establishing a diagnosis, 2 particular categories of patients, patients who are at very, very low risk and patients who are at very, very high risk in the basal state might not benefit from, additional dissection of their clinical state by way of biomarkers. And the biomarkers, when we are talking of risk assessment, it's obvious that biomarkers of acute damage are not going to be helpful. So for risk assessment, what we need are biomarkers which assess renal reserve or kidney fitness biomarkers. And in this context, this is a repeat from Dr. Swaminathan's slide. And in this context, the literature that we have is in relation to the expression of urinary DICOF3, which associated with not only development of AKI post-cardiac surgery, but also long-term outcome at around 800 to 900 days in the study population. The study population in this predominantly included patients undergoing cardiac surgery. And this was something which was also validated in another cohort. So this is, with respect to biomarker, the risk assessment, this is probably the, I would say the representative study that we have. Now, once we have done the risk assessment, then the next thing that we would be interested in, that now the exposure has happened. Now, if exposure has happened, then we would be interested in knowing whether I can predict, because not all exposures will lead to development of AKI, so-called AKI. So is this patient going to develop AKI, and is there a way that I can prevent it? And in this regard, there are 2 or 3 studies. There are in fact several, but I'll just list 3 or 4 which actually make the flow of biomarkers from lab to practice easily understandable and implementable, I would say. The first in this regard is the first study from the PREV AKI group, which was a single center study. And it included patients who underwent cardiac surgery, and 4 hours after surgery, they were subjected to the urinary nephrotic test, which is just an expression of urinary TIM2 and IGF-BP7. And on the basis of that, those patients who had a value which was more than 0.3, they were categorized as having high risk. And in those high-risk patients, they randomized them to receive the KDIGO AKI care bundle. And in the single center study, they showed that there was a 16% absolute risk reduction with respect to incidence of AKI once that bundle was implemented. So the study actually, showed that in addition to serum creatinine and urine output, if you incorporate a stress biomarker and develop a strategy based on that stress biomarker, it can be helpful in preventing AKI in clinical settings. Since this was a single center study, the next step automatically is to, extend it to other centers and see the validity of these observations. So this was extended to multiple centers, almost similar protocol, and the results showed that implementation, though the protocol was implementable, you see, it was they could in the active arm they assessed its effective implementation, and they said that it could be 100% implemented in 64% of patients as compared to 4% in the control arm. But surprisingly, here the implementation of the KDIGO AKI care bundle did not lead to any difference in incidence of overall AKI between the groups. However, it did decrease the incidence of severe AKI, that is stage 2 and stage 3 AKI, and did receive the study showed that it was implementable but helpful probably in a subset of patients and not all. So what this multicentric study showed was that the previous intervention, stress biomarker based intervention that they had previously tested, was implementable and possibly helpful, I would say, because the primary outcome of overall AKI did not show any difference. Now, this was only in the setting of cardiac surgery patients. So then we had another big trial, which was done in patients who had undergone a major abdominal surgery, almost a similar protocol. After surgery, admission to ICU within 4 hours, at 4 hours, they did a nephrotic test and again randomized these patients to, receive the AKI care bundle. And this again showed that with respect to the overall incidence of AKI after surgery, it actually did not help, but with respect to progression to stage 3 or stage 4 AKI, that is a severe AKI, and with respect to, hospital stay and cost, the intervention was effective. So when we look at this data, so this now, further extends this intervention to a clinical scenario which is outside the cardiac surgery. That is a major, patients undergoing major abdominal surgeries. Now all these studies have happened in, strict, I would say, research conditions or research environments where everything is controlled, or you try to control at least a part of the things going around in a patient. Now, this is an interesting study which came out, I think, 2020, where this is retrospective data from a large cardiothoracic vascular surgery center in the US, And what they did was somewhere in 2017 or 2018, they actually implemented the KDIGO care bundle in their clinical practice. It was not done as part of research, but they actually implemented it. And the pamphlet, which is to the, I would say, right of you, just shows that it has all the guidelines on when to measure the nephrocheck and what to do when you get a result which is less than 0.3, more than 0.3, or more than 2. And when they looked at their data and they compared the incidence of AKI in the I would say pre-strategy era versus post-strategy era, they could show that there was an 89% reduction in moderate to severe AKI in patients who were undergoing major cardiac surgery at their center. So this kind of data now shows us that, when you implement these things out of research settings into clinical practice, even then these are effective. So this speaks highly for, at least the use of nephrocheck test for strategy-based implementation, at least in patients who are undergoing cardiac surgeries. So what we can, I would say, conclude from this data set is that if you're using a validated biomarker on top of clinical assessment, because you have to clinically identify individuals who are at high risk first and then do nephrocheck, and then you subsequently reclassify them into further higher risk or lower risk, and you have a strategy which is tailored to that, then it is impactful. It is impactful in clinical practice. But one thing that we should not forget is that we should not forget the context, that it would be applicable only in the population in which it has been studied. If you want to extend it beyond that population, then please, you have to test it in controlled environment. Now, if you are able to, predict AKI and even prevent after an initial exposure and before an overt AKI has happened, then the next important clinically relevant question is, can we diagnose AKI before there is decrease in urine output or increase in serum creatinine? And there is ample data with several biomarkers in this context. And I would take the example of a typical NGAL, and this is a systematic review, pooled analysis of prospective studies. This is an old study, but 2,000 patients, predominantly cardiac patients with cardiorenal syndrome, and it showed that in the absence of an increase in serum creatinine, elevated serum NGAL levels actually correlated with need for RRT association and in-hospital mortality, thereby indicating that the damage or injury biomarkers like NGAL are elevated before you have overt increase in creatinine or overt decrease in urine output, and they can be helpful in identifying patients who are subsequently going to develop AKI. In fact, they already have, because it's a stress or injury it's actually an injury biomarker damage, not stress. Now, there are biomarkers on the base which can help us diagnose AKI early. But at the time of this early diagnosis, is there a way that we can predict that this patient is going to have a severe form of AKI or a mild form of AKI before overt AKI happens? So again, with urinary NGAL, we have data. So this was data from a secondary analysis of a cohort of critically ill children, approximately 178 children. And at day one, the patients, they had a serum creatinine value and a urinary NGAL value, and the investigators, they assessed development of AKI at day 3, which would correspond with the definition of persistent AKI, that is AKI which is present after 48 hours. And what they showed was that urinary NGAL measurements, they complemented the predictive ability of elevated serum creatinine at day 1 to predict severe AKI at day 3. And another observation was that in all patients who had AKI at day 3 and who died, they all had elevated urinary NGAL levels, irrespective of the fact whether their serum creatinine was elevated or not. So in a way, that patients who had AKI and who died, one constant observation in them was not that their creatinine was elevated. The constant observation in this population was that their urinary NGAL was always elevated. So it seems that, based on these damage or injury biomarkers, it's not only that we might be able to diagnose AKI early, but we might also be able to predict the severity of AKI that is going to develop in the subsequent, days to weeks. Now, once we are done with the diagnosis, so we would be interested in the outcomes, and outcomes are, in the context of AKI, as is there for any acute illness, are short-term and long-term outcomes. The short-term relevant outcomes are mortality as well as progression and need of kidney replacement therapy. The long-term are progression to chronic kidney disease, maybe long-term mortality and other complications. Now, this is a secondary analysis of SAPPHIRE study, which was a multicentric study of critically ill patients who were admitted in ICUs. All these patients, they received a nephrocheck test within 12 hours of admission to ICUs, and subsequently it was done every 12 hours for the next 30 years. Importantly, in this study set, they excluded patients who had stage 2 or stage 3 AKI at the time of enrollment. So they had, either stage 1 AKI, or they were absolutely normal with respect to serum creatinine or urine output. And what the investigators showed, the SAPPHIRE investigators showed in this secondary analysis was that, nephrocheck greater than 2 increased the hazard rate for progression to stage 2, 3 AKI or mortality by 1 week from 4 to 10, which, as clinicians, we would say that it's great. So it's helping. And also, nephrocheck more than 2 identified increased risk of death or dialysis by 9 months, even in the absence of progression to AKI stage 2 or 3 within 7 days. So in other words, you see that similar to what we had in the previous study with urinary LGAL, that it's associated with mortality irrespective of the fact whether serum creatinine was elevated or not. So here also we have similar study with nephrocheck in a different population subset, which shows that elevation in nephrocheck associated with short-term and long-term mortality, I would say outcomes, irrespective of the fact whether you had elevated serum creatinine or not. So it seems that there is data to suggest that biomarkers with respect to prediction of outcomes do add value to the traditional outcome assessment that we do with established measures. Now, we know that requirement of kidney replacement therapy or progression of AKI is an important short-term complication. So what about biomarker data which would tell us, which would guide us with respect to actually selecting the timing of kidney replacement therapy, or in those patients who are actually receiving kidney replacement therapy or dialysis, help us decide whether we can withdraw dialysis now or not, as compared to conventional criteria that we use in clinical practice. So unfortunately, there have been several pooled analyses. There are some biomarkers, for example, like blood NGAL, cystatin C, IL-18, again, nephrocheck, which have been investigated for this particular clinical scenario, but there is no final word. So there is promise, but with respect to application in clinical practice, with respect to these particular questions, I think we are nowhere. So at this stage, I think I'm now moving to the outcomes of outcomes related to AKI. So I'll just briefly stop here because we need a change of the, I think, chairpersons, because the second speaker is not here. So yeah, okay. I was previously told that you have to stop in. Oh, there. I think the confusion.
We thank the chairpersons. Sir, please come to the left of the dais for the felicitation. Thank you. As due to unforeseen circumstances, Dr. Arun Kumar is not with us here. So with the expertise of Dr. Vivek Kumar sir in biomarkers, we will also continue the session with him as the speaker for predicting outcomes of AKI and the biomarkers used. And for the chairpersons, it's my privilege to invite Dr. Gulshan Mukhya from Udaipur. Professor Dr. Dharmendra S. Padoria, Professor Nephrology at SGPJMS Lucknow. Dr. Krishnamohan Sahu, Consultant Nephrologist from Patna. Dr. Dhairya Prajapati from Lucknow. We're privileged to have them on the dais. The speaker is well introduced and he's on flow. Thank you, sir, Vivek Kumar, sir, and sorry for the trouble. And he will continue the session. Thank you.
Thanks. Yeah. Yeah, thanks. So with respect to, now we discussed the limitation of serum creatinine and urine output based criteria for diagnosis of AKI. And one of the limitations that we discussed was that it does not give us any clue as to what is the etiology or what is the mechanism behind the AKI. And we know from as clinicians, it's very, very important. We try to, make a guess about it or infer it from various other clinical circumstances and investigations, but it is something which is of relevance to us. Now, one particular category within the causes of acute kidney injury, which has, I would say, both diagnostic and therapeutic implication, other than the usual care that we provide to patients with AKI, is the condition of acute interstitial nephritis. So we all know that in practice, whenever we suspect acute interstitial nephritis, it is something that we consider as an emergency. So in addition to the usual management, which is largely supportive for AKI, where we are just waiting and supporting the organ, we would want to do a kidney biopsy as early as possible, because we know that if it's indeed acute interstitial nephritis, we would want to start the patient on immunosuppression in the form of corticosteroids. Now, till now, biopsy was the only way in which you could diagnose acute interstitial nephritis. But we have had recent, I would say, 2 publications, one of which was referred to by Dr. Swaminathan in his talk, and another one, which both of these are, outcomes of the kidney medicine, precision medicine project in the US. And this study, which came last year from Dr. Chirag Parikh's group, established urinary CXCL9 as a diagnostic biomarker for acute interstitial nephritis. So what they did was that they had a cohort of patients who had undergone a kidney biopsy. They took their urine, which was biobanked, did urine proteomics, looked at differential expression of proteins in patients who had a final diagnosis of acute interstitial nephritis versus other diagnoses, and they found out that urinary CXCL9 was differentially expressed, much higher expression in patients who ultimately went with the diagnosis of acute interstitial nephritis. Subsequently, they validated in other cohort, and they also validated through transcriptomics, they also validated the expression of CXCL9 in human kidney biopsy. So this is the most recent example where, in the biomarker space, now we have a diagnostic biomarker which has helped us, identify etiology or a mechanism for the underlying acute kidney injury. But this is just a start. What we need in this case is more external validation. And since this is just the beginning, we also want development of an easily available and measurable standardized assay for measuring this parameter. We still do not know what is its impact on clinical care, whether it would favorably impact, finally, favorably impact early diagnosis, decision to biopsy, and with respect to decision on therapeutic interventions. And we also need to assess whether any serial changes, because this is just a one-time measurement, whether any serial changes in this biomarker, they have an implication with respect to the therapeutic decisions that we are taking, recovery from illness, or progression in the long run. So this was an editorial comment to this article, which was published in the same journal. And here, to your right is the current approach, where if you suspect acute interstitial nephritis, the only way to go is do a kidney biopsy. And to your left is a proposed algorithm which is based on urinary CXCL9 levels. And if you have very low levels, then you can be, I would say, sure, not exactly sure, but with a high degree of confidence, you can say that you're not dealing with acute interstitial nephritis. And when you have very high levels, you can be slightly more confident that you might be dealing with acute interstitial nephritis. So this was an algorithm which was proposed, but this is something which needs to be implemented, and its actual impact in clinical practice needs to be seen before it can be integrated. And this is the kind of approach which has been tested in the past also, as we have seen in the context of urinary LGAL. There have been studies, the PREV AKI studies, which have shown that it can impact management. But we have certain negative examples also in this regard. For example, we had a CXCL10 as a marker of allograft dysfunction in kidney transplant recipients with respect to a decision to do allograft biopsy or not. But when it was actually implemented in a cohort, in a randomized control trial, ultimately the outcomes in the kidney transplant patients who received a biomarker-based care, they were not better than those who received standard care, and ultimately it did not come in the mainstream. So though it is promising, but until and unless it is tested with respect to its impact on clinically relevant and meaningful outcomes, probably it will just remain a part of research. So when we talk of diagnosis, etiology, finally, I'll just summarize it. When we talk of diagnosis, etiology, and management, it's again a combined clinical, investigational, and biomarker-based assessment, which the kind of data that we have does show that it has the ability to improve early diagnosis, diagnostic accuracy, prognostication, and even uncover mechanisms, as we have seen in case of acute interstitial nephritis. So definitely, with respect to these broad questions, we have scope, but we need more data in order to ascertain its meaningful clinical impact. Now, when we talk of, so I'm just talking of just few single examples, and this is something that Professor Swaminathan alluded to, the most recent paper from Dr. Chirag Parikh's group, where they have actually looked at biopsies from patients with AKI, normal kidney biopsies, and and then they have identified, they did single cell RNA sequencing, identified markers of proximal tubular maladaptation, and subsequently validated these biomarkers in the Tribe AKI cohort and two other cohorts, one cohort of marathon runners and one pediatric AKI cohort. And they came up with this set of biomarkers which seems to correlate with progression to chronic kidney disease in patients who had acute kidney injury. So this is, again, this is something preliminary but very, very seminal work. And again, in this context, what we need to do now is validate it in diverse populations of AKI, and together with other parameters, develop models for prognostication, and maybe we would be able to subclassify the phenotypes of patients in a way that we can tailor treatment to those individuals. And also test if maladaptive mechanisms can be targeted through any therapeutic agent to produce any favorable response. So when we talk of progression in kidney recovery and the context of biomarkers in AKI, there is promise, but as of now, there is insufficient evidence to recommend routine use of biomarkers to guide clinical care post-acute kidney injury. So this is just a snapshot of the table that that was put up in the the ADQI consensus paper. It has a number of biomarkers and their clinical relevance in the different I would say relevant aspects. For example, risk assessment, diagnosis, kidney recovery, and prediction of severity of AKI. So we can go through this. So this just actually summarizes the data in a great detail. And this is something which just came up in Kidney International about maybe a few days back, and this was part of a debate for on biomarkers in AKI, and this summarizes the current status of, I would say, biomarkers which have been through, I would say, most of the stages of validation in particular clinical scenarios. So what I would emphasize here is that we often remember that this is a biomarker, but we forget the clinical scenario. So it is very, very important that we remember that There are biomarkers which have been validated, which have been FDA approved, which are validated by regulatory agencies outside US also, but they are validated for use in only certain clinical scenarios. It is not like this that we can just pick up those biomarkers and start doing them, in every patient with AKI and try to, draw inferences based on that. So what is the promise of biomarkers? So this is how I would conclude that the biomarker is actually introduction of precision medicine in AKI. At every stage, with the, with further refining of, I would say, biomarkers, we would come to a stage where patient is likely to be better subclassified and is more likely to receive appropriate therapy. However, this cannot be realized until we answer this question. For every biomarker, the only one question that we need to ask is, how will the measurement of biomarker at this stage at which I'm caring for a patient with AKI change the way I'm managing this patient with AKI in present? Thank you.
Thank you, Dr. Vivek. Special thanks covering the both lectures, actually. And saving. Now the house is open for the questions.
This KI paper was showing this has been, NGAR has been validated to differentiate between HRS and acute tubular injury. So that is the one subset. There are always you need to think many times. It is very much obvious with the clinical diagnosis also, and many times really confusing and can help out. So that is the one good thing. When you can think of when we are progressing from the AKI to the CKD, which biomarker we should particularly consider that these are the biomarker which you should get from the urine or get from the blood that can predict probably this patient is likely to develop chronic kidney disease. So few has been covered by Swami well, but commonly used biomarker like NGAL, everyone is aware. Like kidney injury molecules, everyone is aware. Epidermal growth factors, that has been fatty acid binding proteins kind of this. Out of all these biomarkers, whether we should use the bundle or you should use in the particular situations one biomarkers. So that is always a confusing question, particularly for the physicians.
Actually, with respect to the discovery of biomarkers which would help us predict progression to CKD, I think the most recent paper from Chirag Parikh's group, this has, I would say, a meticulously conducted and a wide expression of so many proteins, and it has narrowed down on 8 or 9 proteins which significantly upregulation or downregulation of which correlate strongly with future progression. So as I alluded to in one of the slides, that this is preliminary data which is there from one cohort validated in another 2 or 3 smaller cohorts. So what we need now is validation of these biomarkers in diverse cohorts. Now we are not sure whether that would have, whether that the outcome would be positive or not. Now indeed, if the outcome is positive, then the next thing that we need to do is test its impact on clinical care. Until unless we are able to show that it favorably impacts clinical care or helps us identify individuals in whom we are able to offer some kind of care which is over and above the usual care which is being offered to these individuals. Otherwise, what will happen is that what is happening with most of the biomarkers, that when they are being tested in clinical care, they are falling flat. So I think whether the ultimate test of a biomarker is whether it is helping me change my current clinical practice or not. If it is not, then maybe it's just an addition of literature to understanding of why things are happening, but still there is a lot to do.
For paucity of time, we declared this session closed. Thank you. Thank you, speaker. Thank you, audience.
Thank you so much. I invite you all for the felicitation towards the left of the stage. Thank you. With this, we enter our session 4. As we embark on this journey of knowledge and exploration, I invite the chairpersons for session 4 on stage. Please put your hands together for Dr. Deepak Diwan, consultant nephrologist, Regency Hospital, Lucknow. I welcome you on stage, sir. I invite Dr. Shivendra Singh, Professor and Head Nephrology, Banaras Hindu University, Varanasi. Please join us on stage. I invite Dr. Tejendra S. Chauhan, Consultant Nephrologist from Fortis, Faridabad, and Dr. Vishal Punia, Assistant Professor, King George's Medical University, Lucknow. And I again request the speakers to please adhere to the time allotted. Over to the chair.
Now I welcome the next speaker, Dr. Arpana Iyengar. She is Professor, Department of Pediatric Nephrology, St. John's Academy of Health, Bangalore. And I would like to invite her for a lecture on risk stratification and diagnosis of pediatric AKI.
Thank you, sir. Good evening. My gratitude to Professor Narayan Prasad, sir, for having me here today. It was my first time and it was a wonderful feeling to step into this prestigious campus. I'm here to address a very niche area of pediatric AKI, that is risk stratification and diagnosis. 4 years back, in 2020, Stuart Goldstein, often regarded as the father of pediatric AKI, nudged the pediatric nephrology community with this commentary. He asserted that the era of nihilism, which means no distinct meaning or purpose regarding pediatric AKI, was over. It became clear that children could die not with AKI, but from AKI. And the pressing question then was, what proactive steps are we taking to address this? In alignment with his vision in 2021, he spearheaded the inception of the first pediatric acute disease quality initiative, the AKI Compendium, an opportunity I was fortunate to participate in. Since then, numerous publications have surfaced, exploring diverse aspects of pediatric AKI, including risk stratification. And here are key papers that I bring to you fresh from the oven. Let me begin by highlighting the pediatric specific issues in diagnosis of AKI. Firstly, the absence of a baseline creatinine that varies with age from birth to 18 years presents a significant challenge. Secondly, there is scanty research on urine output criteria, which is relevant to this age group in relation to outcomes. Thirdly, AKI is underdiagnosed in hospitalized children, and research on early diagnosis is limited to very specific clinical settings like post-cardiac surgery and the pediatric and neonatal ICUs. Lastly, there is limited understanding of AKI phenotypes in children, a term which has just come up in the recent years. For example, subclinical AKI, persistent, transient, functional AKI, and so on. The diagnosis of pediatric AKI has evolved over years, transitioning from pediatric rifle criteria and Akin criteria in 2007 to the KDIGO in 2012, and then to the PROC in 2018. The quest for improvement continues with the proposed enhanced AKI criteria currently under consideration. Briefly, P-rifle was adapted from the adult rifle criteria with creatinine clearance calculated from the Schwartz formula along with urine output. Akin was proposed as a modification of the P-rifle to improve the diagnostic sensitivity to small changes in creatinine. And KDIGO, as you all are aware of, is universally widely studied and accepted as a standard criteria as it's associated with several clinical outcomes. However, to improve the diagnostic specificity of KDIGO, a Chinese group proposed the PROC, which is Pediatric Reference Change Value Optimized for AKI in Children. So here the reference change value of creatinine is estimated from a normative data, which is based on the age and the initial creatinine level in children without kidney disease in those who had 2 creatinine levels estimated in the last 30 days. And this is a comparative table where you see the 3 criteria, the KDIGO, the P-rifle, and the PROC. And I'm just using the comparisons between the serum creatinine-based criteria. Using the PROC, the incidence of AKI was 50% less compared to that observed using KDIGO. So definitely it was a more specific criteria to diagnose AKI. But the question was, are we in need of a highly specific criteria or a highly sensitive criteria to detect early AKI? On one hand, we are looking at early markers before the creatinine can rise, and PROC is actually doing the other extreme. It's a very specific criteria. In 2022, Goldstein and his team proposed the inclusion of urine NGAL to serum creatinine to improve the precision of early AKI diagnosis in critically ill children. Here's the framework that you see, underscores the utility of the tubular injury biomarker in defining AKI phenotypes. When the NGAL is positive, as you can see here, but the creatinine is not raised, then it is subclinical AKI. And if NGAL is negative with the raised creatinine, it could be reversible, transient, or functional AKI. Accurate identification of children at risk for AKI is critical and involves patient factors, disease factors, event factors, and, like the previous speaker said, kidney fitness. And these are the distinct high-risk diagnoses and exposures that increase the risk of acute kidney injury in hospitalized children. Prematurity, low birth weight are some of the high-risk kids, along with congenital heart disease, transplantation, and exposures like infection, sepsis, nephrotoxins, and cardiopulmonary bypass. Now we come to yet another important issue. What are the novel AKI risk stratification or prediction tools for children? Here is a list, and I shall shed some light on each of these tools. The renal angina index, fluid overload-based scores, biomarkers, furosemide stress test, machine learning tools, and e-alert system. Talking of prediction, let's address this question. Which critically ill child will develop stage 2 to 3 AKI within 3 days after ICU admission? So again, Goldstein and his team derived this index, the renal angina index, to predict subsequent AKI by identifying 3 risk groups: the very high risk, and the moderate risk. The assessment is done within 24 hours of admission, and the risk criteria is given a score. You see the 2 boxes here, the risk criteria based on ICU admission, transplant, mechanical ventilation, or inotropic support, and another box which gives you injury criteria based on creatinine and percentage fluid accumulation. And once you get the scores for these individual boxes, you multiply them, and the total score should be more than 8. That's the cutoff used to identify AKI on day 3 of admission. A meta-analysis of 22 studies revealed better specificity of renal angina index. I'll come to that in a bit. Before that, we have 4 studies from India, 2 from Delhi and 1 from Ludhiana, that add evidence that the renal angina index more than 8 is a good predictor for AKI in critically ill children. However, a study from AIIMS, Delhi, further characterized the renal angina index cutoff to more than 12 and more than 20 to predict severe AKI at day 3 and day 7 respectively, and also was useful to discriminate the need for dialysis. This was the meta-analysis of 22 studies, and then you can see here the specificity from 77 when we used the renal angina index, or when you combine the urinary NGAL and renal angina index, it improved the specificity from 77 to 89%. Moving to the topic of biomarkers, which we have just heard a lot in the last session, Goldstein again and group in the AKI CHIRUP study identified unique biomarker combinations on admission that predicted distinct day 3 AKI severity phenotypes. You saw one figure from that paper, and this is the other figure that is related to outcomes. And you can see here that if you have a positive biomarker in the absence of serum creatinine, that is urine NGAL positive and serum creatinine negative, that is a second group of bars, a proposed state of subclinical AKI appeared to be associated with worse outcomes of mortality and day 3 AKI compared to the group where the tubular injury biomarker was negative. A meta-analysis on 92 studies revealed urine NGAL, the liver fatty acid binding protein, and TIM2 in combination with IGF-BP7 and cystatin C to have good diagnostic accuracy in recognizing early AKI. But these were majorly used in the setting of cardiac surgery or alongside the renal angina index. We know that fluid overload is a critical component of outcomes, and this is the score, the fluid overload kidney injury score, that incorporates fluid overload severity and nephrotoxic exposures to the P-rifle criteria. And this score has been associated with various adverse outcomes. Here is a study with 150 critically ill children where combined fluid overload with creatinine was used, and as you can see here, those with fluid overload had worse outcomes irrespective of the AKI status. They had longer length of hospital stay and higher odds of mortality. The next tool studied was the furosemide stress test. The response to a single dose of IV furosemide in terms of urine flow rates have been studied in children after cardiac surgery, in infants, neonates, and found to be an effective predictor of AKI and other related outcomes. A recent study from AIMS with 51 children with AKI stage 1 and 2 proved that non-response to the furosemide stress test had a high risk for day 3 AKI and need for dialysis. At this point, let us pause and take a look at the opportunities of using these tools as clinical decision supporters. We have evidence for successful clinical decision support systems with the Ninja and the Baby Ninja, that is nephrotoxic injury negated by just-in-time action. In pediatrics and in neonates, Goldstein proposed his algorithm for children needing CRRT. And as you can see here in the Taking Focus trial, he integrated the renal angina index, urine NGAL, and also the furosemide stress test to help clinical decision-making on the initiation of RRT. The next tool is the machine learning tool. We have a decent number of studies on various predictive models for pediatric AKI in non-critically ill children, in critically ill children, neonates, and a good prediction for severe AKI was observed that outperformed even the renal angina index. Well, a short time window for the intervention between the prediction alert and the diagnosis makes it challenging for giving a good window for intervention, and false positive rates are also a concern. A recent paper from the Lancet Discovery Science section revealed a prediction model of 8 factors. So you see these 8 factors on the right-hand side. Use the machine learning algorithm to identify risk for AKI. So this needs more study, but it's just showing that the machine learning models can be useful as a clinical decision support system. E-alerts have been studied in pediatric AKI with inconsistent observations. Here is the complete list of studies showing a reduction in the incidence of AKI, reduction in creatinine monitoring in few, but increased creatinine monitoring in some, no reduction in the incidence of AKI in some. So basically the findings are inconsistent yet. Before I conclude, here are fresh ideas proposed by the PADKI group. Efforts are underway to identify and characterize unique subsets of AKI in children through phenotypes or endotypes, which means subsets that share a common biology or a pathobiology. And also concepts of identifying the right therapy for the right patient, which is called enrichment. And this enrichment is crucial in the heterogeneous disorder like AKI. Enrichment can be prognostic enrichment through the AKI risk stratification use, or predictive enrichment, which is identifying a particular phenotype that is going to likely respond to a specific therapy. So enrichment is going to aid in identifying appropriate AKI therapies in future. I end with this algorithm that succinctly summarizes the future approach to pediatric AKI. Integration of e-alerts to risk assessments, use of prediction tools for early detection, categorizing AKI into phenotypes that guide monitoring and early intervention are here to stay, while well-designed research in this regard will pave the way forward. Thank you very much.
Very informative, I rather would say thought-provoking talk by you. We other nephrologists usually lack this type of knowledge in the, especially the age group, because we usually deal with the adult patients. So very informative and thought-provoking. Any questions from the audience?
Definition. Using a new definition compared to the
Yes.
definition. So why do you think that is really useful? Because we want to detect AKI early.
Exactly. So the Chinese group in 2018 came up with this PROC to prove that they wanted something more specific, the so-called true AKI. And in response to this, Stuart Goldstein wrote an editorial saying, are we really looking at a perfect mousetrap? And by looking at more and more perfection, we will never be content. So what is our need is to detect AKI early. So we need a criteria that is more having high sensitivity than being more specific. Because the comparative studies have shown that the incidence of AKI detected is 50% less than KDQ. But are we happy with that? That is a true AKI probably, but we are not looking at a full-blown AKI. We want to capture AKI early. So that is a problem with PROC. Thank you very much.
Thank you, ma'am.
Thank you, ma'am. And I also thank the chairpersons for their precious time. I request you all to please proceed for the felicitation towards the left side of the stage. Thank you. Moving further, we have chairpersons for this talk, and I'm delighted to invite on stage Dr. R.G. Singh, consultant nephrologist from Varanasi. Welcome, sir. Dr. Vinay Rathore, Associate Professor, Nephrology, All India Institute of Medical Sciences, Raipur. Dr. Anand Banka, Consultant Nephrologist from Gorakhpur. And Dr. Monica Yacha, Associate Professor, Nephrology, SGPGIMS, Lucknow. We will be taking up the discussion at the end of the session, and I also request the speakers to please adhere to the time. Over to the chairpersons. Thank you.
At the very outset, I extend my heartfelt thanks to Professor Nayan Prasad for organizing this wonderful CME. Now, due to paucity of time, I'm going to invite Dr. Darshan Rangaswamy. He's going to speak on kidney support and extracorporeal therapy in children with AKI. We heard a lot about definition of biomarkers. Now, what extracorporeal support we can give? Dr. Darshan is going to cover. Dr. Darshan, please.
Thank you, Chair.
It's a hard act to follow after Dr. Arpana. I thank my alma mater for inviting me. So, kidney supportive therapy. So we'll get into the action now. We have seen how to diagnose. Let's get into the action now. So I'll be more of practical aspects. There'll not be much of theory. No studies, not many studies would be quoted. It would be more of practical day-to-day. When do you plan to start the renal replacement therapy in the kids? So the next 15 minutes, what I do is, I get a call from the ICU consultant saying that a kid is admitted and I've diagnosed that he requires a renal replacement. I've looked at all the biomarkers, I've done all the furosemide stress test, I've done the renal angina, I've done what all we have heard in the last 2 hours, and I've declared that this kid needs a renal replacement therapy. So they call us and we are called into the action. So the next 15 minutes, I'll just talk through why a separate session is required for RRT in kids. We'll also look beyond the conventional indications, what necessitates starting RRT in kids. We'll see what are the available devices and the catheters which are available in India. And overall, my experience is basically with the Baxter Prismaflex. I've not used much of Fresenius CRRT machine. So it's mostly with the Prismaflex from the Baxter we are using. So I'll share my experience with it. So with a mortality of 40 to 45% for children on RRT, should we even start it is another question what the family asks. So we'll just go through each one of these aspects and try to see how best we can improve the care of the kids. So let's start with some of the unique considerations in the kids. So you can have a kid who is who weighs 2 kg and you can have an adolescent who weighs 80 kgs. So there is a wide range both in terms of size, body surface area. So one size doesn't fit all. So you need to make sure that you adapt yourself and you have all the necessary tools, necessary devices with you, which can serve the kids. Second thing is, what is the indication in them and what is the rapidity at which you need to start the renal replacement therapy? There are certain unique considerations such as the urea cycle defect, amino acidemia, inborn errors of metabolism, where the hyperammonia is life-threatening and you may have to initiate renal replacement therapy, and you may want to initiate a RRT which can get into rapid clearance mode rather than the slow clearance, especially with the PD. So you want to be more aggressive with it. Also, we have a very large hemato-oncology unit at our center who wants CRRT to prevent tumor lysis. I mean, anticipating tumor lysis, hyperphosphatemia. Hyperuricemia is taken care by rasburicase, by hyperphosphatemia is mostly not taken care. So they want us to start. So they even ask us to put a line much prior before giving chemotherapy, and they anticipate us to start. So these are certain other indications where we start renal replacement therapy in the kids, other than the conventional indications like fluid overload, acidosis, uremia. These are the conventional indications. These are some of the additional investigations. The other important thing is what are the availability at your center, whether you have adequate staff, you have technicians who are trained, whether they are tubings, dialyzers available to you. Most of the centers, especially tier 3 cities, are difficult to source it, and they may find it difficult to even get dialysis catheters there. So finally, it's the affordability challenge. Not everyone gets the luxury of working in SGPJ, so most of the kids have to pay for their own treatment. So the affordability, the nutritional challenges, varying thresholds for tolerance. We keep stretching. Okay, let's not, kids tolerate hyperkalemia well, so I don't start it. I'll try to medically manage as much as 6.5, 7, even if the ECG changes are not there. So we often keep delaying dialysis in them, but we know that fluid overload, if you delay every 1% rise in fluid overload, has an increase in mortality in kids. So finally, it's the willingness to accept the challenge, come in the middle of the night. Most often the residents may not be able to get a line. You have to be there in the thick of the action. You have to put the line, and that's where you're called for. So let's discuss the type of renal replacement therapies which are often chosen. One is the peritoneal membrane, chosen in the kids, especially if they are in the infants less than 10 kg, or the vascular access based. Either it is the CRRT or the prolonged intermittent renal replacement therapy. That is the PIRRT, that's the SLED. So the goals of the therapy is what is important. Why are you doing it? For example, hyperammonia, you can't rely on PD. So the goal of the therapy, the patient characteristics, what is the weight and the body surface of the kid? And second, and the third is the center experience. What are they good at? So all these things define what is the type of RRT I'm going to choose in my kid. So the prospective pediatric CRRT registry from US spoke that kids who are started on CRRT less than 10 kg had odds of survival of 43% compared to them starting with more than 10 kg. So that 10 kg was the benchmark at that time, but things have improved after that. So the most important category is the weight. So let's divide it into three: less than 2.5, 2.5 to 10 kg, and more than 10 kg. So this is the criteria what usually Western world follows. So I mean, anyone who is less than 2.5 is usually goes for the PD. 2.5 to 10 goes for the newer machines they have at their disposal, and more than 10 kg is what the conventional. They can even go for the intermittent dialysis. So at my practice, I usually divide them into less than 8 kgs, 8 to 20 kgs, and more than 20 kgs. This is what I follow. So as majority of the physicians here are adult nephrologists, and we have been practicing adapted CRRT till now. What's an adapted CRRT? We have an adult machine. We are trying to fit the kids into that. So that is adapted CRRT, what we have been doing. So some of the challenges with an adapted CRRT is you don't have the pediatric dialyzers, you don't have the pediatric tubing. So what we try to do is we try to prime the circuit. There's a lot of ultrafiltrate, which is not controllable. The vascular catheters cannot support the blood flow required for this adapted CRRT. The tubings are bigger, dialyzers are bigger, your blood flow is not generated by the vascular access. And the hypothermia is more common in adapted CRRT machines, the adult machines which are used for pediatric RRT. So these are some of the complications of using adapted CRRT, but the advantage is our technicians are more familiar with it. There is a high clearance rate which is achieved, and most of us are comfortable because we have used this for years together. So the experience is what we have in terms of adapted CRRT, but there are many challenges with it. What the Western country has, what people in US or UK do have is the carpidum, which was invented by Ronco in 2012. In 2013, Aquedex system came, and in 2014, the Newcastle system came. So all these could be used in kids below 10 kgs. So this is the carpidum, this is the Aquedex, and this is the Newcastle infant dialysis system. So this is just what I'll just try to highlight, that this is what is available in India, and this is what I am using at my center. This is all probably, I mean, if someone goes to train in either US or UK, you get to use these systems. So what I use is the HF20. This is from the Baxter. So if you could see, the priming volume is 60 ml, and the dialyzer surface area is 0.2 meters squared. And we can do, the ultrafiltration error is less than 1%, and you can do any of these things. So the advantages of having these system, that is the pediatric specific system, is you can have a variety of blood flow rates, you have warming systems in them, and you can achieve accurate ultrafiltration controllers with them. We know the traditional challenges of peritoneal dialysis: slow clearance rate, can't use it, especially if there is an abdominal surgery. Ultrafiltration is unpredictable, clearance is unpredictable, but it is advantageous, especially in kids and resource limited settings. PD works well. So with this, in case of ultrafiltration, the newer modification is the continuous flow peritoneal dialysis. I wouldn't talk too much into this because we are not practicing at our center. So then if someone wants to follow peritoneal dialysis in AKI, the ISPD came out with the guidelines in 2020. I'm just going to highlight the salient features, which is practically important. If you're placing a rigid catheter, make sure you take it out by the 3rd day. Don't keep it for more than 3 days. If you're using improvised PD catheter, that is not centers who cannot have access to infant PD catheters, we use improvised catheters. At my center, I use intercostal drainage catheters because it comes with a trocar. So I use an ICD, and it is quite easy. 7 French ICD works well. So you can use improvised PD catheters. Recommended to use prophylactic antibiotics prior to insertion, and make sure that you use a closed delivery system and you don't have an open system. This is what the closed delivery system with a Y-shaped system. Currently, even the Y system is also being scarce, and we are not able to source Y system. So we have to use a tri-way, and that becomes an open system. So the source of infection is more common with an open system. Let's go about a case for I'm going to go through 2 cases, which is slightly different from each of them. I'll try to explain what we did different. So this is what the hemato-oncology people forced me to do. This is a three-year-old child who had a B-cell lymphoblastic lymphoma with CNS and bilateral renal involvement. Child had already stage 1 AKI. The pediatric hemato-oncology team suspected they would expect a TLS. They wanted me to put a catheter and keep the child ready as soon as they start the chemotherapy. So he was put on dexamethasone, vincristine, rasbericase was given, and cyclophosphamide was started. So phosphate started to go up, and the team of hemato-oncology in our institute is from Tata, and their experience says that phosphate is bad. So they don't wait for it to cross more than 10. So as soon as they start 10, they push us to start CRRT. And we started CVVHD in the child. And you can see how beautifully the phosphate started to get control with just about 2 days, less than 2 days of therapy. And the child was hemodynamically stable. What you could see is I have not used any PRBC priming in this child. And the dialyzer I used in this child was M60 dialyzer. This is again from the Baxter. This is the PrismaFlex machine. This is an M60 dialyzer. And I'll go to the next case. This is our machine and this is what we are using. I'll just go to the next case, which is about a 1-year-old child with an acute kidney injury, weight about 9.5 kg. That kid was 12 kgs. This is 9.5 kg. I had an 8 French left IJV in situ, but we used priming with this. So the difference between this is the dialyzer is HF20. What I spoke about HF20 in my previous talk, if I go through it, and this is M60. So what is the difference between a HF20 and an M60? I'll just go through it. As I said, I'm using mainly the Baxter system. So M60 basically is approved for more than 11 kgs. It is made up of acrylyl nitrite membrane. This is what the membrane is. The problem with this is if the blood is acidotic, or if you are priming with the PRBC, which is again acidotic blood, the bradykinin gets released, and that can cause severe hypotension. So we use this membrane only when, like for example, I showed the hemato-oncology child in which the ABG was great. I just used it to reduce the phosphate. So while I use my HF20 membrane when the child is acidotic or when I have to prime with the PRBC for the child. In the previous kid, I didn't have to prime the blood, or there was no acidosis in the kid. I used AN69, which is the M60 set. It is much cheaper. HF20 is much expensive. That's the difference. And also the body surface area, if you see, it is 0.6 meters squared in M60 set, and in HF20 it is 0.2 meters squared. So I use it in 8 kilo kids also. Coming to the vascular access, this is the standard table. What is available in India is usually, previously we used to have the 7 French. Currently we are difficult to source 7 French. Currently we have the 8, 8.5 French, 10 French. This is what we are using. Duraflow Meditech comes with 6.5 French. Again, the flow issues are a problem when you use a smaller catheters, especially with the bigger tubings. So let's move on to the prescription. What's the standard prescription, what we use for that? So given the discrepancy between the prescribed and the delivered dose, we should always go for the prescribed dose, which is much higher than the delivered dose. I usually go for about 10 to 15 higher. So the prescribed dose is usually about 30 to 35 ml per kg per hour. When I say that prescribed dose, it is the effluent dose. That is the effluent which is coming out of the at the end of the dialysis. So usually the delivered dose will be around 20 to 25 ml per kg per hour. And in case if you are doing a high volume CRRT, it goes up to 80 ml per kg per hour. This is especially required in cases of hyperammonia. Anticoagulation, this is what we try to maintain. One thing is heparin is the cheapest. Regional citrate anticoagulation is the most expensive. RCA is best with the Fresenius machine because they have 7 pumps and one of the pumps is coordinated with the blood flow. So as the blood flow increases, even the regional citrate anticoagulation dose also increases. It's very well primed for Fresenius machine, not for the PrismaFlex. So we do not use much of RCA at our center. Whenever we require, we use prostacyclin. Prostacyclin is a very good anticoagulant, especially in some patients who have coagulopathy, inherent coagulopathy. We can use prostacyclins. It inhibits by platelet aggregating. We have very good experience in pediatric patients with prostacyclin, especially in pulmonary arterial hypertension patients, and that's what we use. Rest of the things are more academic because they are used in adult patients. So the typical prescription, we have a blood flow rate of 4 to 6 ml per kg per minute. We keep a venous return pressure of less than 200. The rate of replacement fluid is about 2 to 3 liters. This is for not the high dose one. Alternatively, we can just go for 35 to 40 mils. The net ultrafiltration is about 1 to 2. I usually split pre-pump and post-pump if I am using a CVV HDF, half pre-pump, half post-pump. And do not have more than 10% of the extracorporeal blood volume based on the intravascular blood volume. Outcomes, last 2 slides. Outcomes, mortality is up to 80% in post-hematological malignancy if you are using it. Liver disease, 60% mortality. Best outcomes are seen with renal failure patients. In renal failure patients, the CRRT has very good outcomes and mortality is less than 1/3. So the takeaway points are wait, don't initiate because we have seen the high mortality rates. PD for infants less than 8. In future, if infant CRRT machine devices are available, we can have precise ultrafiltration with it. Prepare better, insert a PD catheter at the time of cardiac surgery. This is what we do, we prepare, or we inserted a vascular access before we started chemotherapy. This is how we prepare better. CRRT is preferred method in critically ill and hemodynamically unstable patients in PICU because it helps for gentle fluid removals and prevent episodes of secondary AKI, ensure we have an adequate follow-up of these patients who survive. In CRRT machines using AN69 membrane, make sure that we do not prime the circuit. We can use the blood in the periphery line but not prime the circuit. Yeah, thank you.
Thank you for excellent talk. It's open for house for queries. If there are none, then we may close this session. Thank you.
Thank you so much. Thanks to the speaker, sir, and the chairpersons. And I request the chairpersons to please proceed for felicitation. Now we are entering the third talk of session 4. And for this, I am grateful to invite on stage the chairpersons, Dr. Mufazzal Ahmed, consultant nephrologist from Lucknow, Dr. Vinod PB, professor and head consultant nephrologist, EMH Thrissur, Dr. Sushma Rani, consultant nephrologist, Sakra Hospital from Bengaluru, and Dr. Manoj Dhanorkar, assistant professor nephrologist, assistant professor nephrology, All India Institute of Medical Sciences, Nagpur. I again request the speakers to please adhere to the time as we are running a bit late. So the stage is sparkling with the presence of our chairpersons. I turn the time over to the chairpersons to introduce the speaker. Thank you.
The topic is acute kidney injury in nephrotic syndrome. Speaker is Dr. Sanjeev Gulati, sir, and he's a director from Fortis Healthcare, Delhi. He's a president of Indian Society of Nephrology and specialized in pediatric kidney diseases. And there's no more. He's the most experienced person in the pediatric acute kidney injury. So welcome, sir. So he's going to discuss about the acute kidney injury in childhood nephrotic syndrome.
Thank you, chairpersons, and good evening, friends. At the onset, I'd like to thank Dr. Narayan and team for organizing this annual pilgrimage to this temple of learning. My topic is acute kidney injury in childhood nephrotic syndrome, and this child with acute kidney nephrotic syndrome is actually caught between a rock and a hard place. So he can either go into hypovolemia, hypervolemia, and if that's not enough, he's got several stones being thrown at him in terms of nephrotoxic drugs. So it's no wonder that these patients are actually predisposed to acute kidney injury. Let's start off with a 30-year-old male who now weighs 42 kg. His onset of nephrotic syndrome was 1.5 years of age, and I was a resident at the SGPGI when we started managing him. He was steroid dependent at that point of time. We gave him cyclophosphamide, levamisole, had prolonged remission until in adolescent he started relapsing again. And then one fine afternoon, I got a call from him that he had developed an acute kidney injury, loose stools, dehydration. His peak creatinine had gone to 3.5. He belonged to Lucknow. I advised him immediate admission. Sure enough, with prompt hydration, you can see he resolved the serum creatinine, got down to 0.8. He came to me. We put him on tacrolimus. He had remission, and his subsequent course actually has been pretty eventful. He has had 3 episodes of AKI, every time having loose stools and vomiting, and this time we also had tacrolimus in the background. We ended up stopping TAC. He recovered every time. As you can see, the last follow-up is just recently, April 2024, a normal renal function on TAC and defibrillation. Now, just looking at the epidemiology, and this is adults data, 79 cases of AKI in MCD with a mean age of 58 years in this paper by Smith and Hazlitt. By this publication by Chen reported 277 patients with idiopathic nephrotic syndrome. 34% of these patients had AKI, 18% had rifle various different stages of criteria. So it's far more common in adults than in children. Children, there is varying data. ISKDC study showed that 30% of these children had serum creatinine levels more than 95th centile for age. This is a Polish study which reported a very low incidence, 0.8% of AKI, 8.6% in another study by Rialt et al. This is again the Hiccup Kit database, 8% of nephrotic syndrome hospitalization between 2006 and 2009. This is study from Guwahati by Manjari Sharma showing a very high incidence, nearly 24% in 355 nephrotic children, perhaps because their patients were coming, reporting them to late from distant areas. This is taking you down the memory lane, our own paper published in Indian Pediatrics looking at all AKI. And as you can see, in our experience, about just 2% of all AKIs had nephrotic syndrome. But these are different definitions, so I suspect it will be still higher than this. Now, nephrotic syndrome, as we understand, is a podocytopathy and involves podocyte damage. There is effusement of FIT processes. Filtration barrier is disrupted, leading to massive protein leakage. And this is a background setting that you have to deal with. You can have steroid-sensitive patients or steroid-resistant patients, and there is some immune dysgenicity. We still understand poorly, but steroid-resistant, now we have found a lot of gene localizations. And these respond poorly to steroids. Now, the importance of understanding AKI is that the long-term adverse outcomes following AKI in children underscore the need for better understanding of this complication. As you all know, nephrotic syndrome is an easily treatable disease, but the moment the AKI sets in, it becomes far more difficult to manage with significant mortality and morbidity. These are some of the initial reports reporting 10 to 20% of nephrotic syndromes had elevated urea presentation, 32% in another series with MCD, 40% with FSGS, and creatinine estimation again can be challenging because of its increased tubular secretion and a slow rise. So perhaps it underestimates acute kidney injury. One of the most important factors is that renal dysfunction is generally reversible. So prompt supportive therapy can yield gratifying results. And studies have shown using insulin clearance, there is a reversible impairment of the GFR, partly due to podocyte food procession, which I showed you. The reduced glomerular permeability due to food process fusion decreases the GFR, challenging the traditional underfill hypothesis. So at presentation, a reversible moderate reduction in GFR is there in nearly 1/3 of children or all adults with nephrotic MCD. So you can put it that they are already in a stage of pre-renal AKI. And this is due to multiple reasons. As I said, increased permeability to serum albumin and reduced permeability to small molecules. In adults, there is an additional nephroangiogenesis with concomitant tubulointerstitial fibrosis and
inflammation. So additional GFR reduction in patients more than 50 to 60 years because of the vascular regions are far more common. Endothelin gets activated. You have diuretic induced hypovolemia because of over-aggressive diuresis. The edema of hypovolemia is often interpreted as fluid overload. They can develop diarrhea and vomiting. Nephrotoxic drugs, ACE inhibitors, and angiotensin receptor blockers are always there in the background. So the moment these patients go into volume depletion, as in the index case that I showed you, they develop acute kidney injury, often subjected to contrast media, lithium, sepsis, nephrotoxic. Alternative medications, is something that we have to contend with in our day-to-day practice in our country. And there is a tubular cellular atrophy or necrosis, interstitial edema, hypercellularity, and these are the main causes of AKI. So the proposed mechanisms like impaired filtration from intratubular pressure due to protein casts have not been well supported. Nephrosarcoma theory suggested interstitial edema-induced tubular collapse, and ischemic tubular injury and necrosis has been reported, but underlying mechanisms remain unclear. Now, the tubular injury markers are increased in nephrotic syndrome patients with AKI, and proximal tubular injuries are seen even without renal dysfunction, and they get worsened with AKI. So as I was saying, they're already in a stage of pre-renal AKI. Adults have transient circulatory insufficiency, and studies report increased vasoconstriction, ischemia, which are reversible with resolution of proteinuria, but that's why the incidence is far greater in adults than in children. So these are the various causes of AKI: intravascular volume depletion at one extreme, acute tubular necrosis, interstitial nephritis, nephrotoxic medications like ACE inhibitors, CNIs, infections, and renal vein thrombosis. Hypovolemia is, secondary to complications like diarrhea, vomiting, or excessive diuresis in the context of hypovolemia. So do not interpret the edema as always as fluid overload. Infections, these children being in a state of volume overload are always predisposed to a variety of infections, including peritonitis, urosepsis, systemic sepsis, and gastroenteritis, pneumonia. So which push these children who are sitting just at the edge of the fence into acute kidney injury. And not to forget are the nephrotoxic medications we are increasingly using. ACE inhibitors, ARBs are being used to reduce proteinuria, especially in your steroid-resistant cases. CNIs are being increasingly used again in steroid-resistant nephrotic syndrome, and antibiotics. Higher exposure intensity, longer duration, and increased number of nephrotoxic medications are assured with higher risk of AKI. Some of these patients have not had their CNIs monitored. So if you're using these drugs, be sure that these children receive regular monitoring of their CNI levels. And this is a paper that we published in Pediatric Nephrology years back, reporting tacrolimus-induced HUS, which was an unusual cause of acute renal failure in nephrotic syndrome in a 10-year-old boy who had steroid-resistant FSGS. We used tacrolimus. He developed HUS. We stopped tacrolimus, and he fortunately recovered. So a timely diagnosis resulted in improvement. This is another case report I picked up from a Turkish journal using association with acute kidney injury due to ibuprofen use because of the fever and high cough, something we should always caution the general pediatricians against use. Paracetamol should be the way to go because these children, again I would repeat, are a state of pre-renal AKI, and use of ibuprofen can be disastrous. As I said, renal vein thrombosis, fortunately rare. Acute interstitial nephritis, we have reported in our publications. Acute tubular injury, we have, again, as I said, is there. A rapidly progressive glomerular nephritis can occur, and collapsing form of FSGS can also cause AKI, both glomerular and tubular injury. So if you are encountering such a case, do a detailed history, and most important, a physical examination. Try and look for signs of hypovolemia, which may be there. Cold extremities, high hematocrit, and basic labs are all that are required. So even in remote areas, you can manage this. Kidney biopsy would be required in a very, very small subset if your standard therapeutic measures fail. So if there are atypical features suggesting an alternative diagnosis, active urine sediment suggesting a crescentic nephritis or a rapid progression with the collapsing FSGS, then certainly kidney biopsy is the way to go. Biomarkers, a lot has been said. NGAL is being emerged, as a potential biomarker in AKI, but again, in nephrotic syndrome-associated AKI, this has not been used at all, not studied at all till date. Management is predominantly supportive. Look at underlying causes for volume depletion, infection, nephrotoxic medication. The three common causes, volume replacement may be required if you have volume depletion, particularly albumin infusions. But again, albumin infusions in the vast majority are not required. The only indication is if there is intravascular volume depletion. Recovery is generally the rule. Most patients with mild AKI related to impaired glomerular permeability recover normal renal function as they go into remission of their nephrotic syndrome. So prompt initiation of therapy in an appropriate dosing is all that is required in the vast majority. Because by getting them into remission, you are protecting them from infections which happen in a state of fluid overload. There are also growing concern about the short and long-term effects of AKI in this patient population, particularly with increased exposure to nephrotoxic medications, CNI being the foremost, and it is mandatory now to monitor these children with periodic CNI levels if you embark on this. And obviously, if they develop an AKI, promptly stop this, as I showed you in that index case. Progression to CKD, again, repeated AKIs may increase the risk of progressive CKD, especially in the subgroup who have got steroid-resistant nephrotic syndrome or FSGS, and limited data suggests that a significant proportion of children may develop varying degrees of CKD following AKI. And again, telemedicine, I think, during the COVID pandemic has taught us a lot and came in a big way. This was a time when the parents were morbidly afraid of getting their children to healthcare centers. So we used telemedicine in a big way during that kind of that period, and we were able to triage those patients who required admission. As you can see, 96% of these patients were managed. There was a very high patient satisfaction. Again, following COVID also, we have discovered that you can use telemedicine in a big way in these children, because sometimes the loss of income for these families is far higher. Again, the promptness of therapy is facilitated by use of telemedicine, and this was our publication in JIMA trying to educate the general practitioners. And last but not the least is, patient education. And I've launched a YouTube channel where I try to educate these parents about the efficacy of modern medicine, and also trying to stay away from untested and unvalidated therapies, which are alternative therapies, which are widely available in our country. So equally important to counsel them. We have had cases where we have biopsy proven AKI following use of Ayurvedic drugs. And as far as prevention of AKI is concerned, you would agree that an ounce of prevention is worth a pound of cure. Early and appropriate therapy is required so that you can promptly get these patients into remission. A judicious use of diuretics to minimize NSRCA, at the same time avoiding volume depletion. Make sure you vaccinate these patients during remission so that they are protected of infections. Judicious use of CNI with strict monitoring of trough levels. Albumin infusions if you have signs of intravascular depletion, and regular follow-up and monitoring with the use of telemedicine significantly helps in prevention of AKI. So to sum up, while a decrease in the GFR due to reduced glomerular permeability is a common occurrence in nephrotic syndrome and may not always lead to long-term implications, there appears to be a rising trend of AKI in recent years among pediatric patients because of use of certain medications. Given the notable prevalence of nephrotic syndrome in childhood and the apparent increase in AKI rates, it is crucial to promptly recognize and manage AKI to prevent potential complications in the future with using telemedicine at our disposal. Long-term adverse outcomes have been observed following AKI from various causes, highlighting the importance of addressing AKI effectively in pediatric nephrotic syndrome. And further research is necessary to establish correlations between AKI and pediatric nephrotic syndrome and impact on long-term outcomes, facilitating better management strategies and improved patient care. Thank you for your attention.
Wonderful talk. Thank you, sir. So wanted to know how often do you recommend a monitoring of a CNI levels if nephrotic child is started on CNI?
So the first level should be done about 7 days after initiation of therapy. And thereafter, I think beyond, if the patient is going stable, the second level can wait up till 3 months. If the patient is not going into remission, then I think I do another additional level at 1 month. And thereafter, an yearly level is all that is required in the vast majority of patients. But I still recall one girl with minimal change disease who was being managed at a premier center in Delhi, who came to us with chronic kidney disease, had biopsy proven minimal change disease, 3 years of unmonitored tacrolimus therapy, and she had chronic kidney disease. So so before you embark on therapies, we have to choose the patients very, very carefully.
Just one small question. So it was a very great presentation and a very thought-provoking idea of tele consultation. Just a thought that can we really give teleconsultations for AKI management in those scenarios of nephrotic syndrome as part of legal issues, and how do you practice it? Like
No, so there is a slight caveat here. The teleconsultation will help you in minimizing AKIs by, in appropriateness of therapy, improving your. So if the patient is going into relapse, through teleconsultations, you can immediately advise these patients, to increase their steroid doses. Then if these patients are getting dehydrated, prompt referral to your nearby center is all. And this approach, I first saw use of telemedicine when I was doing my fellowship at Sick Kids Toronto, and we were using the conventional. We used to follow all these nephrotic patients were received a monthly telecall from our health, specialized nurses. So we had the liberty of using nurses. And if the nurse found that there was something, aberrant going on, immediately specialty resident was involved in this. And they were able to actually minimize a lot of inpatient clinic visits, which add to the burden of the healthcare, especially in tertiary centers.
So what sort of teleconsultation method you prefer, sir, in that scenario?
So it's simple. Nowadays, what I would suggest is that you could use one of the electronic medical records. So in combination with the WhatsApp, so you have all you can enter all their data in your software. The EMRs allow you that. So the moment, and you can have a telehealth clinic where you periodically review these patients, and the prescription can be, an electronic prescription, signed prescription is delivered to these patients on their email or WhatsApp. And I've been doing it for last, I think, since the COVID pandemic.
When do you ask us to suspect a AIN in a nephrotic AKI
AIN.
kid?
So very good question. If there's a patient who comes to you who's not had diarrhea, vomiting, is not on any background ACE inhibitors, ARBs or CNIs, has come with an acute kidney injury, a lot of times when you start going into the details, you'll be able to elicit alternative therapy history of alternative therapies, inadvertent use of non-steroidals by their neighborhood general practitioner, or rarely a pediatrician, or even their pharmacist there who gives them ibuprofen. I showed you one of their case reports. So I think a good history taking is paramount. And please don't go away with the idea that you can manage AKI with telemedicine. If the child develops AKI, or even if you have a remote, if you feel that the child is not doing well, should report to the nearest health center that is available. Yeah.
Anyone open to the discussion? Okay. Okay. Thank you so much, sir. And we'll close it here.
Thank you so much for the wonderful session. Request the chairpersons to please let us felicitate you towards the left of the stage. Thank you. Before starting session 5, again a reminder that we have CME quiz just after the session 5. The time has come to dive into session 5, and we are privileged to have our dedicated chairpersons. I invite you all on stage, please. Put your hands together and welcome Dr. Shobik Sural, consultant nephrologist from Kolkata. Dr. Srinivas Avula, consultant nephrologist from Guntur. Dr. Deepak Kalra, consultant nephrologist, Fortis, New Delhi. and Dr. Sabrinath S., Assistant Professor Nephrology, JIPMER, Puducherry. Over to the chairpersons. Thank
Hello.
you.
Okay, so welcome you all again for the session 5. And the topic is very important. Digital health and AKI, current status and challenges in clinical practice. As we know that the AKI, despite the advances in the technology, the outcome has not yet changed. So probably there is a scope of digital health here. And to talk on that is none other than Professor Vivekanand Jha, who doesn't need any introduction here. He's the Executive Director, George Institute of Global Health, Editor-in-Chief, Indian Journal of Nephrology, former President, International Society of Nephrology, former Secretary, ISN, formerly Professor, Department of Nephrology. And Dr. Jha, please take the mic.
Thank you. So we can, let me start first of all by congratulating the Department of Nephrology at the Sanjay Gandhi Institute for its foundation day celebration, and also thank Dr. Narayan Prasad for inviting me to be with you this afternoon. So the chairman has really raised expectations as if digital health is going to solve the problem of AKI. And hopefully I will give you some glimpse of where we are with this. But I think to expect that we have a radical solution is unrealistic. And I would like to remind everyone of the point that Dr. Vivek Kumar made during his talk again and again, is that eventually what we are looking for really is for any intervention, whether it is a diagnostic or a therapeutic intervention, to make a difference to the outcomes. And those outcomes need to be relevant and important to the patients and also to the society and to the clinicians. The idea is not to simply increase the number of cases we identify or that we treat differently, but only if that results in a difference to the outcome. So that's something which we should always keep in mind whenever we are discussing anything. So, not sure whether this pointer works. I'll use this. So this is a version of this figure you have seen in many talks now. So this is the spectrum of acute kidney injury starting in the community, going down to the hospitalization and eventually follow-up care. So in the community, you have individuals at risk, and then some of them will develop acute kidney injury. A few of them will be picked up early, others will be picked up late, will develop complication, will go through the clinical course, and we know the various outcomes. And those who are lucky enough to come out, they will need to be monitored for long-term outcomes. So now let's go straight into digital health. So digital health is a somewhat umbrella concept, and it means different things for different people. But according to the WHO, the definition of digital health is the use of information and communication technologies in medicine and other health professionals to manage illnesses and health risks and to promote wellness. I think the latter one is also important, that digital health is not only relevant to people after they develop the disease, we also want disease to be prevented. And some of that was alluded to by Dr. Gulati when he said that he used teleconsultations to prevent the development of acute kidney injury or advise people on how can it be prevented. And you heard about e-alerts and so on during the course of the day. So there are a range of digital health approaches which can be used to improve clinical care, and they're all listed here, starting from health information technology and health informatics. And these terms mean slightly different things. And electronic health records is something that that we are getting used to. And actually, Sanjay Gandhi Institute was one of the pioneer institutions in setting up electronic health records. There are a number of other hospital institutions which unfortunately are still living in Stone Age so far as electronic health records are concerned. And they include some very major institutions. I wouldn't name them really. Because it becomes a kind of naming and shaming. But we are now entering the era of wearable medical devices, and those medical devices can even be the watch that you're wearing that can give you medical information. Apple Watch can actually diagnose atrial fibrillation. We have the omics technologies that give you a whole range of data. We have now also the use of software as a medical device. And I gave you the example of the Apple Watch. So there the software is acting as a medical device. So you are no longer using an ECG, it's appropriately making it. Clinical decision support system was alluded to by a number of speakers. We have obviously the examples of mobile health, and we'll talk about it a little later. Telemedicine and telehealth, everyone is aware of now. Data analytics, this is very important. So this is something which you often don't think about, but the importance of data analytics in informing digital health is critical. So gathering data, analyzing it appropriately to correctly identify population at risk. And this goes back to the point of using a diagnostic test. So if you use a diagnostic test in a population that is at low risk of developing a disease, you will get a number of false positive outputs. Whereas if you identify a population at risk and then apply the biomarker in that, then perhaps you will pick up a large number of true positive test results. And this is something which becomes a fashion. A biomarker comes in and you use it in everyone. And what will happen is that most of the individuals that you identify will be actually truly low risk individuals, and there the biomarker test will be false positive. Artificial intelligence and machine learning is coming up in a big way, and the shape of artificial intelligence and machine learning approaches is changing on a day-to-day basis. So the information that we have today will get outdated next week, and so on and so forth. And then finally, digitally enabled therapeutics, and this is important. And one example of this is the use of blood sugar monitoring to constantly change insulin dosage and so on. So digitally enabled therapeutics, and that's something which is coming in as well. And we have a bit of that in our dialysis machines, which can sense, which can hopefully sense, various parameters and change dialysate concentrations of different solutes, etc., and thereby, fine tune the dialysis procedure, etc. So again, recapping, what are the potential benefits of digital health? And this is not to forget, I think we always need to think from the public health point of view of improving access to healthcare. An example of that is now a patient can, through telemedicine approaches, can actually access or is able to get expertise of someone like you from sitting thousands of kilometers away. Reducing inefficiencies in healthcare system is also very important. Our healthcare system can be very inefficient at times because of a variety of reasons, and that's a separate talk, what causes inefficiencies. But we need to use digital health optimally to reduce those, improve the quality of care, and reduce errors. Of course, if it comes as a news to you, medical errors are the third largest causes of death in hospitals in NHS UK system. We don't do that, so we don't know what is the burden of ill health due to medical errors in India, but I will not be surprised if it is very substantial. We want to reduce the cost of healthcare, and of course, in the end, provide more personalized healthcare, starting from disease prevention to early diagnosis and self-monitoring, promoting self-monitoring and self-management, and eventually getting to a position where we give what is called bespoke care. You must have heard of bespoke tailoring, where rather than buying something off the shelf, you get measured and a suit is stitched which fits you. And similarly, the medical care will need to be like that suit which fits exactly you and will not fit your neighbor necessarily. Digital health market, as you can imagine, is growing substantially, and you can see the numbers. And this is the global market. But now let's just transition to acute kidney injury, and we go back to the AKI, which is the group that is really at the forefront of pushing knowledge, clinical practice, etc., in the area of acute kidney injury. And one of the AKI puts together a range of initiatives, and they have done up to about, I think, 30 initiatives by now. And the 27th of those initiatives was focused on digital health and acute kidney injury, and they made a number of recommendations. And I'll pick up some of them in my talk, but I'll use other examples as well. So what are the potential settings for the use of digital health and acute kidney injury? On the left, you see acute kidney injury in the West, which is mostly in hospital settings. But in countries like India, a lot of acute kidney injury develops in hospital, outside of hospital, in the community, right? So we have to not only think of the way digital health is used in the West, but we have to think how can we use digital health in our settings, which is fit for us, which is how can we use it in the communities. But no matter where we use it, I think again, the range is starting from risk stratification to early recognition to provision of personalized care, optimizing recovery, and then providing follow-up care. So I go back to my original point is that we have to always look at anything that we talk about from the lens of improved outcomes. Does it improve outcome? If it improves outcome, great, we must adopt it. If it doesn't improve outcome, no matter how sexy it looks, don't use it, because it will raise cost of care, it will lead to low quality care, and eventually it will turn us into poor physicians. So the summary of the evidence that we have so far is that acute kidney injury alerts or e-alerts, they improve early detection and prompt AKI management, only prompt AKI management. But please note that machine learning or artificial intelligence based risk prediction models again might improve the patient identification of patients who are at high risk of AKI, who could potentially benefit from tailored surveillance and primary prevention. Just remember that, potentially benefit. But so far there is insufficient evidence to show that the influence of digital approaches on AKI outcomes has been shown across the care continuum. So, and again, just continuing on the current evidence of clinical decision support system alerts, because that is the bit that has been tested most in the Western hospitals, because what they have done is to use clinical decision support systems to generate alerts for patients hospitalized, whether or not they develop acute kidney injury. So now it has been shown that CDSS alerts can recognize all stages of acute kidney injury. Definitely, it helps with AKI documentation and helps with recognition, and also reduces the response time in critically ill patients, specifically who are receiving nephrotoxins. And remember, I said medical error is one of the commonest causes of death, and therefore nephrotoxins must be considered in that category. And as a result of that, evidence has shown that you can reduce nephrotoxin administration. It also has been tested for its impact on AKI duration and progression, length of hospital stay, and the need of kidney replacement therapy. But the evidence on that is much less clear. And so therefore, we need to really continue to fine tune all of that. But what has the downside has been that the focus on achieving high sensitivity, and that was the point that Dr. Iyengar was making in her talk about, how to balance between high sensitivity and high specificity. But if you are on the side of high sensitivity for diagnosis, you will pick up a large number of cases who are actually false positive. They don't need the kind of care that you want to give them. And in the case of CDSS, what happens when you get too many messages, you just stop looking at the messages, right? So it causes alert fatigue, right? And it might dilute any improvement in outcomes that might come. So that's something which we have to remember. So just now sharing with you some evidence, and this makes basically the same point which I said earlier, is that this study showed that in a cohort of AKI individuals, patients who are expected to benefit from electronic alerts from acute kidney injury were identified. And so this is how this study was designed. So we have a cohort of individuals with acute kidney injury, and the intervention there was an alert for acute kidney injury versus usual care, and they measured the percentage change in serum creatinine. They developed a model there, and what they found is that they were able to identify they were able to show that they could demonstrate reduced increase in creatinine in those who were randomized to the alert arm, and predicted harm. Again, this is simply to identify who could potentially benefit, not that they actually benefited. So they identified individuals who developed increase in serum creatinine and potentially were at risk of harm. But then comes the intervention study, which looked at outcomes, and Dr. F. Perry Wilson and their team has really been at the forefront of this study, and they published this almost 10 years ago now, in which they looked at Because one of the best ways of testing any hypothesis is to subject it to randomized control trial. So any evidence that is not randomized control trial should be looked at with some degree of suspicion. And you need to do appropriately designed randomized control trials with appropriate outcomes to have faith in the value of that evidence. So what they did is that they screened the number of individuals who were hospitalized, and they randomized a certain number of subjects to alert group and to usual care group. And what they found is that really there was no evidence to show that any significant patient-centered outcomes were improved as a result of a patient being randomized to the alert group. Here is another study, which again by the same group, Dr. F. Perry Wilson and colleagues, and Dr. Chirag Parikh, who was named earlier, was also part of this investigation. And here I have shown the design of the study in the PICO format, which is the format that everyone should use whenever you are designing a research study. So P means population. So the population was more than 6,000 adult recipients, inpatient with acute kidney injury. The intervention was an electronic health record based pop-up alert for acute kidney injury with an associated acute kidney injury order set, what to do. Their comparator arm was no alert, who received usual care, and the outcome they looked at was a composite of progression of AKI, receipt of dialysis, or death within 14 days of randomization. And all of us will agree that these are relevant patient-centered outcomes. And so this is an example of the order set that was that came along with the alert. So no need to go into details. If you want, you can look into the paper. And here is the result. And the result is they looked at it in two groups of hospitals: teaching hospitals shown in the purple markers, and non-teaching hospitals shown here in yellow markers. And you can see whether it is teaching hospital, non-teaching hospital, the usual care arm is the filled circle and the alert arm is the open circles. The filled circle and open circles, they're more or less around the same time. The only thing which was different was death, which was greater actually in the alert, in the group that was randomized to alert. And that influenced the composite outcome also. So once again, no difference whether or not they received an alert. Now, and then there is this next study, which is called the Tackling AKI study, which looked at organization level of intervention for acute kidney injury. And similar study, this was a stepped wedge cluster randomized trial. And I wouldn't go into the details of how stepped wedge trials are done. But in summary, one sentence, stepped wedge trials are done in which centers are randomized to an intervention, and over a period of time, the randomization is done in a stepwise manner, so that eventually all the centers will, patients in all the centers will receive the intervention, right? So that no one is disadvantaged. They looked at these outcomes: 30-day mortality, AKI progression, hospital length of stay, AKI incidence, etc. So what did they find? They found that the delivery of AKI care was increased, hospital length of stay was reduced, but the mortality and AKI progression did not change. And these are the most important outcomes. So the most important outcomes did not change. And this is the last one, which was published very recently. Once again, a randomized clinical trial in which they looked at the maximum change in eGFR within 7 days after randomization. This is not a relevant clinical endpoint, but this is the way the trial was done. And this is the type of alert that was generated, and you can read the details of this. The conclusion of their study was also that the electronic alert did not improve kidney function or other patient-centered outcomes, but changed patient care behaviors. So something is happening, but the outcome is not changing. Now, all of this, what does it tell us? It tells us that yes, we still have some ways to go in before we can actually reach a situation where we are optimizing the use of these digital health approaches, and that they help improve outcome of these individuals. So what are the limitations of the current studies and the current approaches? So I showed you a few randomized clinical trials, but the other studies which initially suggested that yes, there is benefit, most of them were retrospective and observational. So here comes the benefit of actually doing randomized clinical trials, because that is the only type of evidence which is something that we can action. We are also limited by the volume and scope of data. We need to do it in very, very large number of subjects. And the RCTs that were done, in fact, most of them were directed at AKI recognition for improved response rather than improved outcomes. The last RCT I showed you was simply looking at 7-day serum creatinine change. They did not look at the outcomes, and that there is a lack of robust validation. To this list, I might add that there is no study which has been done in community setting, which is really relevant for our country, which is a low resource country. And this is a figure which is taken from that ADKI report that I mentioned to you a little bit earlier. And they describe the solution implementation stage, steps, and the various barriers and constraints that may really be faced by all of us, or everyone who is trying to implement them. And I have enclosed and I wouldn't go into details of all of this because we've discussed some of this a little bit earlier. But again, we need to develop an appropriate AKI model, which needs to be validated in using both external data in a prospective manner in a randomized clinical trial. And then it needs to be integrated and deployed. And they mentioned here inpatient, outpatient communication, and the challenge is lack of digital health expertise and limited IT infrastructure. Our IT infrastructure is still limited to mostly doing administrative type work. It is not meant to improve clinical care, which is what we need to do. We need to change our electronic health record configuration to suit and improve clinical care rather than simply collect data and do administrative type work. And of course, operationalization and maintenance is important, whether it is building or your toilets or electronic health record, digital health approaches, maintenance is really critical. And this is the implementation cycle that we need to continue to think about. When we start, we need to carefully define our need. We need to define the context in which we will apply it. For example, we can't take something which has been developed in Columbia University in New York and apply it to a hospital in India, because the entire context is totally different. We need to be mindful of the resources that are available, how our healthcare system is structured, what are our processes, and then agree on specific measurable outcomes and develop solutions in a way that minimize bias. And there have been reports from the Western countries about the bias of electronic decision support systems and artificial intelligence approaches, and how unconscious bias can creep in based on the kind of demographic information that goes into it, which can be sometimes even racially biased and biased towards one sex, etc. And again, we can discuss those into details. We need to consider how do we ensure knowledge transfer and broad implementation to the people who can use it, so that it doesn't remain something which can be used only in ivory tower hospitals like SGPGI, but also goes to district hospitals, primary healthcare centers, etc. How can it be appropriately deployed? We now have telemedicines and we have e-Sanjeevani portals, etc. in our country, but are they being applied in an appropriate way? We don't know the answer to that. And then implementation requires appropriate stakeholder engagement and quality assurance and performance improvement matrices. We have to always be mindful of the ethical, legal, and social implications and usage barriers. There is a big digital divide in different parts of the world. Even though we say that in India, a large number of people use mobile phones, even smartphones, but that doesn't mean that the digital divide has been entirely bridged. I think there is still a lot of gap in the understanding of the use of digital technologies appropriately. Data security is very important, which we in India often don't think about. We freely share our data, whether it is PAN card or it is Aadhaar card or any other type of number. But the threat of using your personal health data, because electronic health record does require sharing of some sort of data, and development of appropriate data security measures is critical. And we are all hearing about how there are all kinds of malware attacks, etc. on all of these servers, and there can be loss of your personal data. There are, again, we come back to acute kidney injury. And so there are a number of areas with potential impact by digital health solution across the care continuum in acute kidney injury. Look at this community for risk stratification, recognition, tailoring of appropriate response, and guiding acute kidney injury recovery, post-acute care applications. We have heard of the AKI to CKD continuum, etc. So again, we go back to the same four headings: risk stratification, recognition, tailoring of response, and guiding therapy. And then, of course, the big acute care applications, which will mostly take, the first two will take place outside the hospital. The one on the right will take place inside a hospital. But these are the key themes which influence digital health readiness, whether it is acute kidney injury or any other type of digital health response. And they can be divided into macro, meso, and micro factors. Macro factors are influenced by the government, local health policies, data policies, how the market is responding, how is the country developing it, and what do policymakers think? Because ultimately they are the ones who will decide. We have to implement whatever policymakers tell us to do. It is important for us to develop evidence which we can present to the policymakers so that we can influence their decisions, but they are the ones who will make those decisions. Then comes the role of more active healthcare players at meso level, where we have strategic leaders and we have the director of the institute sitting here, and it's people like them who can influence these policies. And then we look at our statutory services, how our organizations are structured. Again, we look at the pharmaceutical companies, and we have a large number of pharmaceutical companies here, and they obviously are also a player in this. And in the end, we come at micro levels where individuals become important. And we look at the patients, we look at the social structure of the patients, we look at the doctors, we look at the family of the patients and their caregivers, and so on. So therefore, I think in terms of the treatment gaps that we have for acute kidney injury, they can be summarized here. There is a vast unmet need. There is a large population which is diagnosed late and even remains undiagnosed until very late and may die also in the community. There is an inadequate workforce to deal with those people with acute kidney injury, and there is a disproportionate focus on late stage curative care models that will only give dialysis. We have to focus more on prevention, and that will require more public health approaches, etc., upstream approaches. We have to think about that. There is a huge variation in the quality of care that is received, and not only within one facility, but across the facilities also the variation on care is huge. And of course, we all recognize that the cost of the care is high relative to the ability of to pay. So we have to think of all of these when we develop context-specific digital health solutions. And I go back to the point that our solutions will be different from the one that is developed in the West. And there are examples of it, and we have to learn from those examples. And those examples have come from Africa, where digital health approaches were used to deliver care to HIV individuals. And we have examples in India also, where frontline healthcare workers use some digital health devices to provide care to pregnant women and to babies, etc. And this has, as I said, the vast potential to increase the reach of care to even to rural communities. And here you have an example of, you can see a thatched hut, but there is a healthcare worker sitting there with a tablet device talking to a potential user, right? And so this is a study that we did, and the context is different, not in AKI, but if you give a frontline healthcare worker, they are able to identify high-risk individuals perhaps more efficiently than even trained physicians, not trained, but untrained physicians, primary care physicians who have not received appropriate training. So there is a great potential there. And again, taking an example from a different field, which is of blood pressure control, using this approach has been shown to improve care and more achievement of targets. And this is something which now I'll come to the AKI field, and this is a study which was done by the 0 by 25 initiative of acute kidney injury as a part of 4-country study: Nepal, Bolivia, Malawi, and Nigeria, where clinical risk score was used to identify individuals at risk of developing AKI in the community. And those individuals were then referred to a primary healthcare facility where a telemedicine approach was used to provide care. So a clinical risk score was used. There was a point of care testing. Point of care devices are important for digital health, specifically in the community. So point of care testing for creatinine was done, and a protocolized management using clinical decision support system was provided. And this paper was published in PLOS Medicine a couple of years ago. It led to improved recognition and management of AKI. Once again, let me caution you that it only talks about recognition and management. doesn't talk about improved outcomes, which is really, which should be our North Star. We should always focus on improved outcomes. Now, having said all of that, let's go into, fast forward into the future. Where are we going in the future? I mentioned about point of care devices, and now new point of care devices are being developed. They are on the horizon. And there is this example of an eyeglass based tear biosensing system. And this tear biosensing system can be mounted on a glass, and it can potentially monitor any fluid coming out or any molecule that is excreted in the tear, and lo and behold, it is now able to measure serum creatinine. So serum creatinine can be predicted from tear creatinine, and this is one such proof of principle example. So can you put such an eyeglass in a hospitalized individual and who is at increased risk of development of acute kidney injury and monitor kidney function in real time? We will know at some point a study will be done. But then going back even further into fantasy land, here is a tool that we are all familiar with. We use it pretty much every day, and then we can convert that into something that helps medical care. And we obviously, this is well suited to kidney health, because a biological fluid that is linked to the kidney is poured into this device almost on every few hours, and we can do a number of things with that and thereby improve clinical care. So therefore, in conclusion, my dear friends, digital health tools offer unique opportunities to enhance the care of patients with acute kidney injury, but we have a long way to go. Digital health use for acute kidney injury detection and management will continue to evolve. Context-specific digital health acute kidney injury solutions will need to be developed and tested in real-world setting to examine impact on relevant patient-centered outcomes. And in the end, implementation will need to be monitored for unintended consequences, because we don't want to just rush and go out and start doing things which will increase the cost of care and even lead to low quality care, such as introduction or exacerbation of inequities in care delivery, which is a real risk. Because whenever a new technology is introduced, whether it is a diagnostic technology or a therapeutic technology, automatically enhances the existing inequities in the care. And as the responsible healthcare professionals, not only physicians, but also non-physician healthcare workers, all the stakeholders, we need to be mindful of being in a position that enhances inequities in the society. So with that, I'll stop here. Thank you very much for your attention.
Thank you, sir, very much. The very encompassing lecture, usefulness of digital health in recognition of diseases, better care with ELD monitoring and treatment in the hospital as well as in the community, how we can use it. We have to improve ourselves with digital records, their analysis, and constant improvement in the healthcare using the digital technology, which we cannot avoid as of now. We have to learn and be in assistance with the electronic systems. We have to go forward, taking care of the legal and security aspects of all this. Thank you. Any other comments are welcome.
Dr. Jha, thank you for excellent in-depth overview. The point which you have made is very valid, that we need to really look at the ground realities about using technology in different areas of healthcare. Like I'll give an example that for eICU, this is another thing which has been talked about. It is one thing to have the infrastructure, like as you mentioned, Ronco, the proponent of this electronic way to pick up acute kidney injury could be very useful in the Italian milieu, but how much it would really be, we will be able to apply from the Indian or an African situation, because I've seen both for telemedicine and also like how you can use these measures for delivering an ICU supervisory care depends on the ground realities of the trained manpower and how they can use the technology, because just having a facility does not translate. So what is your take that if you want to use something like this, definitely you have to have data that the outcome improves. But even if we don't have that data, but if we really want to use the technology, say for acute kidney injury, an Indian milieu, because in India we have district hospitals and primary health centers where this problem is there. If these patients, whether they are managed properly, the outcome may be looked at how it is improving in the periphery.
Thank you. I agree completely with all your comments, and I'll repeat what I said a bit earlier. Is that so? I'll make 2 points. One is that you said that these electronic alerts, which are being developed in the Western countries, you mentioned Ronco, etc. So even there, these alerts will not be approved for routine clinical use simply on the basis because you are able to identify individuals. Only if they do trials and show that it improves outcomes will the healthcare system allow for payment for these alerts, right? So that's something important. So as of now, these alerts are being used in clinical trial settings, but in routine clinical care, they will need to generate that type of evidence, which will then undergo health technology assessment studies. How much does it cost and how much improvement is done? That's number one. Number two, coming to so we have to, I agree completely with you that we have to develop solutions which are fit for purpose for us, which can be used in our healthcare settings, which recognize the type of referral pattern that exists in our healthcare systems, etc., and then use it appropriately. For example, the way electronic e-alerts are generated in the West are not necessarily going to work. For example, their e-alerts depend on the availability of past medical record. Dr. Arpana Iyengar spoke about the lack of pre-existing serum creatinine value for children. But what about, leave aside children, pre-existing serum creatinine values are not available for a large proportion of adults in India. So if there is an alert that depends on the use of a pre-existing or serum creatinine 3 months ago, that's not going to be available for a large number of our individuals. So we have to develop a different type of alert on how can we identify acute kidney. So that's just one example, and there will be many other examples. And it's important for us as a community to sit together and come to a consensus on what kind of solution will work for us. We obviously take inspiration from the ideas that are being generated because ideas are universal. But how to implement those ideas will need to be localized. So I completely agree with you.
Yeah, I agree. Like I'll give you an example that a diabetic who is in follow-up for years, but he has never had a urine examination done and renal function tested. So it's a unique situation from an Indian point of view.
Indian perspective.
Thank you.
Any other questions? We come to the end of session. Thank you, sir.
Thank you, dignitaries, and I request the chairpersons to please let us felicitate your esteemed presence. Towards the left side, I request you to please move. Thank you. Organizers have decided that the quiz will be conducted tomorrow for all the sessions together. With this, now we move to the much awaited Foundation Day celebration, and I am delighted to invite on stage the chairpersons for the same. Dr. R.K. Sharma, Consultant Nephrologist, Director, Nephrology, Medanta Hospital, Lucknow. Please give him a big round of applause. Dr. Amit Gupta, Consultant Nephrologist, Director, Nephrology, Apollo Supermedics, Lucknow. Dr. R.P. Ilhens, consultant nephrologist from Lucknow, and Dr. Lalit Kumar Agrawal, consultant nephrologist from Kolkata. Our agenda for today is brimming with stimulating presentation, interactive workshops, and engaging discussions led by some of the brightest minds in the medical fraternity. And we are honored with the presence of our chairpersons. And the stage is all set. And I request the chairpersons to take over the session. Thank you.
So I think we have a very important session, and this is felicitating Professor Harbir Singh Kohli, who is DM from Sanjay Gandhi PGI, one of our first DM students, and we are honored to have him here, who is at present working as professor and head of Department of Nephrology at Postgraduate Institute of Medical Education and Research Center, with his special interest in clinical nephrology and glomerular diseases. He's more than 300 publications and book chapters. We remember when we started the DM programs, we had these two very bright residents who took up nephrology training as a challenge, and that is how the whole process started. And now we have so many alumni who are coming back to this institution. Harbir, after finishing from SCPGI, now I would say that he is a mentor for so many nephrology fellows at PGI Chandigarh. So I would like to congratulate him for his achievements and would like to invite him for delivering this oration, which is given to one of the faculty or one of our students who has really excelled in academics and other parts of scientific teaching and training. Dr. Habib, please.
Good evening. Thank you very much, Professor Sharma, Dr. Amit Gupta, Ravi, and Dr. Lalit. Well, it's always wonderful to be back to your roots, to your alma mater. And I think these are the familiar faces. You all must be recognizing Professor Sharma, Amit Gupta, Dr. K. Dr. Bhandari is a little in the background. Dr. Anant Kumar, Dr. Kapoor, Dr. Lawat, and then some of our resident colleagues. Well, some of the resident colleagues, Dr. Ravi and Sanjeev, now are samdhis. So when you take the word samdhi, it is that the kids are married to each other. So I was just Googling what is the English word for samdhi. It said unification of minds, but then I saw it was samadhi. So one has to be very, very ultimately in Indian families that you have to be united. And sorry. This is one of my closest friend, Pradeep Arora, sitting at his house, and at that time's greatest achievement, that TV. And we used to have a lot of Maggie with Haldiram's spicy stuff poured over that. And this was a dialysis room where meetings were conducted. It was pretty impressive at that time, the furniture and the quality and Ratan Jha with me at in that this thing. And of course, all the bosses at that time, the nephrology, urology were used to have their lunches together. And right, Professor Bhandari is sitting in the center, and then the other colleagues from that. And of course, the ladies always rule. Okay, so what I'm going to talk about a little bit brief is not something unique, any big research. I'm just talking about deceased donor transplantation, which I think in the last year, SGPGI has started picking it up, and this is the SOTO for the deceased donor transplantation. But what I'm trying to talk about is what goes behind the deceased donor transplantation. I'm not going to talk about how to increase it, what is the requirement, everybody knows it. But certain points which may be to somebody's liking or may not be to someone's liking as to what is going on as far as deceased donor transplantation is concerned. So this is our PGI's figure from 2010 onwards, that how many are the deceased donor. As usual, pretty stable number, 62, 78, around 3-4 years. And then there was a drop in number again at 26. And this was the time, I think, when Professor Dhiman, Professor Yogesh Chawla took over to increase. And how to increase, he knows the best, how to hold the meeting, whether to get it on the license, etc. But I'm not going to talk about that. I'm going to talk about this part, why it is not consistent, why it is not stable, why it keeps on dropping, etc. Now, behind the wheel, I think I like this Sri Aurobindo's quote that what we call the knowledge is nothing but whatever we have accepted by reading or etc. And the real wisdom is to look behind that wheel and then try to find out as to what is going on behind that thing which is there. Now, what are we trying to look behind the wheel? Well, somewhat not so positive things. The grim reality, that is, whatever we are doing, the number of transplants, it's mainly for the media, it's mainly for the number game, rather than what is required. That's the point one. And secondly, is the live transplantation and the disease transplantation complementary to each other, or is one coming at the cost of other? Is there an analysis available where that the total number of a transplantation in the country as a whole is increasing, or is it cadaveric in a place is increasing, the live is decreasing? That's the one thing. And the third will be, which brings to point that majority of our patients will be having a marginal donor, the expanded criteria donor, donors with sepsis. And that brings us to the challenging point that we have to relook at our intensive care units. If our ICUs are meant to treat patients, ICUs are not meant to retrieve organs. ICUs are not the organ hatcheries. Until and unless we do not set our ICUs right, that each and every patient gets the desired treatment, then only this program will start running literally in a true sense. And then the two other points, everywhere it is date registered and then the number of transplant. It should be the date of registration or the need based. I mean, and what should be the need? And lastly, a majority of the new second transplants which are getting registered, initially live donor, now coming with the cadaveric or the sensitized recipients, and how to tackle that. So I'll be just touching on these good and not so good points. Well, this is our current around more than 6,000 patients who have been listed across the different blood groups, and depending on the B and O being the most common, AB being the least, and that's what the general population is, and the same holds true as far as the disease donor transplantation is concerned, the number which is registered. Now, if we look at after a gap of 5 years, suddenly 2023 onward, in this, the number for registration has increased like anything. Now, why this number has gone up? So that was the one question which was this thing. And this has resulted in the waiting period from 3 years to 5 years in non-sensitized and insensitized up to 7 years. Now that becomes the waiting period for the individual if we go just by the date of the registration. So now, why this number which is increasing? One, a lot of publicity, a lot of media hype. It is there that this is a deceased donor center or some deceased donor transplantation are being done. So patients come and get registered. And the second is this, sensitized and the graft failure, the first live and the second graft. That's causing this increased number. And the third one, which was there when we analyze our data in authorization committee, when where the swab donation was, that despite having a living related donor, it was the spouse who were getting swabbed. And the same is holding true in the cadaveric also, that 20% have a live related donor, but somehow, since the option of a deceased donor is available for registration, so let's get it registered. And no longer that live is explored any further, and that ends there. That 20% figure is coming up, and believe me, this is the real reason that because we also do not insist too much for that. Ultimately, it is patient's right, whatever the patient wants, whether it's a live or a deceased donor, and you cannot say no, you have to register. That's why the number is just piling up. And that is the grim reality. The numbers which have been registered vis-a-vis the number which have been transplanted, these small bars all across in the last 10 years. As you can see, the average is 10%. That's it. That's the average. In particular year, the peak may be 15%, 17%. It will drop down, but the average is not more than 10%. And this is once your program is active, the so-called a very active program. And that's why I say, if you are keep on registering this much and delivering only this much, then you have to see what is wrong, what is happening. And since last year, I think it was a huge discussion right in this auditorium, because SGPGI was going on with the full-fledged deceased donor program. And this I was talking was that are live and deceased donor complementary to each other, or it is just like a cricket run rate? The moment live transplants go up, the cadaveric transplants go down. Both of them are not following the graph upwards. Either if the cadaveric goes up, the live goes down. If the live goes up, the cadaveric goes down. And what is the reason behind that? And that we need to think and find out, that is it the resources are limited, the operation theaters are limited, our ICUs are limited, our staff is limited, or our will is limited. Maybe the moment we get a good number of cadaveric transplantation, you get a lot of good publicity and you feel very happy, and you are not too much bothered about the live transplantation at that time. And what happens who do not get this thing? Now, this is the figure down below who got transplanted, who were registered somewhere. Whether they got it transplanted with us or outside, it doesn't matter, but it remains around 10%. And this is the group who still have hope, around 25%, who are still on dialysis and are getting transplanted. And this is the number who are no more, who are lost to follow-up, assumed to be not more. And this is a huge number. 60% who are not there, who got registered initially. Now, that's the point where ultimately our program has to focus, not at institution level or a departmental level, but at the national level. And that's quite a scary and grim figure, that what is going on. Okay, so now I'll come to a little bit towards the positive point after telling you a lot of negative points. That is sensitized patients, like criteria of a sensitized patient always is different. That whenever there's a PR is more than 20% with a MFI of 5,000, initially we used to try desensitization, not successful, so labeled as a sensitized patient to that patient. Now that group is growing, and the number of the reasons, whether it's a blood transfusion, whether it's a second transplant, it's a pregnancy, that's a standard this thing. And if we look at our figure, when we started doing donor specific antibodies for each and every patient, like we can see that 34% were sensitized recipient. Of these group of 124, majority were the second transplant. That is, who already had a graft loss, 76%. And these were the group which were the sensitized recipients. Now, earlier on, our policy was to do a standard cross match whenever the patient used to come. And there was a problem whenever we are dealing with a sensitized recipient. And these are the three standard ways we can handle it. Kidney pair donation is a very common thing with us. Desensitization is no longer at our center, is being practiced very frequently, occasionally, and then hope for the deceased donor transplantation. And then comes the role of the cross match, the virtual cross match, when you know the HLA of the donor and you already have in your profile the antibody, single antigen bead assay, where all antibodies you have. So you can know whether this is a suitable recipient or this donor is suitable for this thing or not. Now, in the virtual cross match, obviously you need to know the HLA of the donor at that time. So that's the only requisite which is required across all A, B, C, DR, DP, DQ. And also in the recipient, the single antigen bead assay has already been done and we already have the antibodies against that. So at that time, it becomes a relative easier to know about the virtual cross match. And obviously this is our report, because in general the time taken or appointment, it takes more time, because the cost of a single antigen bead assay, if I will say on a subsidized rate in a private setup, 2 PGI patient is around 25,000 rupees in Chandigarh alone. Outside it is much more, but within PGI it is 15,000, and poor free is of course zero. There is no cost. Obviously, the waiting list is huge to get the single antigen bead assay. And normal cross match, which we used to do earlier, had a lot of pitfalls in the deceased donor transplantation. Reason being, the quality of the lymphocytes at that time was not good, and we're getting either a false negative or a false positive cross match. Even tried having a lymph from the lymph node, from the spleen, the lymphocytes, but overall the quality, and the top of it, if the patient has sepsis, which majority of the patient in ICU have, and then it becomes a problem of this thing. And that's one of the references to substantiate this thing, whether you take the lymphocytes from the peripheral blood or a lymph node or from the spleen. Ultimately, the HLA expression, you are not able to know about that. And this was our journey initially. I mean, from CDC, when we shifted to the virtual cross match in 2022 only, initially every time we used to call the patients, we didn't have the record with us in the software, and then we'll check the HLA of the donor, and then we'll decide whether the cross match is positive or not. Now, subsequently, we already have a record of single antigen bead assay. HLA of the donor is done, and we already know if the virtual cross match is positive, so we do not call them at all, and we go down the list and start calling patients for this thing. So no CDC is done at all now. For last 2 years, it's only a virtual cross match which is done. Initially, it was scary doing this thing without a CDC, because you are like raised with certain values, quote unquote, and CDC is one such value, that without CDC, that means the transplant cannot be done. So that was the result. I think earlier on, 16% patients we were able to transplant who were sensitized. But after virtual cross match, it was being done, it was around 35% that we were able to transplant, which otherwise were just waiting and waiting on dialysis. And the second point, which I was saying, everywhere, which I have seen in the Tamil Nadu, Maharashtra, the date of registration. Now, that is the one which is displayed everywhere, and that decides what should be the criteria for the transplantation. Whether it's the children, they should be given priority. Whether it's a second transplant, the sensitized patient who will get a rare chance to find a suitable donor, and sometimes a living donor, if his or his relative getting complication, should that person be given some chance? Although in the country, one policy, one country, everything is there, but still we deviate from that, and this is our scoring system, okay, which we follow, that apart from registration, every point is given for children. Extra 20 points are given. Those who have a graft loss, they get 20 points. Sensitized recipients get 30 points. First degree relative of the deceased donor already who has given, he gets 40 points. And the living donor who ultimately gets some CKD-SRD, he gets 50 points. So this is the point system which we have evolved. And a lot of complaints, we have submitted this system to the High Court also, and nobody has objected so far. Although country-wise, if you say, the only system which works is the first one, the date of registration, and nothing else. But this is how we are following, and we are getting a lot of appeals, investigations, court cases, but still we are holding on to that. That was a joint decision, duly vetted by this thing as to what will be our criteria like. And then the third point, in ICU, once you have a brain dead or brainstem dead person, should each and every person is a suitable donor? The first and foremost is sepsis. I think in majority of the hospitals, especially the retrieval center, because last time this was being talked in different government hospitals where the majority of the trauma comes, with this sepsis is always there. Now, I think without sepsis, it will not be there. And that raises the question, the better ICU quality care with us, because that will not only improve the general condition of the patient, but also the disease donor transplantation. Similarly, the donors who are more than 60, who are hypertensive, where while in ICU, their creatinine is more than 1.5 milligram per deciliter, whether to take them. Similarly, the pediatric donors. Now, whenever there is an infection versus non-infected, obviously outcomes are better in non-infected, though no long-term data is available. But it is always, as usual in the studies, said that as long as wait listing is concerned, it is better if you have even an infected donor. It doesn't matter. It may be better than being wait listed. But here I'll say a word of caution. It all depends upon the relative. I'll come to this point because many of times patients are taken up, but they end up with some other surgery with a, let's say, gangrene, gut gangrene, because they already had a septicemia that has to be tackled. Sorry. Okay, and this will be the substantial chunk where whether to take which kidneys, which I said more than 60 or already having underlying kidney disease, whether to put both kidneys if the kidney is compromised so that this expanded criteria is there. And that's the definition which we have used, although we have used even those donors with the creatinine 3 and even more than 3 milligram per deciliter with fingers totally crossed whether this is going to work. But now here I'll like to say one thing which may sound a little offensive to somebody, that it's a very easy in a government setup, like in our setup, where patient population is just a captive patient population. Whatever you offer them, they accept it. So it's very easy. But once, even in SGPG or outside, you have to be very, very careful whatever you are telling them, that they're for the same quantity of immunosuppression, whether that kidney will function or not function, B, how long will it function? Because they will become sensitized for the next transplant. Now, that is the level of counseling which majority of us have to do actually. Being in a government setup, you get away with this because you do not deal with the fussy patients. And I always say within the department also that we need to have fussy patients within the department, because then only the real challenge comes to us. Similarly, the pediatric donor, even the irrespective of the age, it can be there. And even in fact, if you had listened to Prime Minister's Man Ki Baat, he referred to one of the patients, less than a month old, that was from our center. That's the one part of the story. The second, I will not say. Okay. And whether this is the thing, policy which is there, that when there is a less than 10 kg, it's an en bloc kidney transplant, both kidneys getting transplanted at one. More than 10, okay, it can be done in this thing. As far as sepsis is concerned, now this needs to be explained to the patient's attendant very, very properly. And the deceased donor transplantation, I mean, just now the last lecture was about the digital health. And since Dr. Jha mentioned that, I will not be mentioning many places. So, so this is our own department's database, which we keep our deceased donor transplant record, because it's very taxing. Actually, the deceased donor transplantation, having 6,000 patients database, it's very, very taxing, and coming out with this thing. And so you need to have all side of a management with the drop down menus, so that the things can be done very quickly and you can come for this thing. And these are the two things which we had added off late only. And was the integration of SMS, that the moment the patient gets registered, whenever every 3 months they have to come to tell us that they are keen, interested. So that automatically that message goes to them after every 3 months. And if they do not come after 6 months, then the message goes that no, your name will be stuck off. So you better let us know whether you are coming or no. And this has not been done. That the DSA report from our lab gets integrated with this software, so that it's easy rather than physically looking at each and every antibody. So it can be done. Now this has not been done, but I feel this should also be done, that the report from the lab should go straight to the database, and accordingly then it will be the true virtual cross-batch with minimal efforts. And okay, so behind the wheel, I kept this title like that only. I think for a deceased donor transplantation, we have to get out of this mindset. And this is the line which Dr. Raja had used. I loved it. Success is mine and failure is yours. And this is the teamwork where without that, it cannot be done. I mean, you cannot say that the nephrology claims or a urologist claims success, and when the success is not happening, it is that the brainstem declaration is not being done by the neurosurgeon or neurologist. The failure goes to the administration, the success goes to the department. No, this cannot be done. I mean, that should not be there. And the second is equally important, the ICU care. I think it has to be improved all across the country. Otherwise, having infected donors everywhere, there's no point. For example, if you have in the whole UP different retrieval center, the transplant may be done here. You may be getting from only government hospitals because majority of the trauma will be going there only. Unless their ICUs are good, they are providing a good care, you will be getting only infected donors, and then there will be a problem. And the last is an interesting point, I think, which of late only we have observed. Earlier on, whenever we had a deceased donor, we used to call just 6 prospective recipients. All 6 will come immediately running. Now, if we document each and everything, the minutes where that we called, so and so picked up the phone or said, no, I am not willing to come. Now we go down to 40 or 50. Some are medical reasons, they are not fit, but other is the real thing, that empowerment. The patient simply says, why should I spend that much of money on immunosuppression for a compromised kidney when I am getting my dialysis free and close to my home? Now that is the empowerment which of late I have observed, which is there, that patients just refuse to come for a deceased donor, or sometimes say, maybe we'll think about after a couple of months, my wife is not around, so I need some help. And these are the earlier or unheard of answers. And that's a really encouraging that at least in state of Himachal, it's free dialysis almost all across, and it's a better quality of dialysis. Patients are surviving for more than 7 years as a routine, so they are willing to wait. That's why the number of deceased donor registration is going up. And of course, with the virtual cross match, the unnecessary visits are no longer necessary. They come only when it is there. So with that, I think still I'll say 5 years ago, this used to be my line in my department always, that good is the worst enemy of the best. If you get satisfied with the good, best will never. A particular position in a government setup, this thing, the best is the worst enemy of the good. So you have to start. At the beginning has to be made. Ultimately, it becomes best. But if you just hope for the best, that your ICUs will become best, no, they will not become best in the beginning. So you have to start, and it's good that this is the learning of whatever deceased donor transplant program is going on, that it should be a team one. And if the team is there, this is Professor Kher batting during the conference picnics, with the tradition he took from PJ Chandigarh and followed it up here. I don't know, Dr. Narayan Prasad, whether it is being followed up. Unlikely. The conferences have become picnics. So I think they should be little break from there. And that was when Professor B.K. Sharma had come 1990, I think, as a visiting professor to the department. And it was a wonderful, at that time, interacting with him, and especially one room, which I think will be of one of your consultants, and his name with the white coat and red embroidered thing, and he loved that thing only. The white coat should always be there. So that's the memories, good memories of the department, of the place, which are there apart from whatever things we have learned. So with that, I think I'll conclude, and thank you so much for listening to this. Thank you very much.
Thank you, Harbir, for this wonderful oration and for talking on a subject which is of extremely importance. And to take you back, if you remember, the first renal transplant that we did at SGPGI on the 6th of July, 1989, was a deceased or a cadaveric transplant. And if you remember, unfortunately, there were no takers for the second kidney. We had 3 other patients waiting for a transplant whose donors were being worked up. We had this lady who did not have a donor, so we could give 1 kidney to her relatives agreed. But the second kidney, there were no takers, and we had to throw it in the dustbin. That was the position way back in 1989. At that time, there were no laws. We took special permission from the district magistrate, and we performed the transplant. This was a young man who had come in with a head injury. Subsequent to that, I don't think we've had a great success with the numbers of deceased donor transplants. After I've joined Apollo Medics, in the last 3.5 years, we have done 4 deceased donor transplants. And we have shared the kidneys with SGPGI. 1 kidney goes to them, and 1 kidney we did with us. The problem in the northern part of this country, if you compare it to the other parts, like east, the south, the west, and the east, the mindset of our people are still a little different. And they're not still willing to agree to organ donation. Secondly, the ICU, as you mentioned. You see, at Apollo Medics, we have a very good ICU team, and who are forward-looking and have been sort of those patients who are brain dead, they've counseled the families, and many a time the families agree. So you need a good ICU team, as you mentioned correctly, good ICU care, so the family is satisfied that everything has been done for the patient, and then they would go forward for organ donation. The third thing is about the living donors. You said the number of, even though 20% of your patients who go in for deceased donor have a living donor who don't agree to donate. There is a problem still about the follow-up of our donors. Actually, long-term follow-up of our living donors is in many centers, including ours, needs to be improved because we don't know the results, how well they do, etc. So that is another important thing that we have to work on. So I really enjoyed your talk and that you took us through brought out some old photographs and memories, the times that we had, and it's a great honor listening to you, our first alumni, who has now become the head of department of a prestigious institute, postgraduate institute, Chandigarh. Very well done.
It is with great pride that we present the Foundation Day Oration Award to Professor Dr. H.S. Kohli, the esteemed first alumnus of our department. It is very apt that the award will be presented by his teachers, Professor R.K. Sharma sir and Professor Amit Gupta sir. I request chairpersons R.P.L. Hans sir and Dr. Lalit Kumar Agarwal to join us. I request Professor Narayan Prasad sir and Professor Anupma Kaul ma'am to join us on stage.
And may we give a standing ovation to Professor H.S. Kohli, sir.
Thank you so much. Now I hand over the mic to Harshita ma'am and Jaykumar.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्व कार्येषु सर्वदा. गुड इवनिंग टू ऑल. फूल है गुलाल है, फूल है गुलाल है, केसर और चंदन है. आप सभी का इस कार्यक्रम में हार्दिक अभिनंदन है. मैं हर्षिता शर्मा, असिस्टेंट प्रोफेसर डिपार्टमेंट ऑफ नेफ्रोलॉजी.
I am Dr. Jayakumar Mayappan, Assistant Professor, Department of Nephrology.
इस भव्य सम्मेलन जो कि संजय गांधी स्नातकोत्तर आयुर्विज्ञान संस्थान के नेफ्रोलॉजी विभाग के तृतीय स्थापना दिवस के उपलक्ष्य में आयोजित किया गया है, मैं आप सभी का विभाग के सभी सम्मानित सदस्यों की तरफ से हार्दिक अभिनंदन करती हूँ.
May I now invite our beloved Professor, ever smiling, Professor Dr. Anupama Kaul ma'am to deliver the welcome address.
ओम नमो विघ्न राजाय सर्व सुखाय प्रदायिने दुष्टारिष्ट विनाशाय पराय परमात्मने। नमस्कार, सुस्वागतम, आभार, आप सभी का हार्दिक अभिनंदन। संजय गांधी स्नातकोत्तर आयुर्विज्ञान संस्थान के नेफ्रोलॉजी विभाग के स्थापना अवसर पर मैं डॉक्टर अनुपमा कौर आप सभी का हार्दिक अभिनंदन एवं स्वागत करती हूँ। नेफ्रोलॉजी विभाग विगत वर्षों में निरंतर देश में ही नहीं अपितु विश्व स्तर पर अपनी पहचान बनाए हुए है। इस उपलब्धि का श्रेय यहाँ के विश्वविख्यात शिक्षकों एवं पुरातन छात्रों को जाता है, जिसका हम सदैव ही कृतज्ञ रहेंगे। स्थापना दिवस के उपलक्ष्य में हम सभी ने एक गोष्ठी का आयोजन किया है, जिसमें भारत से ही नहीं अंतर्राष्ट्रीय स्तर के विख्यात महानुभाव उपस्थित हुए हैं और कार्यक्रम की शोभा बढ़ाई है। हम आप सभी का आभारी हैं। हमारे आज के समारोह के मुख्य अतिथि श्री आशुतोष शुक्ल जी, राज्य संपादक दैनिक जागरण उत्तर प्रदेश, हम सभी की तरफ से हार्दिक स्वागत एवं अभिनंदन। हम आपके सदैव अनुग्रहित रहेंगे कि आपने इस अवसर पर आकर हमारा हौसला बढ़ाया। हमारे निर्देशक पद्मश्री प्रोफेसर R.K. धीमन जी ने सदैव हम सभी को प्रोत्साहित किया है। अपनी दूरदर्शिता और अनुकरणीय नेतृत्व के माध्यम से हम सभी के सपने हकीकत में अनुवादित हो पाए हैं। हम सभी का हमेशा समर्थन एवं मार्गदर्शन प्रदान करने के लिए आपका धन्यवाद। हमारे संस्थान के संकाय अध्यक्ष प्रोफेसर शालीन कुमार जी का मैं दिल से अभिनंदन करना चाहती हूँ कि इतने व्यस्त होते हुए भी इस उत्सव के अवसर पर उपस्थित होकर हमारा मान बढ़ाया। हमारे विभाग के ओजस्वी विभाग अध्यक्ष प्रोफेसर नारायण प्रसाद जी एवं विभाग के सभी कार्यकर्ताओं की ओर से हम आप सभी का आभार एवं स्वागत प्रकट करते हैं। संजय गांधी स्नातकोत्तर आयुर्विज्ञान संस्थान के हर व्यक्तित्व की यही सोच रही है कि कुछ अलग कर जाएं और इस सोच से वो अलग दिखते हैं। मंजिल पर सफलता का निशान चाहिए, होठों पे खिलती हुई मुस्कान चाहिए, बहलने वाले नहीं हैं हम छोटे से खंड से, हमें तो पूरा का पूरा आसमान चाहिए। अंत में अपनी वाणी को विराम देते हुए मैं कहना चाहूंगी कि हम इत्र से महके ये आरजू नहीं है हमारी, हम इत्र से महके ये आरजू नहीं है हमारी, तमन्ना यही है कि हमारे हर किरदार से खुशबू आए। नमस्कार।
Thank you, ma'am. It was a director, Padma Shri Professor Dr. R.K. Deeman sir's vision that we celebrate the foundation of our illustrious department every year. Department was founded in 1987 and we have been celebrating the foundation day 3rd year now. And with every passing year, we start with a renewed purpose and look forward to achieve greater heights. I now welcome Professor Dr. R.K. Deeman sir to the stage, who will be accompanied by the dynamic professor and head of our department and organizing chairman of this CME, Professor Dr. Narayan Prasad sir.
ना पूछो कि मेरी मंजिल कहाँ है, अभी तो सफर का इरादा किया है, ना हारूंगा हौसला उम्र भर, ये मैंने किसी से नहीं खुद से वादा किया है। निदेशक महोदय रूपी माली के निरीक्षण में, संस्थान रूपी बगीचे में कर्मठ चिकित्सक, उपचारिकाएं एवं सभी सहायक जन रूपी फूल अपनी गंध से विश्व रूपी आंगन को महका रहे हैं। ये संस्थान निदेशक महोदय जी की मेहनत और नेतृत्व से महक रहा है, क्योंकि वो जो शोर मचाते हैं भीड़ में, भीड़ ही बनकर रह जाते हैं। वही पाते हैं जिंदगी में कामयाबी जो खामोशी से अपना काम कर जाते हैं। ऐसे हैं हमारे पद्मश्री निदेशक महोदय जी, जिनकी छत्रो छाया में हमारा संस्थान दिन दोगुनी रात चौगुनी उन्नति कर रहा है। आप सभी को हमारा शीश वंदन।
May I now welcome Shri Ashutosh Shukla ji onto the stage. I now invite Professor Dr. Rajkumar Sharma sir and Professor Dr. Amit Gupta sir to the stage. Sir.
हमारे आज के समारोह के मुख्य अतिथि श्री आशुतोष शुक्ला जी, राज्य संपादक दैनिक जागरण, का हम सभी की तरफ से हार्दिक स्वागत एवं अभिनंदन। हम आपके सदैव अनुग्रहित रहेंगे कि आपने इस अवसर पर आकर हमारा हौसला बढ़ाया।
I now welcome our Dean, Professor Dr. Shalin Kumar Sir, who will be accompanied by our Organizing Secretary, Dr. Ravi Kushwaha. May now invite Professor Dr. Anupama Kaul ma'am onto the stage.
किसी भी देश की उन्नति व अवनति उस देश की प्रेस, संपादक एवं पत्रकार के आपसी सहयोग से ही जनता जनार्दन और विश्व के सामने प्रस्तुत होती है। यह देश का प्रमुख स्तंभ माना जाता है। इस दिशा में आपकी प्रतिबद्धता को हमारा सलाम एवं शीश वंदन। जैसे जमीन पर चमकते हैं जुगनू और आसमां में तारे, वैसे ही चमक रहे हैं हमारे अतिथिगण सारे। अब मैं हमारे विभाग के ऊर्जस्वी एवं यशस्वी विभाग अध्यक्ष प्रोफेसर नारायण प्रसाद सर से विनम्र निवेदना करूंगी कि वह हमारे मुख्य अतिथि एवं अन्य गणमान्य अतिथियों को शॉल से सम्मानित करें।
May now invite Dr. Ravi Kushwaha, Organizing Secretary, onto the stage. As we begin this auspicious occasion, let us invoke the blessings of the divine through traditional lighting of the lamp, accompanied by the soulful rendition of the Saraswati Vandana.
वरदे वरदे वीणावादिनी वरदे 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 प्रिय स्वतंत्र रव अमृत मंत्र नव प्रिय स्वतंत्र रव अमृत मंत्र नव भारत ने पर दे पीड़ा काट अंधेर के बंधन स्तर काट अंधेर के बंधन स्तर बहजननी ज्योतिर्मय निर्झर बहजननी ज्योतिर्मय निर्झर कलुष भेद तम हर प्रकाश भरे कलुष भेद प्रकाश भरे जगमग जग कर दे कर दे नवगति नवलय ताल छंदे नवगति नवलय ताल छंदे नवल कंठ नव जलद मंदिर नवल कंठ जलद मंदिर नव नभ के नव विहग को नव नभ के नव विहग वेद को नव परिणव कर दे वर दे वर दे वर दे वर दे पीड़ा दिरि वर दे पीड़ा
That was a soulful rendition by Dr. Anjani Kumar Mishra, Shubham Srivastav, and Aradhya Mishra on the side with them. Thank you.
फूलों पर भव्य की गुंजन हो, माँ शारदे के चरणों में वंदन हो, सद्गुण संपन्न जीवन हो सबका, इस शुभ बेला पर आप सबका अभिनंदन हो।
I now invite Professor Dr. Narayan Prasad sir to deliver the Foundation Day address.
आज का जो स्थापना दिवस है, इस दिन मैं अपने सारे अतिथिगणों का बहुत बहुत हार्दिक अभिनंदन करता हूं। आज हमारे साथ इस मंच पे जो विद्यमान है, हमारे आज के जो मुख्य अतिथि हैं आशुतोष शुक्ला जी, वो इस प्रदेश में जो सबसे ज्यादा चलने वाला जो एक अखबार है, जिसको हम दैनिक जागरण बोलते हैं, जागरण समूह के राज्य संपादक हैं। और अभी हमने सोचा, जैसे बहुत सारे डिजिटल हेल्थ और मीडिया प्रचार और इसके बारे में बात हो रही थी, जिसके थ्रू हम लोग जब भी बातें करते हैं, जैसे ऑर्गन डोनेशन की बात हो रही थी, तो एक बहुत बड़ा माध्यम होता है। तो हमने इसलिए सोचा था कि माननीय आशुतोष शुक्ला जी आज यहाँ आए और ये जो हमारे नेफ्रोलॉजिस्ट ग्रुप और जो हमारे जो पैरामेडिक्स और सारे स्टाफ्स हैं जो इससे प्रभावित होंगे, और ये हमें इस माध्यम से अखबार के थ्रू प्रचार के माध्यम से हमें बहुत सारी मदद मिलेगी। हमारे डायनामिक डायरेक्टर प्रोफेसर आर.के. धीमन, जो हमारे पैट्रन भी हैं, आज के गेस्ट ऑफ ऑनर भी हैं, और जो डायरेक्टर साहब का जो विजन है, जैसा आपने डॉक्टर कोहली सर का प्रेजेंटेशन में सुना था, he has given dynamism for the deceased organ donation at PGI चंडीगढ़, and during that period इनके डेटा से भी रिफ्लेक्ट हो रहा था कि जब वो वहाँ थे तो नंबर ऑफ ट्रांसप्लांटेशन की संख्या काफी अच्छी थी। और हम लोग कुछ दिनों से यहाँ लगे हुए हैं कि वही उत्साह
फिर से यहाँ भी रिप्लिकेट हो और हम लोग डिसीज डोनर ट्रांसप्लांटेशन को आगे बढ़ा पाए। और हमारी, आपको मैं बता दूं, जैसे डॉक्टर गुप्ता सर ने बोला, हम लोगों ने कभी डिसीज डोनर ट्रांसप्लांटेशन छोड़ा नहीं है। हर वर्ष कुछ ना कुछ डिसीज डोनर ट्रांसप्लांटेशन की प्रोग्राम चलती है, लेकिन जो ड्राइव होना चाहिए उत्तर प्रदेश जैसे राज्य में, वो नहीं है। हमारे बीच आज हमारे फॉर्मर डायरेक्टर, हमारे डिपार्टमेंट के हेड प्रोफेसर राजकुमार शर्मा सर हैं। ये अभी मेदांता के नेफ्रोलॉजी को संचालित कर रहे हैं, इसके डायरेक्टर हैं। हमारे बीच प्रोफेसर अमित गुप्ता जी हैं, ये हमारे फॉर्मर हेड ऑफ द डिपार्टमेंट रहे, अभी अपोलो मेडिक्स में डायरेक्टर ऑफ द नेफ्रोलॉजी को संचालित कर रहे हैं। हमारे बीच हमारी कलीग डॉक्टर अनुपमा कौल जी हैं, हमारे डीन हैं डॉक्टर शालीन कुमार सर, और अभी कुशवाहा जी हमारे ऑर्गेनाइजिंग सेक्रेटरी हैं। और हमारे बीच इंटरनेशनल सोसाइटी ऑफ नेफ्रोलॉजी के फॉर्मर प्रेसिडेंट प्रोफेसर विवेकानंद झा जी हैं आज, इनका आपने डिजिटल हेल्थ के बारे में आपने सुना होगा। इतनी प्रभावी प्रेजेंटेशंस होती है जिसको आप हम और आप समझ सकते हैं। और इनका हमेशा विजन और मिशन जो है ऐसा रहा है कि कैसे नेफ्रोलॉजी केयर को वर्ल्ड वाइड बढ़ाया जाए। हमारे बीच आपने प्रोफेसर कोहली को सुना, हमारे बीच बहुत सारे हमारे डॉक्टर सौभिक शुरल जी हैं, डॉक्टर संजीव गुलाटी जी हैं, डॉक्टर के.एल. गुप्ता फॉर्मर हेड ऑफ द डिपार्टमेंट ऑफ द चंडीगढ़। हमारे बहुत सारे एलुमनीज आए हैं आज जो काफी इम्पोर्टेंट हमारे लिए हैं। ये हमारे 3 स्टालवर्ड्स हैं जिन्होंने इस डिपार्टमेंट को शुरू किया था। प्रोफेसर विजय किर वाज द फर्स्ट फैकल्टी ऑफ दिस इंस्टीट्यूट। कुछ ही दिनों के बाद प्रोफेसर आर.के. शर्मा सर ने ज्वाइन किया, तत्पश्चात अमित गुप्ता जी ने प्रेजेंट किया। हमारा विजन और मिशन जो है वो किसी से छुपा नहीं है। हम लोग यह चाहते हैं कि यह देश का सबसे बड़ा डिपार्टमेंट बने और जहां पर एविडेंस बेस्ड, इथिकल, सोशली माइंडफुल पेशेंट केयर हो, रीजनल और नेशनल हेल्थ प्रायोरिटीज हो, हम लोग ज्यादा से ज्यादा मेडिकल और पारा मेडिकल मैन पावर को प्रोड्यूस कर पाए। मेडिक्स तो ठीक है, पारा मेडिक्स का भी बहुत अभाव है स्टेट में। ट्रेंड नर्सेस, ट्रेंड टेक्नीशियंस ये नहीं है। इस पे हम लोग बातें कर रहे हैं। ये हमारा एक विजन और मिशन है। स्टेट ऑफ द आर्ट रीनल ट्रांसप्लांटेशन प्रोग्राम अक्रॉस हमारे उत्तर प्रदेश में शुरू हो। सबको आश्चर्य लगेगा कि हमने ये टॉपिक क्यों चुना था। एक प्रिवेंटिव एस्पेक्ट्स पे बात हो रही थी। AKI का प्रेजेंट, फ्यूचर और पास्ट क्या है। पहले ऐसा सोचा जाता था AKI ठीक हो गई तो ठीक हो गई। अब हम लोग सोचते हैं कि AKI हो गई तो ये एक 7 से 10% चांस है कि इसमें से 7 से 10% पेशेंट्स को क्रॉनिक किडनी डिजीज हो जाएगा। और ये एक जो हमारा लार्ज पूल ऑफ रिक्वायरमेंट है जो डोनर का, रीनल रिप्लेसमेंट थेरेपी का, उसमें ये और एडिशन होगा। तो क्यों नहीं इसके प्रिवेंटिव एस्पेक्ट्स के पे काम किया जाए। हमारा जो इंटरनेशनल सोसाइटी ऑफ नेफ्रोलॉजी है उन्होंने एक विजन दिया था कि 2025 तक कोई भी प्रिवेंटेबल कॉज ऑफ डेथ नहीं होना चाहिए। अगर AKI हुआ है, अगर वो प्रिवेंटेबल है, उसके डेथ तो ये नहीं होना चाहिए। उससे अभी हम लोग कोसों दूर हैं, लेकिन फिर भी यह प्रयास अभी भी जारी है। और मैं साउथ एशिया रीजनल बोर्ड का चेयर हूँ अभी। प्रोफेसर विवेकानंद झा जी सर इसके फॉर्मर प्रेसिडेंट रहे हैं। और बहुत सारे विजन और मिशंस के बारे में बातें होती रहती है और इसमें हमको लगता है कि हम अवश्य सफलता पाएंगे। हमारा जो डिपार्टमेंट है उसमें लगभग 107 बेड क्लिनिकल नेफ्रोलॉजी के लिए है। 125 डायलिसिस स्टेशन सेपरेट है जहां पर 2 से 3 बार सारे मरीज आते हैं और अपनी डायलिसिस करा कर जाते हैं। हमारा 39 बेड का किडनी ट्रांसप्लांट यूनिट है। इसके अलावा जो हमारे बीच जो अभी हैं, जो 12 फैकल्टी है, हम लोग हर वर्ष 18 DMS स्टूडेंट्स को ट्रेन कर रहे हैं, 2 पोस्ट डॉक्टरल फेलो को कर रहे हैं। हमारे पास रीजनल ट्रेनिंग सेंटर है इंटरनेशनल सोसाइटी ऑफ नेफ्रोलॉजी का, जिसमें हमारे फेलोज आते रह रहे हैं। और अभी हमारे इंटरनेशनल नेफ्रोलॉजी के लिए भी रिकॉग्नाइज हो गया है। और लगभग लाखों की संख्या में हम लोग के पास पेशेंट्स जो है हर वर्ष आते हैं। हमारा 74,000 लगभग पेशेंट केवल हमारे OPD में विजिट करते हैं हर वर्ष। इसके अलावा जो इंडोर पेशेंट्स होते हैं, जो हमारे यहाँ जो इंटरवेंशंस के लिए आते हैं, बहुत सारे ओपीडी बेसिस से इंटरवेंशन था, वो अलग है। और रीनल ट्रांसप्लांटेशन जो हम लोग लगभग 150 तक हर वर्ष कर पाते हैं, उसमें भी बहुत हाईली सेंसिटाइज ट्रांसप्लांटेशन के लिए बात कर रहे थे। हमारे यहाँ लगभग 20% ट्रांसप्लांटेशन जो है वो हाईली सेंसिटाइज ट्रांसप्लांटेशन होते हैं। हमारे पास हम लोगों ने देखा कि जब प्रधानमंत्री नेशनल डायलिसिस प्रोग्राम शुरू हुआ तो सडनली उत्तर प्रदेश से वैस्कुलर कॉम्प्लिकेशंस की संख्या बढ़ गए। तो हमें लगा था कि यहाँ पर वैस्कुलर एक्सेस प्रॉब्लम लेकर के लोग आएंगे, और हमने 2 वर्ल्ड क्लास ओटी बनाया। आप ये देख सकते हैं, ये ओटी जो है इक्विप्ड विद द सी आर्म्स है, और डीएसए लैब, डीएसए एक्सेस है, यहाँ पर डीएसए सूट्स है, जहां पर हर दिन कम से कम 20 से 25 प्रोसीड्योर्स होते हैं। तो हमारी जो वैस्कुलर एंजियोप्लास्टी, और इसके लिए जब हम रेडियोलॉजी डिपार्टमेंट पे डिपेंडेंट होते थे तो महीनों का डेट मिलता था, जो हम लोगों ने उसको सुचारू रूप से संचालित कर रहे हैं। और आप यहाँ देख सकते हैं कि हम लोग लगभग 900 लगभग हम लोग टनल और 1600 लगभग नॉन टनल कैथेटर हर साल डाल रहे हैं। हमारे पास एबी फिस्टुला हमारे रेजिडेंट्स सब बना के जाते हैं, और इसकी आउटकम्स बहुत ही अच्छा है। पिछली वर्ष हम लोगों ने 2023 में हमारे रेजिडेंट लोगों ने, ये हमारे यूरोलॉजी के डेटा से अलग है, 900 एबी फिस्टुलाज बनाए गए। वो किसी भी, अभी ऐसा माना जाता है कि वर्ल्ड में इतना कोई ओटीज में, नेफ्रोलॉजी डिपार्टमेंट में इतने प्रोसीड्योर्स नहीं होते हैं। मैक्सिमम जो डेटा है यूएसए में एक सेंटर में 3300 का होता है, और हम लोग 4000 के पार हैं। और ये है कि हम लोगों ने लास्ट ईयर्स हमने जस्ट इंटरवेंशन नेफ्रोलॉजी शुरू कराया था। डॉक्टर मानस पटेल जी हैं, वो इसको देख रहे हैं। और हम लोगों ने 2022 में केवल 31 हम लोगों ने वैस्कुलर एक्सेस को रिकैनलाइज किया, एंजियोप्लास्टी किया, जबकि लास्ट ईयर हम लोगों ने 224 प्रोसीड्योर्स किए। बायोप्सी हमारे वर्ल्ड क्लास हैं, हम लोग ने बहुत सारे डेटा इससे रिलेटेड पब्लिश किया हुआ है। आप देख सकते हैं कि 1342 हम लोगों ने किडनी बायोप्सी लास्ट ईयर किया। और एक ट्रेनिंग है, जो हमारे स्टूडेंट्स यहाँ से ट्रेंड होकर जब बाहर जाते हैं, और यही प्रक्रिया कंटिन्यू के रहते हैं। पहले सारे मरीज हमारे यहाँ आकर बायोप्सी कराते थे, और अभी जब से हमारे स्टूडेंट्स पास होकर के डिफरेंट कॉर्नर्स ऑफ उत्तर प्रदेश पे गए हैं, नंबर ऑफ बहुत सारे पेशेंट्स अब बायोप्सी करवा कर आते हैं। ये हमारे लिए भी सुखद होती है। हमें लगता है कि नहीं, जो हमारे रेजिडेंट्स और हमारे स्टूडेंट्स पास होकर गए हैं वो अच्छा काम कर रहे हैं। हीमोडायलिसिस की जो फैसिलिटीज है आपको हमने बताया है, 125 डायलिसिस स्टेशन आते हैं, 110 हमारे न्यू सेंटर्स पे, 15 पुराने सेंटर्स पे हैं, और हम लोग पूरी केयर करते हैं इस मरीजों का। और जो डायलाइजेट सिस्टम जो है, डिस्ट्रीब्यूशन सिस्टम, सीडीएस सिस्टम, हमने डायलाइजेट को पहले मैनुअली बनाए जाते थे, कंटेमिनेट हो जाते थे, लोगों को फीवर आता था, राइगर आता था। अभी आप डायलिसिस यूनिट में घूम कर देखते, किसी भी मरीज को कोई नौशिया नहीं, कोई वॉमिटिंग्स नहीं, कोई राइगर नहीं, कोई चिल्स नहीं। और ये सेंट्रल डिस्ट्रीब्यूशन सिस्टम ऑफ द डायलाइजेट जो है, पहला कोई सरकारी संस्थान है जहाँ पे हम लोगों ने, प्रोफेसर आर.के. धीमन सर ने इसमें काफी सहयोग किया, और हम लोग इसको बना पाए थे। नंबर ऑफ डायलिसिस आप देख सकते हैं, अप्रैल 2024 में 5249 डायलिसिस। हम लोग लगातार जैसे जैसे हमें मैन पावर मिल रही है, स्टेशन मिल रहे हैं, हम लोग बढ़ाते जा रहे हैं। हम लोगों ने एक लॉस्ट ग्लोरी था, एक समय था कि हमारे यहाँ मैक्सिमम पेरिटोनियल डायलिसिस शुरू होते थे, जो बीच में काफी संख्या कम हो गई थी। हम लोग फिर से, जो हमारा सेंटर जो था, लार्जेस्ट सेंटर ऑफ द पेरिटोनियल डायलिसिस इन साउथ एशिया हुआ करता था, वी आर गेटिंग दिस बैक। और हमने 2023 में फिर से 58 पेशेंट्स को पेरिटोनियल डायलिसिस पे शुरू किया। पीडी कैथेटर इंसर्शन के लिए हमारे रेजिडेंट ट्रेंड किए जाते हैं। हमारा क्वालिटी कंट्रोल पे बहुत ध्यान है, और इसके लिए हम लोग हमेशा, हमारे फैकल्टी जो है डायलिसिस यूनिट को हमेशा लगातार विजिट करते रहते हैं, ओटी यूनिट्स को विजिट करते रहते हैं। ये हमारा पेरिटोनियल ट्रांसप्लांट जो केयर है, आपको मैं बता दूं कि हमारे यहाँ 3500 से ऊपर लिविंग डोनर ट्रांसप्लांट हो चुके हैं, और लगभग हम लोग 2000 लगभग पेशेंट जो बाहरी हैं वो हमारे यहाँ फॉलो करते हैं। ये बहुत बड़ा हो गया और हम लोग डेडिकेटेड ट्रांसप्लांट ओपीडी शुरू करने जा रहे हैं। तो पहले थोड़ी मिक्स हो गई थी जिसमें हम लोग डेली के पेशेंट्स और ट्रांसप्लांट पेशेंट को भी मिक्स करते थे, जिसको हम अलग करने जा रहे हैं। हमारा इन हाउस कटिंग एज ट्रांसप्लांट इम्यूनोलॉजी लैब है और यही कारण है कि हम लोग डिफिकल्ट से डिफिकल्ट ट्रांसप्लांट कर पा रहे हैं। लास्ट हफ्ता हमारे यूरोलॉजिस्ट कलीग डॉक्टर संजय हैं यहाँ, संजय सुरेखा जी, हम लोगों ने 125 किलो के 2 पेशेंट्स का पिछली महीने में ट्रांसप्लांट कराया और वो हाईली सेंसिटाइज थे, एबीओ इनकम्पैटिबल ट्रांसप्लांटेशन थे और वाल्वुलर डिजीज और कंजेस्टिव हार्ट फेलियर में रहा करते थे, जिसको हम लोगों ने सक्सेसफुली ट्रांसप्लांट किया है और उसको डिस्चार्ज भी किया है। तो हम लोग किसी भी पेशेंट्स को अपने सेंटर से चाहे कितनी भी डिफिकल्ट हो उसको वापस नहीं करना चाहते, हम चाहते हैं कि इस सेंटर में उसका इलाज हो जाए। ये हमारा यूएसजी स्क्रीनिंग है एबी फिस्टुला का, जो रूटीनली होती है, जहाँ से भी पेशेंट्स आते हैं हमारे यहाँ डेडिकेटेड अल्ट्रासोनोग्राम मशीन है इको का, जो हम करते रहते हैं। क्वालिटी पे हमारी काफी ध्यान होती है। स्टूडेंट सेंट्रिक मेथड्स जो हमारा है, इनहेंसिंग द लर्निंग एक्सपीरियंस, चाहे एकेडमिक एक्टिविटी हो, इंटर डिपार्टमेंटल एक्टिविटीज हो, इस पे हम बहुत ध्यान रखते हैं। केस डिस्कशन, बेड साइड डिस्कशन, रीनल लैब्स और नेफ्रोपैथोलॉजी सेशन, ये सब हम लोग कंटिन्यूसली करते रह रहे हैं। ये हमारा सोर्स है और हमारे स्टूडेंट्स भी पूरे देश और विदेश के स्तर पे जितने भी कॉन्फ्रेंसेस होते हैं सब में पार्टिसिपेट्स करते हैं और दे आर getting lot of best paper posters awards across from not only within the country, from out of country also. हमारा पब्लिकेशंस डेटा भी है, हम लोग हर वर्ष हमारा डिपार्टमेंट 30 से 35 पेपर पब्लिश करता है और वो अच्छे पेपर में करते हैं। हमारे डिपार्टमेंट में पेटेंट्स भी है। हमारे यहाँ आपको जैसा हमने बताया सीनियर रिसर्च फेलो, रिसर्च लैब हमारा एक अलग है, रिसर्च एसोसिएट्स ज्वाइन करते हैं और हमारी डिपार्टमेंट का डिस्टिंक्टिवनेस यही है कि हम लोग लीडरशिप और मेंटरिंग में विश्वास रखते हैं और हमें लगता है कि भविष्य में चलकर हम लोग इसको और आगे बढ़ाएंगे। हमारा आउटरीच एक्टिविटीज भी काफी स्ट्रांग है और मैं सोचता हूँ कि हमारी एकेडमिक जो विंग है वो काफी और स्ट्रांग हो। और आप समझ सकते हैं कि अभी इंडियन जर्नल ऑफ ट्रांसप्लांटेशन, इंडियन जर्नल ऑफ रीनल न्यूट्रिशन एंड मेटाबॉलिज्म्स, इंडियन जर्नल ऑफ ट्रांसप्लांटेशन के असिस्टेंट एडिटर, हम इन हाउस अभी हम इंडियन एडिटर इन चीफ ऑफ इंडियन जर्नल ऑफ ट्रांसप्लांटेशन है। इसके अलावा बहुत सारे जर्नल्स में एसोसिएट एडिटर का काम कर रहे हैं। हमें लगता है कि भविष्य में ये काफी एकेडमिक एक्टिविटीज और रिसर्च जो है वो हम आगे बढ़ाने के मूड में हैं। और आप ये देख सकते हैं हमारे जो पास आउट एलुमनीज है अक्रॉस कन्याकुमारी से लेकर जम्मू कश्मीर तक लोग हैं और ईस्ट वेस्ट डायमेंशन आप देख सकते हैं। हम लोगों ने 114 लगभग डीएम स्टूडेंट्स पास किए हैं और लगभग उतनी ही संख्या में हमारे जो है जो शॉर्ट टर्म ट्रेनिंग करके जो यहाँ से गए हैं या नॉन डीएम रेजिडेंट हमारे यहाँ उतनी ही संख्या में रहे हैं। तो हमें लगता है कि डिपार्टमेंट ने काफी कंट्रीब्यूट किया है। ये हमारा वर्कफोर्स है डिपार्टमेंट का। और सबसे जो इम्पोर्टेंट है कि जब भी मैं आप लोगों को याद करता हूँ, हमारे एलुमनीज हैं वो सब बढ़ चढ़ करके आते हैं और हमारे यहाँ पार्टिसिपेट करते हैं, ये हमें हमेशा बूस्ट करता है। मैं एक बात कहना चाहता हूँ अपने एलुमनीज से, मिलो एक बार को तुम, मिलो एक बार को तुम, शिद्दत से बात करनी है, तुझसे ही गले लगकर तेरी ही शिकायतें करनी है। इसी के साथ मैं अपने शब्दों को विराम देता हूं और मुझे लगता है कि हमारे जितने भी एलुमनीज आए हैं वो आप इस क्षण को एंजॉय करेंगे। इसके बाद ही हमारा कल्चरल इवेंट्स है जो काफी अच्छा होने वाला है। हम एक्सपेक्ट करेंगे आप लोग सबको उसमें पार्टिसिपेट करें। थैंक यू, थैंक यू।
Thank you, sir, for being the driving force behind the great standards. May I now invite our Dean, Professor Dr. Shaleen Kumar, to share his thoughts with us on this occasion.
Ashutosh Shukla ji, Raj Sampadak, Jagran Uttar Pradesh, Director Dhiman sir, Dr. Professor Sharma sir, Dr. Amit Gupta, Narayan Prasad, and Anupma Kaul, and of course H.S. Kohli Sahab, one of our alumni, and friends Sanjeev, Dharmendra Bhadoria there, and ladies and gentlemen. I can't help but reflect on what Dr. Narayan Prasad has just talked about for the last 15 minutes. I'm reminded of this quote: "We stand tall on the shoulders of those who come before us or who have gone before us." These people are, in no particular order, Professor Vijay Kher, Professor R.K. Sharma sir, and Professor Amit Gupta sir. And taking forward the baton is currently Narayan Prasad and his team. Listening to Professor Kohli sir today, this evening, talking about the deceased organ donor, I couldn't help wondering what an irony of things it is that we started this institute. The first transplant was on a cadaver. However, almost 26 years later, our cadaveric donations, our cadaveric transplants are a small fraction of the work that this department is currently doing. And it's a source, it's something to think about. The other irony is that our current director, Professor Dhiman, has just yesterday been awarded the Padma Shri, and for one of his sterling contributions to the cause of organ donation, also alluded to by Professor Kohli Sahab. It was, among other things, as I learned just this morning, that it was organ donation, deceased organ donation, I think. And yet, there's something about our milieu here that prevents us from reaching out to more people. We have an Apex Trauma Center, and I'm aware that our hospital administration and the SOTO program, the State Organ Transplant Program, is working full steam in this direction. And I think, sir, that, Director, sir, at this point in time, one of the most important things that we need to do is, I mean, this is one game changer, that one thing that can possibly make a difference to the patients. I understand about 10% of your acute kidney injury patients go into chronic renal failure, eventually requiring transplants, et cetera, et cetera. But I think this would be a lot of difference. So I thank you all for coming here, and thank our alumni for being here as well. And I wish you have a good time and a very good evening.
थैंक यू डीन सर। कार्यक्रम को आगे बढ़ाते हुए अब मैं संस्थान के निदेशक प्रोफेसर आर के धीमन सर को आमंत्रित करना चाहूंगी कि वे हम सभी को इस अवसर पर संबोधित करें।
थैंक यू मैडम। श्री आशुतोष शुक्ल जी, प्रांत संपादक, दैनिक जागरण। प्रोफेसर शर्मा, former director SCBGI, Professor Amit Gupta, head of the department, former nephrology, and we are missing the third of the trio, Brahma, Vishnu, Mahesh, Professor Vijay Kher also. Maybe the next time we can see him here also. Professor Shaleen, Dean, Narayan Prasad, HOD, Professor Anupma Kaul, Ravi Kushwaha, and my dear colleagues from I would say the PGI Chandigarh. I can see Professor KL Gupta, Professor Jha, and Professor Kohli. And thank you very much for coming over here. And जब भी आपको देखते हैं तो बहुत अच्छा लगता है। लखनऊ है anyway. And dear ladies and gentlemen, when I was just entering and took my seat, I was listening to Professor Jha. It was really a mesmerizing lecture, mind blowing also actually, because I am also interested in the digital health, telehealth, and there, what are the uses could be in our society or in a medical college or in the medical education. In fact, I was just discussing with him also. He also emphasized that the digital health does not mean only in the treatment. It starts from the prevention or the diagnosis, treatment, and so on and so forth also. So one of the examples that I want to share with you, that when I was in the PGI Chandigarh and was working with the Punjab government for the early detection of the patients with hepatitis C and ultimately their treatment. So we have made the SOP while the government was providing the free diagnostic as well as the free treatment. It was a very successful program. And where does digital health come into the play over here? The one thing is that when a patient is not coming for the collection of the drug, we used to give the treatment for the 3 months, and every patient has to come at the end of the 1 month. So we were having the support from the CHAI, that is the Clinton Health Access Initiative. They were doing the part of the monitoring and the evaluation. If the person does not collect his or medicine 3 days in advance, then there is a generation of the red alert. We have to go even to the village to provide the medicine, or we call him to the OPD, and therefore we could increase the compliance of the patient, therefore ultimately the outcome. So I'm talking of the outcome. What Professor Jha said, so many randomized controlled trials in AKI, there are many parameters have improved, but not the ultimately the outcome. So that is your thing also. So that I am giving you the one example. And we have embarked in other area also in the state of the Uttar Pradesh, what we call as the tele-IC. And that is based upon the hub and the spoke model. That is the beginning. That is only the pilot study. The SGPGI is an hub, and the 6 old medical colleges, Gorakhpur, Prayagraj, Kanpur, Jhansi, Meerut, and Agra, they are the spokes having the 10 beds each the telemedicine. In fact, we have started it. The inauguration has to take place after this code of conduct. Anyway, it is working. So basic aim is not only providing the services through the telemedicine or this kind of whatever we have in the facilities to the distant place or distant ICU, basically capacitating their I would say faculty as well as the paramedicals also. The similar care could be provided over there. So this is the one area where we can use the digital health. If it is successful, then we can provide this facility in other upcoming medical colleges. So there are many more things actually. And I would like to share here that in the third phase of the expansion, we are going to expand it, the digital health along with the public health. Because if you combine these two, then you can provide the services which include prevention, early diagnosis, many more in the line also at their doorstep or there. So that is the one thing I would like to say. Second thing that I equally enjoy the lecture by Professor S.S. Kohli also, and he reminded me good old days also at the PGI Chandigarh, where in 2011 when we started the department of the hepatology, and ultimately see that we are not providing the training to our trainees regarding the hepatic or the liver transplantation. That was the point where we started the organ donations programs also. But one thing is that Professor Jha invited me in one of the organ donation meeting, and he gave me about the pancreatic transplantation. And I learned one thing from here. You can do any kind of the awareness, But the main thing is at your own hospital, and that is the emergency department. If I talk about the KGMU here, the emergency department of the trauma center, at least 2 or 3 potential brain deaths are coming, and we are not able to tap even the single one. So if you want to increase your organ donation, I think that is the first thing that you have to concentrate. You have to basically talk about the transplant coordinators also, and your protocols also, which patient you have to follow. But I totally agree with you, the ICU care that is lacking over here has to be given preference, and usko बढ़ाना चाहिए, जितना भी करना चाहिए, so that you can convert these brain deaths into the real organ donation. If I remember, if we ask 10 people over there in PGI, only 1 or 2, they agree for the organ donation. And I tell you that commensurate your figures also. When in 2019, I came in the February 2020 here, and in 2019, Chandigarh was the number 2 place with the maximum of the 47 donations, organ donations, from the person's donation in that year. So we can do it actually. As far as you are talking about the disease donor transplant programs also, आप उसको देख सकते हैं, and you have to tap the where you have to basically go and do the hard work. Anyway, I wanted to talk about these 2 things that were coming off from your talks actually. Very informative. I really enjoyed both the talks, and thank you so much coming all the way to the Lucknow. Thank you so much. Thanks a lot.
धन्यवाद महोदय। अब मैं आमंत्रित करती हूं हमारे मुख्य अतिथि श्री आशुतोष शुक्ला जी को कि वे हमें इस अवसर पर संबोधित करें, हमारे प्रोत्साहन हेतु कुछ शब्द कहें।
सबको नमस्कार। पीजीआई के निदेशक आदरणीय डॉक्टर धीमन साहब, आदरणीय डॉक्टर अमित गुप्ता साहब, जिनके आदेश पर मैं यहाँ उपस्थित हुआ हूँ, डॉक्टर नारायण प्रसाद जी, जो यहाँ डीन हैं, अभी जो बोल रहे थे डॉक्टर शालीन कुमार साहब, डॉक्टर अनुपमा कौल जी, यहाँ जो अभी एक इतना शानदार, जैसा कि आपने कहा 2 लेक्चर्स हुए, और मैं तो एक लेमैन हूँ, और जो जहाँ साहब का मैंने सुना, और कोहली साहब को, डॉक्टर कोहली साहब का जो है, मैंने व्यक्तिगत तौर पर मुझे उनसे ये सीखने को मिला कि प्रेजेंटेशन जो है वो कितना सिंपल पर कितना इम्प्रेसिव बनाया जा सकता है। और आपने जैसे जितने कम शब्दों में, मैं कह रहा था, हमारे कलीग बैठे हैं कि देखो कितनी वाइट स्पेस है, हम लोग बहुत पीपीटी वगैरह बनाते हैं इन दिनों, कोविड के बाद से नौकरी का एक ये पक्ष भी हो गया है। थैंक यू सर, आपने एक बहुत अच्छा पीपीटी बना, और खास करके उसमें वो जो आपने अपने दोस्तों को, अपने कलीग्स को जैसे याद किया, वो जो क्रिकेट का बल्ला दिखाया, और वो सब बहुत ही अच्छा। तो आज आपसे मुझे ये सीखने को मिला, लर्निंग ऑफ द डे। मैं बहुत छोटी सी बात, सबसे पहले तो मैं आप सबके प्रति इस हॉल में, इस संस्थान, इस जमीन पर खड़े होकर के कृतज्ञता ज्ञापन करता हूँ। 2014 में 21 नवंबर 2014 मेरे फादर का हम ले गए उनको मेडिकल कॉलेज, और वहाँ पर कहा गया कि नहीं साहब, यहाँ तो हम कुछ नहीं कर सकते, इनका ऑपरेशन होगा, आज होगा, अभी होगा, और पीजीआई में होगा, अलावा इसके कहीं नहीं हो सकता। मैंने कहा सर्वाइवल के चांसेस कितने हैं? उन्होंने कहा 2%। हम आए, कैसे आए? यहाँ मेरी नौकरी है थोड़ी सी, हम यहाँ पर हम बहुत सारे, हमारी नौकरी की समस्याएं होती हैं, बहुत मेहनत होती है, बहुत दौड़ धूप होती है, लेकिन थोड़ा सा प्रिविलेज हो जाते हैं कि आप जैसे लोगों से मुलाकात होती है। हम आए यहाँ पर, यहीं बाहर थे, और डॉक्टर राजन सक्सेना साहब ने देखा, उन्होंने ऑपरेशन किया, रात को 12 बजे वो ओटी में गए, रात को 12:30 बजे गए, 3 बजे निकले, और उन्होंने मेरे पिताजी को बचा लिया। तो मैं आप सबके प्रति, उसके बाद पिताजी फिर नहीं रहे बाद में, पर उस समय वो जो एक जीवन था, बाद में नारायण प्रसाद साहब के ट्रीटमेंट में रहे, तो आप सबके प्रति मेरा एक बहुत कृतज्ञता ज्ञापन। मैं इस हॉल में जो आप लोग बैठे हैं, आपसे बाहर का हूं, एक समाज से आता हूं, उसकी तरफ से मैं आप सबका कृतज्ञता ज्ञापन करता हूं कि आप जो हमको देते हैं, जो हमारे बुरे वक्त में हमारी जिंदगी बचाते हैं, हमको जो बहुत जब अंधेरा चारों तरफ होता है तो रोशनी दिखाते हैं, उस अंधेरे से हमको बाहर लाते हैं, उसका कोई हिसाब नहीं है, उस कृतज्ञता का कोई मोल नहीं है। तो वो मैं सबकी तरफ से, अपने कलीग्स, एक सोसाइटी, समाज की तरफ से आप सबका बहुत आभार व्यक्त करता हूं, धन्यवाद देता हूं। थोड़ी सी मेरी बात है जो इस समय सब लोगों ने अपनी अलग अलग कही, लेकिन उसके पहले एक छोटी सी कथा उसी से जुड़ी हुई है। एक बार ब्रह्मा जी के दरबार में देवता पहुंचे। देवताओं ने उनसे कहा कि ब्रह्मा जी को सिखाइए। तो ब्रह्मा जी ने कहा, तुमको क्या सिखाएं भाई, तुम्हारे पास सब कुछ है, ऐश्वर्य है, इतना धन है, तुमको क्या। तो देवताओं ने कहा, नहीं नहीं कुछ बताइए। तो जब देवता बहुत पीछे पड़े तो ब्रह्मा जी ने कहा तो देवता की समझ में नहीं आया, देवताओं की। उसके बाद लेकिन फिर ब्रह्मा जी से कुछ पूछने का मतलब नहीं, तो ब्रह्मा जी ने भी फाइल खींची, एक कुछ अपना काम करने लगे। ये इशारा था कि अब बाहर चलो। तो देवता लोग बाहर आ गए, लेकिन बाहर जाके उन्होंने आपस में बात की कि इस दा का क्या अर्थ है। उनमें से एक बुजुर्ग ने कहा कि हमें लगता है दा का अर्थ चल के पूछना चाहिए, मुझे ऐसा लगता है कि दा का जो अर्थ है वो दमन है। तो ब्रह्मा के पास गए, ब्रह्मा से पूछा। ब्रह्मा ने कहा, हाँ, आपके पास में धन है, ऐश्वर्य है, इतना भोग है, आप सब उसी में रहते हो, इंद्रियों का दमन करना सीखो। ये अच्छी बात नहीं है कि तुम, कोई भी व्यक्ति तपस्या करता है तुम परेशान हो जाते हो, ये अच्छा नहीं है, दमन करो इंद्रियों का। देवताओं ने कहा ठीक है, आ गए। अब देवता गए थे तो मनुष्यों को लगा कि हम भी चलें। मनुष्य उनके पास पहुंचे। मनुष्यों ने कहा, ब्रह्मा ने उनसे भी कहा दा। मनुष्य भी बाहर आ गए, तो उनको भी समझ में नहीं आया। लेकिन एक बुजुर्ग बार थे, और बुजुर्गों को इसीलिए उनका बहुत ध्यान रखना चाहिए। उन्होंने कहा कि हमको लगता है कि दा का अर्थ हमारे लिए यहाँ पर दान है। तो वो ब्रह्मा जी के पास गए। फिर से ब्रह्मा ने कहा कि हाँ, दान है। पूछा क्यों? कहा कि तुम सब चिंता में रहते हो कि आज हमारे पास ये है, हमारा प्रोविडेंट फंड इतना होना चाहिए, ग्रेजुटी जोड़ा करते हो, उसके आगे का भी जोड़ लेते हो, 2 मकान लेते हो, फिर एक और लेते हो, फिर सोचते हो दिल्ली में, गुड़गांव में एक मकान फ्लैट ले लें, फिर वहां सोचते हो, फिर तुमको लगता है कि एक लड़की को फ्लैट दे दें, लड़के को फ्लैट दे दें, फिर उनके बच्चे आएंगे। मत करो भाई, इतना संग्रह मत करो। बुढ़ापे में खाना तुमको भी शुगर के बाद वही है, एक रोटी खानी है जौ की, क्यों चक्कर में पड़े हो इतना। तो उनका दान करो, विद्या का दान करो, यश का दान करो, ज्ञान का दान करो, जाओ। तो मनुष्य चले आए। अब देवता हो गए, मनुष्य हो गए, तो राक्षसों को चैन कैसे आता। तो राक्षस पहुंचे। राक्षसों ने ब्रह्मा से कहा कि प्रजापति कुछ हमको बताइए। ब्रह्मा जी ने कहा द। अब राक्षस तो बहुत परेशान हो, वहीं पलट गए। उन्होंने कहा पहले यहीं बताइए। ब्रह्मा जी ने कहा नहीं, यहाँ नहीं, बाहर जाओ। तो बाहर पहुंचे। फिर उनमें से जब ये हुआ कि नहीं समझ में आया, तो एक, ब्रह्मा जी ने कहा नहीं सब मत आना, एक आओ, यहाँ आके झगड़ा करते हो, तो राक्षस हो। तो वो पहुंचा। तो उन्होंने कहा कि हमारे लिए क्या है। बोले तुम्हारे लिए दा का अर्थ है दया। तुम किसी को तपस्या नहीं करने देते हो, लोग उसमें विघ्न पैदा करते हो, तो तुम दया करना सीखो प्राणी मात्र पर, इसके बिना काम नहीं चलता। यहाँ कर रहे हो, ऊपर की भी कुछ चिंता करो। तो वो राक्षस चले गए। ये तो उपनिषद की कथा है, बृहदारण्यक उपनिषद है, उसकी कथा है। इसमें एक छोटी सी एक बात और है। जब ये सब हो गया तो एक दिन डॉक्टर्स पहुंचे उनके पास, और डॉक्टर्स ने कहा कि ब्रह्मा जी कुछ हमको बताइए। तो ब्रह्मा जी ने कहा दा। तो डॉक्टरों ने कहा दा का क्या अर्थ है। वो आ गए बाहर। अब डॉक्टर धीमन साहब जैसे किसी सीनियर डायरेक्टर के पास पहुंचे, उनसे कहा कि भाई बताइए दा का क्या अर्थ है। तो धीमन साहब ने कहा नहीं, हम समझ तो गए हैं, लेकिन चलो। तो ले गए। तो लोगों ने कहा आप क्या समझे। धीमन साहब ने कहा रुको, मैं एक स्लिप में रख के रख रहा हूं, अभी तुमको दिखाता हूं, पहले चलो। तो डॉक्टर गए ब्रह्मा जी के पास, उनसे पूछा। ब्रह्मा जी ने कहा दा है। तो कहा नहीं, दा का क्या अर्थ है। तो ब्रह्मा जी ने कहा डॉक्टर साहब से कि आप ही बता दीजिए। तो फिर ब्रह्मा जी ने कहा कि दा का अर्थ है दायरा, अपना दायरा बढ़ाओ। मैं आपसे यही एक बात कहना चाहता हूं। ब्रह्मा ने कहा कि तुमको मेरा दर्जा मिला हुआ है, तुम बहुत विद्वान हो, जब से पढ़ना शुरू करते हो, MBBS क्वालिफाई करते हो, नीट में अब आने लगे हो, और उसके बाद से सारी जिंदगी पढ़ते हो, मोटी मोटी किताबें पढ़ते हो, बहुत काम करते हो, सरस्वती के उपासक हो, लेकिन एक सीमा में रहते हो, अपना दायरा बढ़ाओ। दायरे का अर्थ मैं आपसे ये कहना चाहता हूं, अभी मैं 2 दिन पहले इलेक्शन चल रहा है तो मैं अमेठी गया था। अमेठी में 20 CHC और PSC मिला करके 33 हैं, 20 PSCs हैं और 13 CHC हैं। डॉक्टर्स नहीं हैं, क्योंकि ये कहां से आएंगे? किसी को यहाँ किडनी की बात चल रही है, लोग नहीं जानते हैं। हम लोग एक मेडिकल कंफ्यूजन के दौर में भी रह रहे हैं। मैंने वॉक करता हूं, मैंने एक दिन गलती से गूगल पे टाइप कर दिया और उसके बाद से मैं कुछ भी काम करता हूं और नीचे से पॉपअप आता है कि हाउ मेनी स्टेप्स शुड यू वॉक इन अ डे। अब कोई बताता है 8,000, कोई कहता है 10,000, कोई कहता है 6,000 चल लो, कोई कहता है 3 लीटर पानी पियो, कोई कहता है 5 लीटर पानी एक दिन में पियो। ये जो कंफ्यूजन लोगों के अंदर है, ये कैसे दूर होगा और कौन दूर करेगा? कोविड की जो वैक्सीन है, जो आप देख रहे हैं, उसको लेकर के हमने अभी 2 दिन पहले अपने मेडिकल रिपोर्टर्स की एक कॉन्फ्रेंस की है, जिसमें दिल्ली के और पूरे हमारे देश भर के, हम अगर लोकसभा कॉन्स्टिट्यूंसीज की बात करें तो दैनिक जागरण और मध्य प्रदेश में नई दुनिया और मुंबई में मिड डे और उर्दू में इनकलाब हमारे इतने निकलते हैं कि हम सीधे सीधे अगर कहें बहुत सामान्य भाषा में तो हम अपनी सरकार बना सकते हैं, इतनी कॉन्स्टिट्यूंसीज कवर करते हैं। उन सब के चीफ रिपोर्टर्स और हेल्थ रिपोर्टर्स थे, और हमने केवल एक बात तय करी कि हमको डराना नहीं है किसी को, हमें किसी को ये नहीं बताना है, हमें केवल लोगों को हिम्मत देनी है। पर हमारे कहने से हिम्मत कौन लेगा? मैं सर आपसे कहना चाहता हूं कि हमारा इस्तेमाल करना सीखिए। हमसे ये मत सोचिए कि एक खबर हमारे यहाँ ऐसी हो गई है ऑपरेशन की या उसके, अरे ठीक है, वो समाज है, जो ऊपर नीचे। आप जो काम कर रहे हैं उसको बाहर तक आना है, आप जो काम कर रहे हैं उसकी रोशनी बाहर तक जानी है, वो हम ले जाएंगे। पर कैसे ले जाएंगे? लोगों को ये तक नहीं मालूम है, बहुत सारे लोगों को बाहर, कि शायद पानी न पीने से, डिहाइड्रेशन से भी किडनी की समस्या होती है। लोगों को ये नहीं मालूम है। आप मेडिकल कंफ्यूजन में कह रहा हूं, किसी दिन कहा जाता है कि प्री डायबिटिक का ये स्केल है, किसी दिन कहा जाता है डायबिटिक का ये है, इतने का ब्लड प्रेशर है, उतने। ये कौन बताएगा लोगों को कि जो हाइपरटेंशन है वो डायबिटीज, इसका किडनी रोगों का, रीनल रोगों का सीधा एक कारण है? मैं लेमैन की तरह कह रहा हूं, लेकिन साल में एक बार तो कम से कम भाई अपनी जांच करा लो हाइपरटेंशन की। लोग डॉक्टरों के पास जाते हैं, आपके पास डॉक्टर कहता है कि अरे आप ये किस में चले आए हो, आपका नीचे वाला 115 है, ऊपर वाला 180 है। कहा नहीं हमको तो इतना ही रहता है। जांच कब कराई थी? बोले एक बार कर दी थी, घर में इंस्ट्रूमेंट आया था, वहां देख लिया था। तो ये कौन बताएगा? ये जो कैडेबट, अभी जो इतनी सारी बातें हो रही थी, हमारे पिताजी जो बाद में उनका देहांत हुआ, उन्होंने अपनी आंखें दान की और उन्होंने कहा कि हमको इसमें कराना, इलेक्ट्रिक जो क्रेमेटोरियम है। मेरे मामा जी, उन्होंने अपनी पूरी बॉडी मेडिकल कॉलेज को दी, देहदान किया, मैं ही दे करके आया। कितने लोग लेकिन ऐसा करते हैं, और कितने लोगों को ये जानकारी होगी? आपके पास में जो ट्रेंड, हम जो आप अगर, मैं आपको क्या बताऊं, आपको मालूम है कि ट्रांसप्लांट का कितना बड़ा बैकलॉग है और क्या उनकी ट्रेनिंग है। हम आपके काम केवल इसमें नहीं आ सकते हैं कि हम आपके लिए अवेयरनेस फैलाएं, हम इसमें भी आ सकते हैं कि अगर आप हमसे एक दिन फोन करें और आप कहें कि हेल्थ मिनिस्टर से हमारा अपॉइंटमेंट कराओ, हमको यहाँ बात कर, मैं आपके साथ चलूंगा, थोड़ी वो हमारी सुनेंगे, हम आपके साथ बैठेंगे। हमको आप अपना वॉलेंटियर बनाइए, हमको उस वॉलेंटियर की तरह यूज करिए। हम समाज में हैं, हमारा पहला काम, हमारी पहली वफादारी, हमारी पहली जवाबदेही उस आदमी के प्रति है जो हमारा अखबार खरीद रहा है, या जो आदमी इस देश का नागरिक है। और हम एक लोकतांत्रिक राज्य में रहते हैं, वेलफेयर स्टेट में रहते हैं, जिसमें हम सबकी जिम्मेदारी है। लेकिन ये तब हो पाएगा जब आप हमारा इस्तेमाल कर पाएंगे। आप तो बहुत अपना काम करते हैं, आप तो सब कुछ कर रहे हैं, मैं क्या कहूंगा आपसे, लेकिन वो जो बात है जो बाहर तक जाए। पर आप देखिए ना, इतना बड़ा गैप है। आप एक इसी शहर में किसी जमाने में जो नेता थे, अगर आप किसी अस्पताल की लोकप्रियता को जांचना हो या उसकी जो एफिशिएंसी है उसको परखना हो, तो सबसे पहले बलरामपुर में जाके जमा हो जाते थे। बलरामपुर में एक प्राइवेट वार्ड था, एक नियो प्राइवेट वार्ड था, तो बलरामपुर माना जाता था कि यहाँ सबसे अच्छा अस्पताल है। और था भी। एक समय डॉक्टर एस सी राय साहब ने क्या कमाल का काम किया था वहां। और फिर वो बहुत दिनों तक उनकी लेगेसी बनी रही, क्योंकि डॉक्टर भटनागर साहब ने उसको लिया और चलाया। बाद में जो मेयर साहब हुए थे, मेयर हुए राय साहब। अब आपके यहाँ लोग आते हैं, लेकिन क्या सिविल हॉस्पिटल हमारा पीजीआई से मैच कर सकता है? नहीं। कितने लोग हैं जिनको आपकी जरूरत है, कितने लोग हैं जिनको आपकी, आप मतलब आपकी भी और डॉक्टर्स की भी। तो हम अपने यहाँ, जैसे आप में से कई लोगों को हम सादर आमंत्रित करते हैं, आप आते हैं, हम एक हेलो डॉक्टर एक चलाते हैं, अपने यहाँ लोग टेलीफोन पर बात करते हैं। सर आप बैठे हैं, आपको ये नहीं मालूम है कि आप पीजीआई में बैठे हैं और आपकी वक्त क्या है, लोग आपको कैसे देखते हैं। मैं जानता हूं, मैं अपने फादर की बीमारी में यहाँ रहा हूं कई कई दिन, या हमको आना पड़ता है। मैंने आपकी मेहनत देखी है कि आप सवेरे से लेकर शाम तक कितनी मेहनत करते हैं। बिल्कुल करिए, लेकिन एक महीने में एक दिन ऐसा निकालिए जब जहां पर आप कोई बात करिए जिसमें आप लोगों को हम उसको ऑर्गेनाइज करेंगे, लेकिन आपकी बात लोग सुनेंगे, मेरी बात कोई क्यों मानेगा। हम आपके लिए एक प्लेटफॉर्म उपलब्ध करा सकते हैं, हम आपके लिए एक प्लेटफॉर्म बन सकते हैं, लेकिन आप अपनी बात जब लोगों तक कहेंगे जाकर, हम आपके लिए गवर्नमेंट के साथ, मैंने अभी आपसे कहा, एक ब्रिज बन सकते हैं। तो प्लीज हमारा इस्तेमाल करिए। एक बात आखिरी है जो मेरे और आप दोनों के ऊपर लागू होती है। राजा भरत के पास एक बार एक ही अपराध के लिए चारों वर्णों के लोग पहुंचे, और राजा भरत ने उस अपराध में चारों वर्णों में सर्वाधिक दंड ब्राह्मण को दिया। ब्राह्मण ने पूछा कि हमको क्यों दिया? उन्होंने कहा इसलिए किया कि बाकी को नहीं पता था, तुमको ज्ञान था। तो जिसको अपराध की प्रकृति पता है, जिसको अपराध के परिणाम पता है, उसको दंड भी अधिक होता है। तो यहां दंड की बात नहीं है, हमारी जिम्मेदारी की बात है, आपकी भी हमारी भी। हम दोनों मिलकर करेंगे तो समाज का ज्यादा भला करेंगे। आपने एक बहुत बढ़िया कार्यक्रम किया, मुझे यहाँ बुलाया, मैं इसके लिए आपका धन्यवाद देता हूँ, आभार व्यक्त करता हूँ, और फिर से आप सबको नमस्कार करता हूँ। समाज की ओर से आपका आभार व्यक्त करता हूँ। बहुत बहुत धन्यवाद। थैंक यू सर।
May now invite Professor Dr. R.K. Sharma sir to share his thoughts on this occasion.
Good evening, ladies and gentlemen. It's my pleasure to welcome all the alumni to this institution. And I think the tradition goes on. And I would like to also thank the various dignitaries on the dais, Sri Ashutosh Shuklaji, Professor Dhiman, Professor Shalin Kumar, Dr. Narayan Prasad for giving me this opportunity to be here, Dr. Amit Gupta, Dr. Anupama Kaul, and Dr. Ravi Kushwaha. What reminds me when I come to this Foundation Day is the tradition of mentorship, which has to develop and grow. And what do we understand from the mentorship? एक को एक महाभारत के मेंटर की याद आती है। द्रोणाचार्य का नाम हम सबको मालूम है, द्रोणाचार्य के नाम से अवार्ड्स भी हैं। The way he mentored both Pandavas and Kaurav, और उस मेंटरशिप को किस तरह से महाभारत में उसका उपयोग या दुरुपयोग हुआ, और the person who wanted to be mentored by him, एकलव्य, जिसने अपने अंगूठे को काट के उनको गुरु दक्षिणा दी, because he was not accepted by Dronacharya as a disciple. But Dronacharya was a great mentor. We still remember him. And we know that his most favored student, Arjun, who fought in the battle of Mahabharat and the way Mahabharat came to an end. The other name I would like to mention is about Hazrat Ali. Some of you may remember Hazrat Ali has a famous quote. He was one of the wisest person in the line of Prophet Muhammad. And about mentorship, he mentioned that anybody who teaches me even a single word is my mentor. And that single word gives permission to that individual to start the mentorship. And we know that in the Guru Sishya tradition, you just have to sit with the mentor or with the Guru, and that energy will transmit. So I think this tradition has to go on, and you must know, some of you must be knowing that Hazrat Ali was one of the very ferocious fighter, but his saying and his quotes are some of the wisest quotes. And one of the very famous poem written by Amir Khusro, you might have heard, is in praising Hazrat Ali, his greatness, his wisdom, and his mentorship. So I think on this occasion of the Foundation Day, I would think that this tradition must go on. The mentor is not only your teacher, even you teach us so much, because I have mentioned that anybody who teaches me a single word, maybe my friend, my student, my family member, is my mentor. So the mentorship concept is very broad. What we learn as medical training over a period of 30, 40 years is phenomenal. And some of these things we learn not by the traditional mentorship, by a mentorship which goes on and on over the years. So I think let this tradition continue, and the mentorship, as we go out from an institution, we should also try mentoring whosoever comes in our contact. So once again, I welcome you all, and thanks that we are STPGI under Dr. Narayan Prasad has really progressed, as he was mentioning, the growth of the department, and also Professor Devan has done a great job by taking the tradition of this institution forward. He was one of the very bright DM student in gastroenterology, and we are very, I think, lucky to have him as a director. So once again, thank you very much for giving me this opportunity to be here. Thank you.
May I now invite Professor Dr. Amit Gupta, sir, to share his thoughts.
Good evening to all the esteemed dignitaries of the dais and my dear friends of the dais. And indeed a great pleasure to come back here and to have our director, Professor Dhiman, who was the first DM student of this institute in gastroenterology, and to listen to Harbir, who was our first DM student in nephrology. So that brings back a lot of old memories and such a pleasant occasion. It's also great to meet all of you, all our alumni who have excelled in their own ways all across the country and have made a name for this institution. I'm also greatly It was a great pleasure to meet all my old colleagues working in the dialysis unit, our technicians, our nurses, the nurses working in the wards, as well as our nephrology department office people. I mean, it's this meeting really brings back all the fond memories of working here for so many years. Just to remind some of you and to tell you the history of the department, we started in 1987. In May 1987, Dr. Kher joined. I joined in August 1987, and Professor Sharma joined in December 1987. The OPD service at that time in 87, this hospital was being built. So our only job was to go and see how much the building had been completed. The OPD started first in the general OPD, general hospital. That's where the OPD first started. And that started in the month of January or February, I remember, 1988. And there were hardly any patients. And then we moved into this main building, and the wards, all the departments used to share the common ward, which had now become the neurosurgery ward. So that was the ward that everybody's patients were kept. Our dialysis unit started functioning in June of 1988. And we had received this grant from Japan when we had 14 Toray machines, and we had these chairs which actually no patient would like to use. And so they were used, Kohli was showing that photograph when he was sitting on the chair. The furniture actually had come from Japan, and he was enjoying because the patients were not interested in lying on a couch at that time. And the first transplant was done in July 1989. And the department since then has grown tremendously, and I'm really proud that Narayan and his entire team have worked so hard, along with ably supported by the paramedical staff, by the office people, by the nurses and the technicians, that we have built up this great department, and which is doing so well. And I wish all of you a grand success in the years to come. And I'm sure this department will become one of the finest departments. It is already one of the finest departments, but even rise to greater heights in the years to come. Thank you very much, Narayan, for having me here.
It is now time for the award ceremony, and may I now invite our respected dignitaries on the stage to come forward for giving the awards. Sirs. For the Mentor of Mentor Awards, it is a great pleasure to give the award to Professor Dr. R.K. Sharma, sir.
नियत साफ हो जिनकी उनके कदमों में जमी होती है, नेक इरादों से काम करने वालों को कब सितारों की कमी होती है.
For the Mentor of Mentor Awards, we now give the award to Professor Amit Gupta, sir. We now give the award to Professor Amit Gupta, sir, one of the founding pillars of the department, meticulous clinician par excellence, and the forerunner of the peritoneal dialysis program in India and Asia as well. Sir is currently heading the nephrology services at Apollo Medics, Lucknow. For the third DM Batch Eminent Alumnus Award, we invite Professor Dr. Sanjeev Gulati, sir. For the Eminent Alumnus Award, one of the leading nephrologists in the country, currently Principal Director of Nephrology Services in Fortis Hospital, New Delhi, an accomplished researcher, astute nephrologist with a magical pediatric touch, and immediate past President of the Indian Society of Nephrology. Eminent Alumnus Award. As Dr. Pradeep Kumar sir from Meerut, who could not be here with us, we give the next Eminent Alumnus Award to Dr. Pradeep Kumar Rai sir, one of the foremost and leading consultant nephrologists in Uttar Pradesh with a roaring clinical practice in the holy land of Varanasi. He has completed 3 decades of distinguished service in nephrology. May we give him a big round of applause.
सारा जग जान गया है आप हो कितने काबिल, हर कठिनाई पार की तब लक्ष्य किया है हासिल।
Yes. For the Best Senior Residence Award, the next award is for the well-performing residents. The award for the Best Academic Resident of 2022 goes to Dr. Rachana Shenoy, whose academic credentials are deeply ingrained in her DNA. With her all-round abilities and focused academic approach, she has truly excelled. Sharing the honor with her is Dr. Shivam Roy, currently serving as Assistant Professor at AIIMS Raebareli, an avid quizzer with a voracious appetite for nephrology knowledge. And for the Best Performer Award, no prizes for guessing, the award goes to Mohammed Umair, a dedicated and hardworking resident, currently Assistant Professor in Jhansi Medical College, serving the underserved population of the Bundelkhand region. Now we will award the fellowship awards. Dr. Hemant Kumar has successfully completed the Interventional Nephrology Fellowship 2023-24. Department appreciates Dr. Hemant's dedication and passion to learn the art of giving rebirth to dialysis patients' lifeline, the AV axis. We wish him well for his success. I next call upon Dr. Naeem Min Han from Myanmar, Department's first International Society of Nephrology Fellow. He completes his one-year tenure on May 15th under the guidance of his mentor, Professor Narayan Prasad Sir. Sponsored by the International Society, he has completed his tenure with passion and excellence.
I will request Professor Vivekanand Jha to come on the desk and to be part of felicitating. This is the first fellow, International Society fellow here who has completed successfully 1 year of the fellowship, totally sponsored by International Society of Nephrology, and there was a good contribution of Professor Jha.
Memorable moment for Dr. Naeem Min Han. We wish him a wonderful nephrology career as he goes back to his motherland to serve his people with fresh insights. We will now give the Foundation Day Awards.
अब मैं मंच पर बुलाना चाहूंगी श्रीमान दीपक लोखंडे जी को कि वो मंच पर आए और पुरस्कार ग्रहण करें। अगली श्रृंखला में नाइटिंगेल अवार्ड के लिए मैं मंच पर बुलाना चाहूंगी श्रीमान अनिल कुमार मौर्य जी को, श्रीमती मुन्नी सिंह जी, श्रीमती गीता चंद जी, श्रीमती कुसुम नाथन जी, श्रीमती रोजलीना इमैनुअल जी, सफलता एक चुनौती है, इसे स्वीकार करो, क्या कमी रह गई और सुधार करो, कुछ किए बिना ही जय जयकार नहीं होती, कोशिश करने वालों की कभी हार नहीं होती। आया है ये अवसर जिसमें तुम्हारी मेहनत है रंग लाई, यूं ही मिलती रहे सफलता और हम देते रहे बधाई। अब मैं बुलाना चाहूंगी डिलीजेंट अवार्ड के लिए श्रीमान जितेंद्र कुशवाहा जी को, श्रीमान मनोहर जी, श्रीमती लीला जी, श्रीमान वकील जी, वे मंच पर आएं और पुरस्कार ग्रहण करें। हम इस विभाग के विकास और सुचारू कामकाज में आपके महत्वपूर्ण योगदान के लिए आप सभी को धन्यवाद करते हैं।
We would like to call upon Dr. Anjani Kumar Mishra. We would like to honor him. He has always been part of our functions, and we would like to honor him with a murti. In all of our functions, he gives the soulful renditions of his music. Thank you, Dr. Anjani Kumar Mishra and team. Thank you. Thank you, dignitaries. Now, I would like to call for the vote of thanks. Recognized for his calm demeanor and effective execution, I now invite our organizing secretary, Dr. Ravi Kushwaha, for the vote of thanks.
Good evening to all. The root of all goodness lies in soil of appreciation. Thus today, I stand before you all to thank a lot of people, a time for togetherness and gratitude. It gives me immense pleasure to deliver the vote of thanks. I want to thank chief guest of the today's function, Sri Ashutosh Shukla ji, Rajya Sampadak Dainik Jagran, Uttar Pradesh, who has given time from his visit schedule. Thank you, sir. I want to thank patron and guest of honor, our director, sir, Padam Shri Professor R.K. Dhiman, sir, who has been instrumental in initiating the Foundation Day celebration. Thank you, sir, for guiding us and encouraging us to do better year by year. I want to thank our Dean, Professor Salin Kumar, sir, who have accepted our invitation and for being here with us today. Thank you, sir. Our distinguished teachers, Professor R.K. Sharma, sir, and Professor Amit Gupta, sir. Words fall short to thank them. Their positivity and encouragement brightened so many lives. They are true epitomes of great teachers and mentor of mentors. We all bow in respect to both of you, sir. With hand folded to all the stalwarts of nephrology and our dear delegates who have been present here to attend this function today. I want to thank all the technicians, nursing staff, helping staffs, office staff who made what the department is today. It is a team effort by one and all. Thank you is a very small words to acknowledge your contribution. Our faculty and our students are the strength of nephrology department. On this occasion, I want to thank each one of you, Professor Anupama ma'am, Professor Dharmendra Bhadoria sir, Dr. Manas Patel, Dr. Monica Yacha, Dr. Manas Vera, Dr. Jay Kumar, Dr. Harshita, Dr. Vamsidhar, Dr. Bashavraj, Dr. Abdullah, and all the senior residents without whose support we would have not seen this successful event today. The vision is the art of seeing the invisible. Our head of department, Professor Narayan Prasad sir, under whose mentorship we all aspire to do better. A big thank you, sir. I also thank all the media persons who have been here to cover this event. In the end, I also want to thank all the industry persons who have supported me for this successful event. Please forgive me if I have forgotten to name anyone, and very big thank to all of you. Thank you. All dignitaries, we seated here, We will present here the departmental song shortly, followed by the national anthem.
थैंक यू सर। हमारे विभाग के सदस्य अपने विभाग, संस्थान और चिकित्सक संसर्ग की कर्मठता, संपन्न और अपने कार्य को धर्म बना लेने के जज्बे को व्यक्त करने हेतु आपके समक्ष एक गीत प्रस्तुति ला रहे हैं।
This song has been written by Professor Dr. Anupama Kaul and composed by Dr. Anjani Kumar Mishra.
पेपर तो है। आप सभी लोग हमारे साथ गाएंगे, सेवा धर्म है हमारा, सेवा धर्म है हमारा। जो ये लाइन है सभी लोग साथ में रिपीट करते रहेंगे। मन की भाषा कर्म से निकले यह उद्देश्य हमारा, मन की भाषा कर्म से निकले यह उद्देश्य हमारा। सेवा भाव जीवन में उभरे यही है धर्म हमारा, सेवा भाव जीवन में उभरे यही है धर्म हमारा। सेवा भाव हमें प्यारा नहीं कहीं है अंधियारा, सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा। सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा। मानव सेवा पुण्य बड़ा, बचपन से यह ज्ञान मिला। डॉक्टर रूपी शूरवीर ही हर विपदा में खरा उतरा। मानव सेवा पुण्य बड़ा, बचपन से यह ज्ञान मिला। डॉक्टर रूपी शूरवीर ही हर विपदा में खरा उतरा। सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा, सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा। सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा। गुरुदे के फल होते ही दुख और गम मानो गहरा। श्वेतांबर धारण कर कोई संकट मोचन वहाँ। गुरुदे के फल होते ही दुख और गम मानो गहरा। श्वेतांबर धारण कर कोई संकट मोचन वहाँ खड़ा। सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा, सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा। सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा। जन जन की किडनी की रक्षा हम सबका कर्तव्य सच्चा। दिल के भाव से करते सेवा बदले में मिले दुआओं का मेवा। जन जन की किडनी की रक्षा हम सबका कर्तव्य है सच्चा। दिल के भाव से करते सेवा बदले में मिले दुआओं का मेवा। सेवा भाव हमें प्यारा नहीं कहीं भी अंधियारा, कहीं भी अंधियारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा। परम सत्य ही प्रत्यक्ष बड़ा, रोगी बाधाओं से लड़ा, निष्काम कर्तव्य भाव से उनकी दुख दर्दों को हरा। परम सत्य ही प्रत्यक्ष बड़ा, रोगी बाधाओं से लड़ा, निष्काम कर्तव्य भाव से उनके दुख दर्दों को हरा। सेवा भाव हमें प्यारा, नहीं कहीं भी अंधियारा, सेवा भाव हमें प्यारा, नहीं कहीं भी अंधियारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा, सेवा धर्म हमारा। किडनी सेवाएं यहाँ से बेहतर और नहीं कहीं होगी, हर जन मानुष की खातिर आंखें नम अब ना होंगी। किडनी सेवाएं यहाँ से बेहतर और नहीं कहीं होगी, हर जन मानुष की खातिर आंखें नम अब ना होगी। सेवा भाव हमें प्यारा, नहीं कहीं भी अंधियारा, सेवा भाव हमें प्यारा, नहीं कहीं भी अंधियारा, सेवा धर्म हमारा, सेवा धर्म हमारा। सब लोग आएंगे। सेवा धर्म हमारा, 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 सेवा धर्म हमारा। सभी लोग अपने स्थान पे खड़े हो जाएंगे। जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा, विंध्य हिमाचल यमुना गंगा, उच्छल जलधि तरंगा, तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाहे तब जय गाथा, जनगण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 जय। भारत माता की, भारत माता की, भारत माता की।
On behalf of the organizing team, we invite you all to join for the high tea, followed by the cultural event by the Cultural Ambassador of the Year 2024, Ms. Maithili Thakur, in the adjoining Shruti Auditorium, which will be followed by dinner.
अपनी वाणी को विराम देते हुए मैं अपने व विभागीय परिवार की तरफ से तहे दिल से आप सभी उपस्थित मान्य जनों का इस कार्यक्रम की शोभा बढ़ाने व अपना अमूल्य समय देने पर धन्यवाद करती हूँ। आशा है समय समय पर हम सभी ऐसे ही याद